So there's nothing but an FNAC, a fine needle aspiration cytology, right? So it's not biopsy slide making part, it's an FNAC slide making, right? So what does FNAC means is, generally you have a needle and you can poke in a lymph node or in a lipoma or in a swelling and you go with that, right? That's what we do in FNAC. Here, what you can see here is, I'm going to mark a few things. You can see that there's a structure here, a silver color thing, that's called an FNAC handle. That might alone come in an image-based question. If you're an MBBS, you might have in a Viva a specimen asking what this is, an FNAC handle. So what we do in the FNAC handle is, you take the syringe will have a piston, you will attach the piston into the FNAC handle, and then you'll have the syringe, along with that you'll have the needle. You pull the handle to maintain the negative pressure, because for a lesion like a bone tumor, I might be required to use 10-20 ml syringe. To have a negative pressure consistently is very difficult. That's why we have the FNAC handle. One second. If you look at this FNAC handle, you can see that the person is holding it, pulling it, and then pressing it outside, right? So what actually happens is, once you insert the needle and you give negative pressure, in the hub of the needle, that's called the hub of the needle. In the hub of the needle, you will have the material there. Material is nothing but the cells, right? Whatever cells we have, if it's a lipoma, it's a lipoma, whatever is there, we'll have that, right? So then they press it on a slide and then they make a slide, right? A follow-up question, can anyone tell me what are the stains done on an FNAC? I have done an FNAC, what are the stains generally we do? I'll ask a few of the follow-up questions which has come on an FNAC before, and then I'll also share you an important MCQ. I want you to answer that as well. Stains, most of the FNAC have two different stains. We have something called a PAP stain, Papanocolo stain, and we have MGG or a May-Grunwald-Giemsa stain, right? PAP smear, the fixative is alcohol. Once the smear is made, I put them into an alcohol, a 95% alcohol or an ethanol or an absolute alcohol or an isopropyl alcohol. Great, Saurima. MGG, May-Grunwald-Giemsa, these are air-dyed smear. So there is no fixative here. So what we do is, I make a smear, dry it, and then start staining with May-Grunwald-Giemsa or MGG, or simple Giemsa stain should be enough. Fine. Okay. So you must have heard this question, me talking about it previously. This has come multiple times in exam as well. Tell me one disease which FNAC cannot diagnose in a thyroid. Can anyone tell me one disease which FNAC can't diagnose in a thyroid? I'm sure you know the disease. Can anyone tell that? Classical. That's a classical case of a follicular thyroid carcinoma. Follicular thyroid carcinoma or a follicular carcinoma of thyroid cannot be diagnosed on an FNAC because, for the simple reason, you need a capsular invasion or a vascular invasion in order to diagnose a follicular carcinoma of thyroid, which cannot be seen on an FNAC. In an FNAC, I'll see only cells. I won't be able to see capsule at all. That's why I cannot diagnose them on an FNAC, right? Perfect, great, amazing. I'll ask you one more leading question. Let's see how many of you can answer it, right? So can anyone name the classification system on FNAC for a thyroid lesion? This also has been asked before. What is the FNAC reporting system for thyroid? I'm sure you know that. This is the same reporting system followed for pap smear also. I just want the name. I don't want you to tell me the criteria or the categories, just the name. The name is perfect. For both FNAC as well as for pap smear, we have the same system, the name of the system, which is Bethesda classification, right? Bethesda is a classification which is used for thyroid FNAC and also your pap smear reporting. Name is same. Obviously, the criteria and the diseases under which it comes are definitely different, right? Perfect. So I had a video. I'm going to have a follow-up question. Read the question carefully and then tell me what's the right answer. It's not in a hurry. It's a new question for most of you. It's not a PYQ. I just created a question with respect to the video. So what video-based question happened in FMG is, they put a video and they asked a question related to that. I'll keep quiet for 30 seconds. Read the question, read all the 4 options and tell me what's the right answer. I want you guys to comment. Again, if you're wrong, you know me, it doesn't matter. It's the attempt which counts. I'll read through the question. The video demonstrates an FNAC procedure. Which of the following is the most immediate step after obtaining the aspirated material? You had an aspirate, you got it, that was also actually in the video, right? Do I place the entire specimen in formalin? No. FNAC has only 2 fixatives, either alcohol or air dried. I don't maintain that in formalin at all. I have to, like you guys said, I have to expel the material onto a glass slide, prepare the appropriate smears, centrifuge the material immediately, right? I'll put a question mark here because for not all FNAC we centrifuge them. We don't centrifuge them at all because in thyroid I get like 0.2 ml. Where to centrifuge? Make a smear, that's all. Transfer the sample to an EDTA tube. I don't do that as well, right? This could be a very important step if the sample is different. Let's say you must have heard about thyroglossal cyst. You must have heard about it, obviously. Cystic lesions in the body, yes. So let's say I have a cystic lesion in the body. I put a needle, I aspirate it. What will come? Will the entire cyst fluid come? Yes. It will come automatically, right? So if I have a cystic fluid like 5 ml, 10 ml of aspiration, I cannot make a smear in a 5 10 ml. In that case, you have to immediately centrifuge and not put them onto a glass smear, right? So this happens in case of cystic fluid. So if you in a cyst, FNEC is actually both therapeutic as well as diagnostic, right? So that's a cyst treatment. I have to aspirate the entire thing. Or you put a needle, you have entire pus coming outside. That all time also I might be required to centrifuge, right? Any cystic fluid more than 5 10 ml, you centrifuge and take the sediment and look them into the microscopy. Clear? Done? If it's clear, can we go to the next video? I'm going to play the next video. You might have seen this video. See the video carefully. Tell me if you have seen this and tell me what it is. And then obviously we'll go to the question. That's all as the video, right? I'll go back and play again once again for you guys. Tell me what is this instrument? Have you seen them before? Yes or no? Let's see how many of you have seen this before. I'll give you a clue. This instrument, you can see them in a blood bank. Blood bank, by the way, it's one of the important topics for you. You have to know them, especially if you're an intern or a post-intern. It's must for you to know them. NEET PG has good number of questions there. Parthsarathy, if the question says that, okay, for a cystic lesion, do you have to centrifuge? Yes, I do have to centrifuge. Okay, you're not seen this? Great, Rajakumar. That's a platelet agitator, right? I'll go back once again. I'll play the video once again. If you see this video, you can see that the plates here, right? There are multiple plates here and all of them are moving like this, right? This is something called a platelet agitator. Here in the end, every plate here, what you'll have is the platelet bags. This is a platelet agitator, right? So that's what it is, the platelet agitator, right? So why should I agitate a platelet, right? So what happens is when you collect samples, right? You collect blood, you separate them into platelet, you separate them into an plasma and everything, right? Everything has a shelf life. I can store a blood for 35 to 42 days based on the medium which I store them in, right? I can store a platelet for 1 to 5 days based on whether I am agitating it or whether I am not agitating it. Why should I agitate them? What is the quality of platelet? If I don't agitate something, will all of them settle? Yes. If everything settles, imagine there are thousands of platelets settling in the bottom. Can they get contact activated? They can. So do you think the platelet will be enough lasting for 5 days or they will disappear or get destroyed immediately? They'll get destroyed immediately, right? Platelets will be suspended in plasma. This agitation makes them not come in contact with each other and it will not get activated so that they can retain for a longer time. And also the plasma has a nutrition which has to percolate into every platelet for them to live, right? That's the reason we have to agitate the platelets. This is one of the most important thing which is done in a blood bank. If you are in your college still, as an intern or an MBBS student, go to the blood bank, just have a visit once, look at all the samples which are there in the blood bank because every one of them can come as a video based or an image based question, right? Now a follow-up question. Read the question, tell me the answer. It's a very simple question. The platelet units shown on agitator in the video are continuously shaken or agitated. What will be the shelf life of the same? NEET PG aspirant, I don't agitate them to avoid bacterial contamination. The only thing for bacterial contamination is it should be taken from an aseptic precaution, that's all. The shelf life of an agitated platelet is? No, platelet cannot live for 22 days. It's either 1 day or it's 5 days, that's all. The shelf life of platelets is either 1 day or 5 day, right? Without agitator, if I don't agitate, right, it can live for a day, that's all. 1 day or 24 hours. If I can agitate with agitator, it can live for 5 days, right? I can store them for 5 days and then I can give to the patient up till 5 days, right? And one more follow-up question. Can anyone tell me what is the temperature in which platelet is stored? With agitator or without agitator, I need a perfect temperature store, right? I need a perfect temperature for my blood, for my fresh frozen plasma, for my cryoprecipitate, everything I need a set temperature, right? What's the temperature for platelets? It's at room temperature, right? Perfect. So unfortunately, room temperature not in India. It should be in the AC rooms. 22 degrees centigrade to 25 degrees centigrade is an ideal temperature for platelet to stay. So every blood bank has to have a mandatory AC, air conditioner with a maintained temperature with 24-hour power backup. It's very, very important. Med school grad, 2 to 8 degrees centigrade is for blood, right? It's for whole blood or your packed RBCs. Don't get confused, right? 2 to 8 degrees centigrade is for your whole blood or PRBC, which is packed RBC. Anything in minus, okay, is for cryoprecipitate and fresh frozen plasma, right? Like minus 20, minus 30. Fresh frozen, it has to freeze, so it should be sub-zero temperature, right? Your FFP and your cryoprecipitate should be in minus. It can be minus 25, minus 30. I don't mind. It has to be frozen so that it can live for a longer time. That's all fine. Okay. We know the lifetime of your platelet agitator and platelets. Whole blood can be used for up to, it varies based on what additive I can give. The max I can use it 42 days. We have an additive called an SAGM. With SAGM, I can use up to 42 days, 35, 28 days. Generally, it's around 35 days, right? Max is 42 days. Can anyone tell me what is the half-life or shelf life, not half-life, shelf life of FFP or cryo, right? Good evening, Siddhi. What's the shelf life for FFP, which is fresh frozen plasma, or a cryoprecipitate? If when it's stored at minus 25, let's assume that it's stored at minus 25 degrees centigrade, what will be the shelf life? The shelf life is very simple. It is 1 year. I can use it for up to 1 year, right? In minus 25 to minus 30 degrees centigrade or anything lower than that, it's completely fine with me, right? And one of the important questions, you have to answer this to me. Let's say, can anyone tell me in which condition I do use FFP or cryoprecipitate? Any one condition where fresh frozen plasma or cryoprecipitate is used? We use it for, yes, med school grad, you are right. We use it for, maybe for hemophilia, DIC, we use them, right? So let's say you are in a lab, you're in a hospital, your PG or your consultant says, okay, give FFP to this patient. You go to the blood bank and you ask them, I need FFP, right? When it's FFP, it's frozen. You cannot inject a frozen thing, right? So whenever you do order for an FFP in the blood bank, they take it and they use a mechanism called thawing. When it's ordered, when it's to be given to the patient, we thaw FFP. Thawing is nothing but making it come to room temperature, that's all. So what do? I have a water bath, 37 degrees centigrade. That also can be video. Just water will be flowing, that's all. Normal body temperature, 37 degrees centigrade, right? So this will be put into a water bath of 37 degrees centigrade. So it's to a normal body temperature and then it becomes a liquid. Fine. FFP will be thawed and FFP becomes a liquid. The moment it becomes a liquid, what is the shelf life or for how long can I use it? I made an FFP. I've ordered for an FFP. The blood bank gave it to you and it's in liquid form. You take to the ward and the consultant or the PG says, no, I don't want it. Patient is settled. Go and give it back. Can I give it back? Not at all. After this, lifespan is maximum 6 hours. At the earliest is the best. I'm going to thaw it, immediately give it to the patient. Max time is 6 hours. After 6 hours, there is no use in freezing it again. You have to throw it away. It's either used or discarded. So when you become a consultant, unless and until it's required, please do not order FFP or a cryo. After 6 hours, it's wasted completely. It's either wasted or it should be given to the patient. That's all, right? Perfect. Great. So we saw a platelet agitator. And like I said, please go to your hospitals, see anything which is in the blood bank can come as a video based question. Can you go to the next video? I'm going to show you the next video. Simple video. tell me what it is. The clues are actually there. The question is very simple. What is the procedure shown here? I'll play it once again. It's a very simple video. Like I said, the clues are actually there. I should have hidden this, but it's fine. We're just learning, right? What is this? What is this procedure? I'll give you a clue. This procedure is commonly done to identify leukemias and lymphomas. Great, that's a simple example of flow cytometry, or FCM is flow cytometry, right? It's simple flow cytometry, right? So you can see that it's flow cytometry. Why did the term flow come? I can do for anything which is in liquid medium, like blood, pleural fluid, peritoneal, ascitic fluid, right? CSF. If it's a tissue, I have to make them in a liquid form and I can do it. I cannot do it in a biopsy. I have to convert them into liquid form, then I can do it, right? So this is the flow. That's a chamber in which the fluid flows, which has various cells, RBC, WBC, platelets, whatever it is, right? And then a light is shined onto it, right? A light comes from here. So it can detect in two ways. We have something called a forward scatter and something we have named as side scatter, right? It's a simple principle of physics, as simple as that, right? So let's say this is your neutrophil. We have read this in the classes, just reading it once again. So when you shine light, the light can get deflected along the corners of the cell, right? That is forward scatter. And I can have light going into the cell, hitting it and reflecting at right angles, right? Because obviously light can penetrate into a cell. I have a granule, hits it, reflects in right angle. I have a nucleus, hits it, reflects in right angle. That we call it a side scatter. And this we call it a forward scatter, right? It's deflecting slightly forward and deflecting like a 90-degree side scatter, right? Now, the question what I'm going to display is also based on this. Can anyone tell me what does forward scatter give information about? I have a flow cytometry of a leukemia with blast. What does forward scatter tell me? What information does forward scatter give me? This was asked previously in one of the AIMS question. Forward scatter tells me the overall size of this cell, right? Simple. I have this big cell. It scatters like this. It gives me the size of this cell, right? Perfect. Done. So side scatter goes inside and reflects, which gives me the internal complexity of the cell, which means whether it's nucleated or anucleated, whether it's granulated or agranulated. That's what it does, right? Med school grad, CD markers are not given by side scatter or forward scatter. CD markers are actually more radiations, right? You can see them. There are antibodies here. Everything will have a blue or a yellow signal or a red signal, right? Based on the color emission, my laser diodes will pick them up and say that, okay, this is positive, this is negative, right? So that's the principle, simplest principle of flow cytometry, right? A follow-up question, tell me what is the right answer. I'll keep quiet for some time. What's the answer? The same thing what we discussed. In flow cytometry procedural, which is demonstrated in the video, forward scatter, please remember, this is a known abbreviation you have to remember, and SSC means side scatter, that also you have to know it, right? Provides information regarding which of the cellular characteristics. The answer is simple. It gives me about the cell size. The cell morphology, cell granularity, both will be given by my side scatter. DNA sequence will not be picked up on flow cytometry unless and until I have antibodies attached to a particular thing. It cannot pick them on flow cytometry, right? You're absolutely right. Everyone spot on. The answer is option B, cell size, right? Great. Let's go to the next question. Let's see if you're able to identify this. This question has a very interesting history also. I'll tell the history later on. The simple experiment. Can anyone tell me what principle is this? Can anyone tell me what principle is this? Later on, I'll put the question. If you're not sure about what principle it is, I'll explain you what principle it is. Fine? I'll play it again. What is this principle? Okay, if you look at this video, I'll explain this video first. You have two columns, right? You have one column A, you have column B. So here what's happening is, I have a cell moving from column A to column B. When a cell moves from column A to column B, will it displace from fluid? It will. when I have two charges, this displacement of fluid will create a spike. Look at this again. I'm going back. This displacement of fluid will create a cell is moving there. You can see there's a spike or a electrical difference, voltage difference when the cell displaces. This principle is called as an Coulter principle. Okay, perfect. It is not electrophoresis. I have an electrophorus also. I'll show you that. Right? Just because we have cathode and anode, it doesn't make it electrophoresis. Right? This principle is called as Coulter principle. How many of you has seen a CBC report? Great. You're right, med school grad. Please don't remove the comment. If you're wrong, it doesn't matter. No one cares about it. If you're right, be happy for yourself. That's all. You must have seen a CBC report, right? Having TC, DC, ESR. The report comes within seconds. You put the blood sample, it automatically comes within seconds. Who is there inside counting them? Newbar's chamber is very difficult. I cannot count it. So the principle works on this. So what I do is, when a 10 to 20 microliter of blood goes into the machine, the cells will move across from one column to other. More the cells move, more amplitudes or more voltage difference comes. So it can exactly tell me the number of cells RBC per cubic mm, WBC per cubic mm. Then we adopt little bit of flow cytometry principles to tell that WBC is neutrophil, lymphocyte, monocyte based on the nuclear shape and the granules present or not, right? This is simple Coulter principle. Coulter principle is the one which is the basis for all the modern cell counters. Cell counters nothing but, in simple terms, we can call it CBC machines. Okay, we have 5-part counters, we have 3-part counters, we have 7-part counters. 7-part counters even can tell me reticulocyte count and blast count. Right? That much amount of inference is there. The simple principle calls in Coulter principle, right? Let's go to the follow-up question. Let's see if you're able to answer that. Answer, option. I explained the video. I told you what it is. Let's see if we're able to get it. It's a simple one, right? Perfect, Pathology. It is B. Coulter principle is a principle behind cell counters. It will help us counting the and sizing up of the blood cells, right? It's not useful for measuring electrolytes. It's not used to detect blood group antigens or measuring the clotting time, right? It is just useful to count the and also categorize the cell types. That's the basics behind a CBC analyzer, right? Perfect, done. Let's go to the next video. Let's see if you're able to understand it and tell me what it is. A very simple video. Tell me what it is. What is this instrument? That's all is my question. I'll have a follow-up question later on. I'll show this once again. See, almost every instrument showed to you in your Viva, in your practicals can be made as a video. What is this instrument? I want the exact thing. I don't want you to tell, okay, this is used for this condition. No, tell me this instrument. What is that? Great. Jamshedji needle is an amazing name, right? It's a bone marrow aspiration or biopsy. Can anyone tell me in that, the difference between that? Is it a bone marrow aspiration or a bone marrow biopsy needle? What do you guys think? Is it bone marrow aspiration or bone marrow biopsy needle, right? Perfect. It's a bone marrow biopsy needle. Parthsarthi, great. Not a right answer will help us to understand something better. This is not a punch biopsy gun. I will show you later on. I'll put in the WhatsApp group a true cut biopsy gun. True cut biopsy looks different from a bone marrow biopsy needle, right? It's a biopsy needle. It's not an aspiration needle, right? How to differentiate first, we'll look into it and then we'll go to the follow-up question, right? So there are two things here. Aspiration is nothing but I am going to aspirate blood. That's all. I puncture the bone. I aspirate the blood. Biopsy is I'm going to break the bone and I'm going to take a piece of it, right? That's what I do in a biopsy. So tell me, aspiration or biopsy, which needs more force? In order to aspirate, I need more force, or to break the bone, I need more force. Obviously, to break the bone, you need more force, right? Aspiration is I puncture and suck it up with a syringe, that's all. So now, if I need more force to break a bone, this needs more support. That's the handle here. Easiest way to remember. If you look at this video, I'll go back to the video once again. You can see that there's a handle there, right? I'm able to hold it like this. Look at this part. You're able to hold it like this, right? So that's how I can hold and I can drill the bone, push it inside and take a bit of it, right? It has a beveled edge which will cut that, right? So biopsy will always have a handle. Whatever variation of needle you use, there are multiple biopsies needle, right? 𝐒𝐿MA is there, Jamshedi is there, whatever it is, it will have a handle to hold. Aspiration will not have a handle, right? Aspiration also will have a stillet. Rather than that, it will be a round part like this. Here, you can apply a syringe. The job of an aspiration is, it should be able to hold a syringe, so they press it with maximum pressure, put a syringe on top of it, suck it so that you can take it from there, right? Okay, 𝐒𝐿𝐴𝐄𝐝. Okay, thank you. Fine. That's how an aspiration needle looks like and a biopsy needle looks like that, right? The follow-up question is a very, very simple question, right? Tell me the answer to this. I'll ask more questions with respect to bone marrow aspiration biopsy. Answer this first, then we'll go to that. What's the answer? A, B, C, D. I want everyone online to answer. It doesn't matter if you make mistakes. The needle demonstrating the thing is a bone marrow refined biopsy needle. What's the most common preferred side in adult? Not a big deal at all, right? You have a posterior superior iliac spine or a iliac crest. That's a preferred site by default, right? Can anyone tell me what will be the site of a bone marrow aspiration or biopsy if I'm having an infant, a 6 months old infant? I have to take a bone marrow aspiration or biopsy. Which will be the preferred site? Posterior, anterior, based on the convenience. If posterior is there, obviously prefer posterior. If it's a child, if it's an infant, I'm going to prefer a tibial tuberosity, right? Infant. Why? The answer is very simple. An infant cannot lie down in a lateral recumbent position. You ask an adult, okay, tilt in a lateral position and sleep. They will be able to sleep. An infant cannot. And I cannot put pressure on the infant to break the bone, right? It's an infant. So, easiest one is tibial tuberosity, because in tibial tuberosity, the kid's knee will be like this, right? You can hold here and you can puncture here easily. Because the kid cannot change position, I prefer that. If this is the reason, can I also say a patient who is bedridden, quadriplegic, I will do in the same tibial tuberosity? Yes, because anyone who cannot turn to a lateral position, I'm going to do in the tibial tuberosity because it's easy to do. It's not that I cannot take from the bone, the anterior superior, posterior superior ligament, right? That's how it is, right? Please do remember them, right? Great. Okay. A follow-up question. This is very simple question, right? Everyone answer. Tell me conditions where bone marrow biopsy is required for diagnosis. Tell me conditions where I need bone marrow biopsy to diagnose. Anything which comes to your mind. Conditions where bone marrow biopsy is must for diagnosis. I'm not asking aspiration, biopsy. Without this, I cannot diagnose that condition. Only few places requires bone marrow biopsy. One is aplastic anemia. Second, myelofibrosis. Third, any metastatic deposit. Okay, metastasis to bone marrow and adenocarcinoma going to the bone marrow, right? Parthasarthi, CA bone, I won't take a bone marrow biopsy, I'll take a bone biopsy. That's different, right? Same with osteoporosis. Okay, leukemia suspect, med school grad, I don't want a biopsy, I want an aspirate. That's why I want to differentiate. Biopsy is a different procedure, aspirate is a different procedure. Only when I cannot diagnose in an aspirate, I need a biopsy. Generally, what is done is they're like, let's do both. Trust me, it's a very, very, very painful procedure. We should be a little bit humane to the patient. Okay, not required, I won't do it. Biopsy cannot aspirate cannot diagnose aplastic anemia. Dry tap, myelofibrosis, dry tap, METS, dry tap. I cannot. Only in places where I cannot diagnose with an aspirate, I do a biopsy. Okay? Harry cell leukemia, yes, I can have a myelofibrosis there also, right? Okay? How much painful an aspiration is or a biopsy is. Okay? You must have read in your books that sternal tenderness is a finding in leukemia. And people will say, leukemia patients come, let's evaluate sternal tenderness. Please don't do it because it's very painful. I want you to do one thing now. Take a knuckle, keep it here on your sternum and really press it hard. Press it hard for me. Just once you do it, you will know that your sternum also will be tender because a very, very, very thin papery bone. It's a very painful procedure. Just pressing on my sternum is painful. This hip bone, that's also a flat bone. I'm breaking the bone. Only when it's required, do it. If it's not required, please don't do it, right? Second question. Tell me whether I require bone marrow aspirate or biopsy bone marrow procedure to diagnose the following conditions, right? I'm going back 1 second. I want you to tell me, do we require a bone marrow study for these conditions? Yes or no is enough for me. Fine. The first thing. How many of you pressed your sternum? Is it painful? The first thing, CML. Do I require a bone marrow? Yes or no? Everyone online, answer. Yes or no, that's all. Put yes or N if you're lazy to type LES. What's YES? CML? No, I don't want a bone marrow study. CML can be diagnosed on a peripheral smear. Do a PCR or a FISH, diagnose 922 translocation, come out of it, right? Second, an ALL or an AML with 50% blast in peripheral smear. Do I need a bone marrow here? Yes or no? Do I need a bone marrow here? Yes or no? A leukemia, ALL or AML, I'm not sure about it. 50% blast in peripheral smear. Answer is no, I don't need it because I have 50% blast. Enough for me to diagnose it is leukemia, acute leukemia. Can anyone tell me what's the next step here? I don't want an aspirate or a biopsy here also, right? What's the next step here? Patient came, peripheral smear done, 50% blast in the peripheral smear. What's the next step? The next step is do a flow cytometry on the blood. I don't want a bone marrow biopsy or an aspirate here, right? Why should I go and puncture the patient's bone when I can diagnose with confidence on a peripheral smear, right? So the funda is simple. If you can diagnose or satisfy the criteria for diagnosis with peripheral smear, don't go for a biopsy, don't go for an aspirate.
A patient presented with involuntary movement. So yes, we are talking about a movement disorder here. Patient's involuntary movements are documented in the video attached. Which of the following is false about the patient's condition? So that means this is going to be the most common video based question template where video holds some information. You have to make a mental diagnosis of what this particular condition is all about, and then the question will be asked based on that mental diagnosis that you're making. If you get the diagnosis wrong, then your answer of course goes wrong. Okay, and what we have to identify is among the given statements, which statements are false. That's what we need to identify. Okay, so let me play the video first. So here's an individual showing some involuntary movement. And we know the movement disorders are classified broadly into two groups, where you have like hyperkinetic movement disorders and hypokinetic. So when you have involuntary excess movements, it's of course an hyperkinetic movement disorder, and hyperkinetic movement disorders are further divided into rhythmic and non-rhythmic. Rhythmic is where the same rhythm or same movement keeps recurring again and again, and we have called them as tremor or dystonia. And in the non-rhythmic movement disorders, we had chorea, athetosis, and balismus. Hi Vivek. So now please watch the video and tell me what do you think, which kind of movement disorder it is. Am I talking about a tremor here, or is it a dystonia? Is it chorea, athetosis, or balismus? Okay, is it the same movement which is recurring again and again? For those who have joined late, let me read out the question again and then we will see the video one more time. So we have a patient who presented with some involuntary movements. We have already watched a bit of that video. Patient's involuntary movements are documented in the video attached. Which of the following is false about the patient's condition? So first thing I have to do is, by looking at the video, I have to diagnose what is the movement abnormality here. Okay, so can we take a few minutes to quickly discuss about the movement disorders? We have done that in the previous lesson as well. Movement disorders where there are abnormal movements are classified into two broad groups, the hypokinetic and hyperkinetic movement disorders. And you know, hypokinetic, a classical example is bradykinesia that you encounter in hypokinetic disorders. A classical example is bradykinesia that you get in patients with Parkinsonism. Bradykinesia of Parkinsonism is a classical example. Okay, then we have hyperkinetic movement disorders, where we further classify them into two groups. The hyperkinetic disorders are further classified into rhythmic and non-rhythmic. Rhythmic and non-rhythmic. Now, rhythmic means the same movement keeps recurring again and again, and under rhythmic we have two of them. One is tremors, and in the previous lesson we have in detail discussed various types of tremors, like the resting tremors, intention tremor, postural tremor. Another one is dystonia. Today we will focus on the non-rhythmic movement disorders. There are mainly three non-rhythmic movement disorders that you need to remember. The first one is going to be chorea. Second one is athetosis, and the third one is balismus. If it is unilateral, you can add hemi to any of them. You can call it as hemichorea, hemiathetosis, or hemibalismus. If it is bilateral, you can simply call it as chorea, athetosis, and balismus. Now, it's pretty easy to describe the rhythmic movement disorders because the same movement keeps recurring again and again, and we can compare it to some day-to-day event and easily describe it. Like, for example, the Parkinson disease tremor, we call it as pill rolling tremor because it looks like the patient is holding a pill between thumb and other fingers and she is rolling it. This hepatic encephalopathy tremor, we call it as flapping tremor because it looks like the flapping of the wings of a bird. The postural tremor that we get in patients with Wilson's disease, it looks like again the beating of the wings of a bird, so we call it as wing beating tremor. But when it comes to non-rhythmic movement disorders, it's a bit difficult to describe. Why? Because there is no one standard rhythm. The movements are random. You cannot predict where will be the position of the affected limb or affected group of muscles in the next second. In rhythmic movement disorders, it is predictable, but still we can make an attempt to describe them. So what is the usual way we describe the chorea? The chorea is described as, okay, remember, chorea mainly affects the distal body parts. It affects distal body parts and face. Okay, and the usual way of describing chorea is dance-like movements. In fact, the word chorea comes from choreography. Means it looks like someone has choreographed these movements. These are called as dance-like movements. Why they are called as dance-like movements? Because the movements keep, like, they appear flowing from one joint to other joint. Like, first I do this and then this. It was flowing from elbow joint to wrist joint. And that's what we do in the dance, right? We keep moving body parts as if there is something flowing through the body. So it kind of resembles dance. So that's why we describe it as dance-like. Okay. And also remember, the movements in chorea are generally rapid. They are not very slow movements. Okay. In case of athetosis also affects distal parts, means hands, and if it is lower limb involved, then maybe feet, but proximal parts are not affected. It mainly affects the distal body parts. But unlike the chorea, these movements are slow. These movements are not rapid. Athetosis movements are not rapid, slow. And the best way to describe them is, we would rather call them as writhing movements or snake-like movements. Writhing or snake-like movements. So these are more of twisting movements. It looks like something is being constantly twisted, like how snake moves. If there is distal body parts where you see twisting movements occurring and they are rather very slow, they are not rapid, then you will call it as athetosis. And now how do I describe balismus? The best way to describe balismus, again remember, balismus predominantly affects the proximal muscles than distal. So the movement is not going to happen in the small joints of the hand or forearm. The movement is mainly going to happen in the proximal group of muscles like the shoulder girdle muscles and arm muscles. So what are the main functions of shoulder girdle muscles? Like deltoid is the main muscle, right? So what are the main movements that can occur at the shoulder joint? So you will be seeing the movements there, the proximal muscles, and these are usually described as violent flinging movements. Violent flinging movements. So these movements are not like gentle movements that you get in case of chorea. Chorea are literally like some classical dance kind of movements, very gentle movements. So here the proximal group of muscles showing violent flinging movements. Now fling means what? Fling basically refers to take something and then throw far away from our body. That's what the fling means. So it looks like they're trying to fling the body parts away, and that won't happen by small muscles of the hand contraction, right? I have to contract the proximal muscles. That is where I can execute the flinging movements. So whenever you get a non-rhythmic movement disorder video, first thing you should see is whether the main driver of the movements is proximal muscles or distal. If you see they are proximal muscles, probably the question is about balismus. But if it is distal muscles, then it is going to be chorea or athetosis. Then you should see whether the movements are kind of twisting movements and are slow. In that case, it is athetosis. But if the movements are rapid and they appear to flow from one joint to next, kind of dance like, then it is going to be chorea. So now can we see this video? Is there any involvement of shoulder joint? No. So it's not proximal group of muscles which are affected. So I'm not thinking about balismus here. I'm going to think about athetosis and chorea. The movements are rapid, they are not slow, and they appear to flow from one joint to other. Like you can see elbow showing some movement, and then wrist joint showing some movement, then hand joints, small muscles of the hand showing some movement, again elbow, wrist and small muscles of the hand. So this is typical of chorea, flowy movements. It looks like someone has choreographed. I can probably relate to some Bharatanatyam or Kathakali, Kuchipudi movements. The same kind of movements they do, right? But of course, they are doing gracious movements. These are involuntary here, but kind of comparable. So that's why we are going to call them as dance-like. So yes, many of you got the diagnosis right. This video plays chorea. So once the diagnosis is sorted, now can we answer the question? What they're asking is, which of the following statements are false about the condition? Okay. So first thing is, a lesion in caudate nucleus is likely to produce the involuntary movement showed in the video. True or false? True or false? Diagnosis is right, that's chorea. The first statement, caudate nucleus is the site of lesion for chorea. True or false? Well, I definitely want you to remember the site of lesions for all the movement disorders. So on one side, we will write the movement disorders, and on the other side, we will write the site of lesion. Site of lesion. Okay. The first most important one is the pill rolling tremor. Pill rolling tremor. And what is the site of lesion for pill rolling tremor? You get that in Parkinson's disease, and the site of lesion is going to be substantia nigra pars compacta. Substantia nigra pars compacta. Okay. The second one is action tremor or intention tremor, that you get whenever there is a lesion in cerebellum. Cerebellum. Okay. The third one is chorea. Chorea occurs whenever there is a lesion in caudate nucleus. Easy to remember, C for C. C for C, caudate nucleus. Caudate nucleus lesion produces chorea. Okay. The next one was athetosis, where you have distal movements but slow and twisting or snake-like movements. And the site of lesion to produce athetosis is globus pallidus. And or the putamen, globus pallidus or putamen. And the next one is the balismus, where you have violent flinging movements mainly occurring in the proximal group of muscles. This is what the patient will be doing. Movement is occurring at the shoulder joint usually. And the site of lesion for that is subthalamic nucleus, also called as subthalamic nucleus of Lewis. That's the site of lesion. Okay. Now, how do I remember the balismus as the subthalamic nucleus as the site of lesion for balismus? That's pretty easy and simple. Please remember, there's a cricketing shot which is also literally a violent flinging shot. where the movement mainly occurs at the shoulder joint and there is barely any movement occurring at the elbow joint. Otherwise, most of the cricket shots, you talk about square drive, right? Any cricketing shot, elbow is the main driver. But there is one shot where the main driver is the shoulder muscles. Elbow joint doesn't move much, and we call it as helicopter shot, right? Who plays that helicopter shot? The first helicopter shot was played by Mohammad Azharuddin, but the one that popularized it is Dhoni, popularly called as Tala, right? So whenever the ball comes to cricket pitch, Tala comes to play there. Balismus, ball is in the pitch, Tala has to come there. So you remember it as subthalamic nucleus as a site of lesion for Balismus. So that means the first statement is true. Caudate nucleus is the site of lesion for chorea. Okay. Second, patient is suffering from postural tremors. True or false? This patient had a non-rhythmic movement disorder, not a tremor. Tremor is a rhythmic movement disorder. So this is a false statement. Okay. Next one is hyperglycemia is one of the causes, right? So we should remember the causes for chorea. Few are very popular causes, few are not very popular. In fact, the most common cause is hyperglycemia. So uncontrolled diabetes can lead to caudate nucleus damage, mainly demyelination in the caudate nucleus, and that can lead to chorea. That's the most common cause. The popular causes are not very common. One of them is Huntington's chorea. Huntington's disease or Huntington's chorea. The other one is Sydenham's chorea. Where do you get Sydenham's chorea? Sydenham's chorea is a major criteria for rheumatic fever, right? So these are the common causes that you need to remember for chorea. So hyperglycemia is one of the causes, not just one of the causes, but indeed the most common cause. So this is true statement. Sodium valproate can be used for symptomatic relief. Yes, in patients where we have chorea, to relieve the chorea, we do use sodium valproate. So this is also true statement. So we are looking for a false statement, and that's there in option B. So that becomes our correct answer. Okay. Now let's go to the next question. A known diabetic presented with tingling numbness in both feet. His walk revealed abnormal gait seen in the video. Which of the following is true about the condition? There are two things here. One, he has got tingling numbness, and then the gait is abnormal. Which of the following is true about the condition? Okay, so let me play the video so that you can recognize the gait, and then we will talk about the question. So what do you notice here in the gait? Yes, first thing you can observe is patient needs support with a stick to walk. Second thing, probably it looks like he has got foot drop, and that's why he is raising his feet quite high on the ground and then stomping to avoid tripping over. So this kind of a gait, we call it as high steppage gait or stomping gait. Where do we get that? Generally, we get it when there is foot drop. Foot drop occurs when you have weakness of distal muscles of the feet, right? Mainly the tibialis anterior and other smaller muscles. Okay, unilateral foot drop can occur because of a particular nerve damage, but here we are looking at bilateral, so it has to be a systemic disease. So which systemic disease causes distal muscle weakness? It is mainly peripheral neuropathies. Peripheral neuropathies. The muscle disorders like Duchenne muscular dystrophy or endocrine myopathies, they affect the larger proximal group of muscles, but peripheral neuropathies affect the distal smaller group of muscles. So in the upper limb, patients can develop wrist drop. In the lower limb, patients can develop feet drop. Okay, so we can conclude that we saw a high steppage gait, and being bilateral, I am thinking of not an individual nerve injury, but rather peripheral neuropathy. Peripheral neuropathy. Okay, so once you have peripheral neuropathy, the first question is, what is the most common cause for peripheral neuropathy? Diabetic neuropathy is the most common cause for peripheral neuropathy. Okay, so now what they're asking true about the condition. Patient is suffering from sensory neuropathy. True or false? Patient is suffering from sensory neuropathy. True or false? Is there any involvement of sensory involvement? Yeah, so if I had got a unilateral foot drop, I would have thought of the CPN nerve injury. But because it is bilateral, we would be thinking of more of systemic pathologies. So CPN, in peripheral neuropathies, generally length-based involvement occurs. The longest nerves, which are carrying the longest journey, they get affected first. Okay, and CPN, yes, carries a very long journey from the lumbosacral region all the way to the small muscles of the feet and the leg. That's why it gets affected first. See, I wouldn't consider this as a pure sensory neuropathy. Why not? Because yes, these tingling sensations are suggestive of sensory symptoms. There is involvement of sensory. But then there is also bilateral foot drop that we have noticed. And bilateral foot drop indicates that it is not only sensory, there is also involvement of motor. So there are both motor as well as sensory symptoms present. So I have to call this as sensory motor peripheral neuropathy and not pure sensory or pure motor. Okay, so we'll keep this reserved. Gait demonstrated is festinant gait. This is clearly a false statement because what we saw is the high steppage gait. The festinant gait is the gait that we see in patients with Parkinson's disease. In patients with Parkinson's disease, where because of the increased tone of anterior muscles, they have a stooped forward posture. And because of the stooped forward posture, they have a tendency to fall forward. To escape falling forward, they make certain gait adaptations. They make their feet placement wide and they tend to walk hurriedly. That's an escape mechanism trying to avoid falling. And that kind of a gait, we call it as the festinant gait or short shuffling gait. So this is false. Gait demonstrated is high steppage gait. Yes, this is true. This is what we have seen here, also called stomping gait. Patient is suffering from diabetic motor neuropathy is false because here both the sensory and thing put together, I would rather consider this peripheral neuropathy as sensory motor. Sensory motor. In fact, in diabetic neuropathy, sensory gets affected first and eventually motor gets affected. Initial presentation is always with sensory symptoms. Is a known diabetic, so his diagnosis was uncontrolled diabetes resulting in sensory motor polyneuropathy. Okay, so we were looking for a true statement. This is not pure motor, not pure sensory. We got the true statement in option C. We are dealing with high steppage gait here. Okay, next one. The test demonstrated here helps to identify. Okay, I'll play a test. You should see the test and then tell me which of the following finding it helps to identify. Just give me 1 second. So what is this test called and what is it actually done for? What are we trying to identify by doing this test? If you look closely, the patient is holding his thumb and index finger wide open at the beginning of the test, and after that he's tapping it repeatedly. The instruction given to him was keep it as wide open as possible and then tap as fast as possible. As fast as possible. So what do we call this test as? Well, the test is called as finger tap test. The test in the video is called as finger tap test. Finger tap test. It is not for the coordination of the movement. This is done to identify bradykinesia. Bradykinesia is one of the manifestation of Parkinsonism. Okay. Now, when the bradykinesia is severe, patients themselves will complain and then you will see bradykinesia in everything. They will be slow in everything, facial expressions gone, small handwriting, all those typical findings appear. But if I want to recognize it way before the bradykinesia becomes overtly apparent, then we do this finger tap test. Normally, a healthy individual with good motor activity should be able to, we generally ask them to do it for 10 seconds and then we count how many taps they do. they should be able to do comfortably anywhere above 45 taps in 10 seconds. If it is less than 30, that means there is bradykinesia present. Okay, understood? So we do this for 10 seconds, and if the number of taps less than 30 taps and more than 45 taps, if they are able to do more than 45 taps, then there is no bradykinesia. And if they are doing less than 30 taps, there is clearly bradykinesia present. Between 30 to 45, it's a gray zone. We have to look at the clinical context and then decide whether I should count this as bradykinesia or not. But less than 30, we take it as bradykinesia. Okay. Brain fog is basically a cognitive arrest where suddenly the thought process gets blocked. Nothing to do with this motor movement. For coordination of movement, mainly we do tests like finger nose test or knee heel shin test. Intention tremor, we ask the patient to do any voluntary movement and see whether the tremor kicks in. So what we saw here is the test done for identification of bradykinesia, and we call this as finger tap test. Okay, clear? It's one of the easy early way to recognize the motor slowing or bradykinesia in Parkinson's disease suspected cases. If you follow them for few more years, then the other manifestations will become apparent, but the finger tap test becomes slow much before that. Okay, so next question is this. A known hypertensive with dyspnea on exertion. Patient is hypertensive, is having shortness of breath on exertion. Examination revealed a BP of 160/60. Do you see anything abnormal in the BP here? Anything unusual in the BP? What is the pulse pressure here? In this case, is a known hypertensive. Remember, hypertension increases the risk of a lot of problems with respect to heart. Hypertension can lead to left ventricular hypertrophy. Hypertension can lead to heart failure with preserved ejection fraction. That can lead to pulmonary congestion. That can cause dyspnea. Another thing you have to remember is hypertension is also one of the leading causes for aortic regurgitation. Okay. Yes, BP is increased, but diastolic is lower and systolic is grossly increased. So if you calculate the pulse pressure here, what is pulse pressure? Pulse pressure is the difference between systolic BP minus diastolic BP. So in this case, the pulse pressure turns out to be 160 minus 60. That's almost equal to 100 millimeters of mercury. Normally, we have a pulse pressure around 40 millimeters of mercury plus or minus 10 this side, that side. So clearly there is increased pulse pressure. Now tell me, in what all conditions we can get wide pulse pressure? Yes, we get wide pulse pressure in patients with aortic regurgitation and hyperthyroidism. These are two important conditions you need to remember. There are other conditions, but these two you cannot miss, right? Please remember causes for wide pulse pressure. First one is aortic regurgitation and the second one is hyperthyroidism. Okay, now there is a displaced apical impulse. That means either there is eccentric LVH or left ventricular dilatation. That's why the apical impulse is displaced. Plus an early diastolic murmur in the left third intercostal space. Left third intercostal space is your Erb's area. And we use Erb's area for listening to the murmur of AR. And is this the murmur of AR? Yes, in aortic regurgitation, we get early diastolic murmur. So don't you think the diagnosis is pointing towards aortic regurgitation? Yes, the diagnosis is pointing towards aortic regurgitation. Now we have to just watch the video and answer what sign is being demonstrated. Because of this wide pulse pressure, a lot of pulses become visible in aortic regurgitation. Like you will have visible uvula pulsations, you will have visible forehead capillary pulsations, you will have visible carotid pulsation, you will have visible brachial artery pulsation, you will have visible nail bed pulsation, and we have given name for all these signs. Till now, the named signs in AR were asked as like match the following or which of the following is not or is a finding in AR, those kind of questions. But now you can expect video based questions as well. Okay, so let me play the video and see if we can identify that. Just give me 1 second. So this is a very popular video. I think all of you would have seen this. What do you notice here? Already the context is set. The context is we are expecting a patient of AR here. And if it is a case of AR and you see some visible pulsations in the neck, what should you conclude? You would think of it as dancing carotids. And what is the name given to dancing carotids? Yes, it is Corrigan's sign. It is Corrigan's sign. What is 𝐷-Musette's sign? What is 𝐷-Musette's sign? And let me tell you an important tip. There can be JVP based questions where some neck pulsations will be visible. There can be AR related questions where neck pulsations will be visible. In both the cases, it can be very confusing. If I have a real patient, I can see whether it is coming from an artery or vein, whether it is compressible or not. But then when it is a video, I cannot examine and see, right? I have to rely on visual inspection. So in such cases, the context helps you to differentiate whether the question is about a JVP abnormality or whether the question is about the aortic regurgitation. Okay, in this case, the context is set. It is aortic regurgitation. So I'm not talking about a JVP abnormality for. Yes, the head bobbing or head nodding is what we call as 𝐷-Musette's sign, again encountered in patients with aortic regurgitation. Okay, what is frog sign? What is frog sign? In the JVP, we get something called as Cannon A waves. What are Cannon A waves? Very tall A waves which appear intermittently. Typically encountered when there is AV dissociation, when atria and ventricle are contracting on their own rate and rhythm. Sometimes atria and ventricle end up contracting simultaneously. So when both of them contract simultaneously, atria will not be able to transfer any blood to the ventricle. So atrial pressure rapidly rises and gives you a very tall A wave. The next contraction, atria may be contracting first, transferring the blood to ventricle, and then ventricle contract. That time you get a normal size A wave. So these intermittently appearing tall A waves, on the JVP we call it as Cannon A waves, and those A waves may be visible on the neck as intermittent vein pulsations. In that case, we will call it as frog sign. So frog sign is nothing but visible Cannon A waves. Visible Cannon A waves. And you get those visible Cannon A waves any condition there is AV dissociation. AV dissociation, and it was typically described in patients with, it was described first in patients with AV nodal reentrant tachycardia or AV NRT. Okay. Now what is this Lancisi sign? Lancisi sign refers to fusion of C wave on the JVP with the V wave that is seen in patients with tricuspid regurgitation. Okay. Now similar neck pulsation videos might be coming up, which may be actually be a case of Lancisi sign or frog sign. Just go through the context and then decide what should be your answer. Okay. A similar video, but then the context is suggestive of tricuspid regurgitation, pulsatile liver, right-sided symptoms, raised JVP, hepatomegaly, ascites. Then choose Lancisi sign. Sudden onset palpitations, breathlessness, brought in a shock state. Then it could be an arrhythmia. Then if there is neck pulsation visible, think of it as frog sign. So context plays an extremely important role, and we keep telling this again and again. Even in real patient management, history plays an extremely important role, right? An isolated finding does not lead to efficient diagnosis and management. Okay, now let's go to the next question. The test demonstrated in the video helps you to identify which of the following pathology: dysmetria, intention tremor, motor apraxia, akinetic mutism. So let me play the video, a very popular one. All of you have done this test. Okay, just give me a second. So what is this test? We simply call it as finger nose test. We have been told that this test is done to identify in coordination of movement. This is the test for coordination of movement, which is largely correct, but exactly what are you looking for when you do this test? Exactly what are we looking for? So video played finger nose test. It is a cerebellar function test. Cerebellum helps you to coordinate the movements. How does it help you to coordinate the movement? The cerebellum receives the inputs from the spinal cord. If this is cerebellum, it receives the inputs from the spinal cord through what you call as spinocerebellar tract. Mainly it's getting the proprioception. It also gets the inputs from the motor pathway, motor cortex, and it also gets the input from the vestibular apparatus. So constantly the cerebellum is monitoring the body's position because it is getting to know the position of different joints. It's also getting to know whether you are tilted or balanced with the help of vestibular apparatus, and motor cortex is also giving the information. So it is getting the information from higher centers as well as spinocerebellar tract and vestibular apparatus. And because it is getting all this information, it can help you to coordinate the movement. Motor area can fire and send a signal to contract a muscle to get an voluntary activity done, but voluntary activity is not gross, it is fine. To give you an example, in front of me there is a cup. If I want to grab that cup, my motor area will send the signals to the required muscles. But do you think it's only one muscle which is going to contract to get me the cup? No, multiple muscles, right? For example, right now, cup is here. So I think the first movement I should be doing is the elbow extension. When I do the elbow extension, I reach the cup. That means the triceps has to contract. Once the triceps contracts, at that time biceps has to relax, triceps has to contract so that I can reach the cup. Once I have reached the cup, I have to contract the small muscles of the hand to grab it. Once I grab it, probably I have to do an internal rotation of the shoulder. And then if I want to take a sip, the flexors of the elbow, that is mainly biceps, has to contract so that the cup reaches my mouth. So I need to coordinate, plan the movements, and to be able to plan the movements, first thing is I need to know where are my joints currently positioned. If my already elbow is extended, then I have to only contract the small muscles of the hand to grab it, right? But if my elbow is in flexed position, I have to extend it. So I have to be aware of the position of joints, which I am getting to know through the spinocerebellar tract. The sensation that it is carrying is proprioception. Body's balance is told to me by vestibular apparatus, and then motor cortex is giving the input to the cerebellum that what it wants to do. So based on what it wants to do, what is the current position of different structures in the body, we can plan and execute the movement. Okay, and one of the thing that helps me to plan and execute the movement is metria. Now what do I mean by metria? Metric means measurement. It's simple. Metria refers to ability to gauge distances. Because for the smooth movement to occur, like if I have to grab the cup, my hand should reach only the cup. It should not go beyond that. I should not extend the elbow beyond the cup, or I should not fall short of it. So I need to gauge the distance. The cerebellum, because it is getting all these inputs, can help me gauge the distance. And we are calling it as metria. If I'm not able to gauge the distance, we will call it as dysmetria. Okay, got it? So metria, or gauging the distance, is one of the functions of the cerebellum which helps you to coordinate the movement. Now what we did in the finger nose test is actually trying to see whether patient is able to gauge the distance or he has developed dysmetria. When you ask them to touch their finger and then come back and touch your finger, they have to gauge the distance. Where is your finger positioned? If they're able to gauge the distance, then they will be able to do a coordinated movement. If they're not able to gauge the distance, one thing you will notice is either they fall short of it or they go beyond the target. Going beyond the target is a frequent observation. We call it as past pointing. Past pointing. So finger nose test helps you to understand whether there is incoordination of the movement by understanding whether patient is able to execute the metria or whether he has got dysmetria. Okay, so the first and the most important answer here should be dysmetria. Okay, but the test also helps you to identify the presence of intention tremor, because in cerebellar dysfunction, they may not have the tremor at rest. They may not get the tremor when the limb is held in a particular posture, but when they try to do a voluntary movement, they cannot get the coordination right, and then they start pointing here and there, and that's exactly what is our intention tremor or action tremor. So the same test can help you to gauge the dysmetria by looking at past pointing, and the same test helps you to unmask the presence of intention tremor. Like the moment they try to touch the nose, the finger goes here and there. That is your intention tremor. When they come to your finger, again it goes here and there. That's intention tremor. They go beyond the target, that is past pointing. So dysmetria manifests on the test as past pointing. And you can also identify intention tremor towards the target, the tremor kicks in. So both are right answers here. If you have to choose one, I would always choose dysmetria over intention tremor, because for intention tremor I can ask them to do any voluntary action and it will come. But to prove the past pointing, I have to first have a target and then ask them to reach it. When they are going beyond that, there is dysmetria. Okay. Now, can anybody tell me what is apraxia and what is akinetic mutism? What is motor apraxia? Okay, so in neurology, the word apraxia refers to loss of learned or acquired skills. So when we lose a skill which you have already got, then we call it as apraxia. For example, as a child, as we start passing through milestones, we learn to make a tower of 3 cubes, 4 cubes, right? So now I could make a tower with 3 objects. It's a skill. I have learnt it during my childhood, and pediatricians have called it as a milestone. I don't remember by what age a child is supposed to make a tower of 3 cubes. I guess 3 years. It's a skill that I have acquired. But now if I'm not able to do that, you give me 3 cubes and I cannot arrange it like a tower. That means an acquired skill is lost. That's apraxia, right? So apraxia refers to loss of acquired skills or learned skills. Okay, more on the apraxia we'll discuss in the next video based lesson, where we will have few apraxia based videos as well. Okay, the next one is akinetic mutism. Can anybody tell me what does that mean? Akinetic mutism. Mute means switch off, like mute. Everybody knows what is mute means. And bradykinesia is a word we are familiar. Kinesis or kinesiology refers to the study of movements. Akinetic means no movements. Tushar Goswami, absolutely right. Good. So akinetic mutism is different from paralysis and aphasia. Now, for me to speak efficiently, there are multiple areas doing their job. If you ask me a question, the question first falls on my ear, then the information goes to the temporal lobe, where we have auditory area. Auditory area first processes what did we hear, then that is passed on to the Wernicke's area to decode the meaning of what I heard. Once Wernicke's area decodes the meaning of what I have heard, now I have to give an answer. So I have to coordinate with my memory area, extract the answer, and then that answer is processed by the Broca's area. Like grammatically, the answer is organized by Broca's area by placing the required words, and that signal is now sent to the vocal cords to produce the sound. That's how I give the answer to questions asked to me. In this whole apparatus, if there is any pathology and because of that I'm not able to speak, we call it as aphasia. If Wernicke's area is damaged, sensory aphasia or Wernicke's aphasia, connection, arcuate fasciculus between Wernicke's and Broca's area, if that is damaged, you call it as conduction aphasia. And if Broca's area is damaged, you're not able to produce the words, then we will call it as Broca's or motor aphasia. But if this whole speech apparatus is fine, but still the person is not speaking, then we will call it as mutism. Means he's capable of speaking, but he's not doing it. That is mutism. Similarly, for motor movements, we have a pyramidal tract. Motor area sends the signals to through upper motor neuron to the spinal cord, and from the spinal cord through lower motor neuron, the signal comes to muscles and muscles contract. In this whole motor pathway, if there is any damage and because of that I'm not able to execute a motor movement, then we will call it as paralysis or paresis. But if this whole system is fine, motor area is fine, the spinal cord is fine, lower motor neurons are fine, the muscle is fine, neuromuscular junction is fine, but still the patient is not executing any movements, then we call it as akinesis. The simple thing is, for us to execute movements is also, and also for us to speak, there's a constant motivation required at the level of CNS, and that motivation actually comes from the cingulate cortex. So if cingulate cortex is damaged, you will have perfectly fine motor system, perfectly fine speech apparatus, but still you lack the motivation to move and you lack the motivation to speak. So such patients, despite having all motor functions, speech functions normal, they don't speak much, they don't move much. Such condition is what we call as akinetic mutism. So absent movement and speech despite normal motor and speech system, and it is usually due to severe lesions in cingulate cortex, which is part of the limbic system.
I'll read the question first. What is the best surgical management of the lesion shown in this laparoscopy of a primary gravida? Okay, this is a woman who is pregnant for the first time, and there's a lesion which I'm going to show you in the laparoscopy. And what is the best surgical management of this? So yes, you can see there is a lesion here. I'm now with my instrument, with my grasp, I'm trying to show you. Can you see? While I was making this video, I was keeping my students in my mind so that I can, show you how the parts of this. See once again. So this is the uterus, this is the fallopian tube, and I'm pointing out a segment of the tube which has a swelling. So it's obviously a swelling in the fallopian tube. So if there's a swelling in the fallopian tube, we are going to ask you only about an ectopic pregnancy. So if there's an ectopic pregnancy, what is the best surgical management of this lesion in a primary gravida? See, now you have to use your basic understanding. You can make out by this that it's an ectopic pregnancy. What kind of ectopic it is? Are you seeing any blood? Are you seeing any blood in the abdomen here? In this laparoscopy, are you seeing any blood? No, you're not seeing. Are you seeing any rupture in the tube? You're not seeing. So it's an unruptured ectopic pregnancy, and we are doing a surgical management. So it's understood that the criteria has been met for doing a surgical management. So when you're doing a surgical management, what is the best surgical management? Yes, a lot of you are saying answer is D, because that's a linear salpingostomy. Resection anastomosis, nobody wants to say. You can do a resection anastomosis. Yes, that is a surgery which you can do. Yes, that is a surgery. You can chop the tube from here and re-anastomose. A much more difficult surgery, but it can be done. So remember, resection anastomosis is a option which is correct, but the best option is obviously what you guys have written, and that is a linear salpingostomy. You'll make an incision on the tube and take the products out and leave the incision. Okay, let me try and show you. See, don't do total salpingectomy because she's a young lady. She wants to, she's a primary gravida. She wants to save the tube so that she can have children next. And partial salpingectomy is never done. There's nothing called partial salpingectomy. I don't know why it is there, still mentioned in so many books. Please remember, nobody does a partial salpingectomy. There are people who've been penalized by the law. Yes, there have been cases against people who've done partial salpingectomies, and people have had an ectopic in that segment which was left behind. So do not even think of writing. So a lot of books are giving you some 30 surgeries for ectopic pregnancy, and you don't have the basic concept of ectopic pregnancy management. So basic is, if it's a ruptured tube, do a total salpingectomy. But if it's an unruptured tube, then you want to save the tube. Now, how you can save the tube? You can do a medical or a surgical conservation. So what is a surgical conservation? Linear salpingostomy. So let me show you what is a linear salpingostomy. See here, now if you see this picture here, look at this same patient. Now you see the tube is a little distended because I have injected something called the vasopressin injection in the antimesenteric border. This is the antimesenteric border. The top of the tube will be antimesenteric. The bottom of the lower part of the tube will have a mesenteric. So antimesenteric border, I have injected the vasopressin. That part I am not showing you. Now I am showing you the part where I am doing the surgery. Wait a minute. Oh God. So what happened to the video? Yes. See this. This is the linear incision. Okay. So that is the lengthwise incision which I have made. Once again, yeah, once you make that lengthwise incision, once you made that incision, you can see that the edges will bleed. So these edges are cauterized, all that I am not showing you here. Next is that these edges, the bleeding stops and the products have to be removed. So that is the gestation sac inside there. So come, we will show you that also. Yeah, see, now how do you remove the gestation sac? We don't generally pull it out. What we do, we actually do a hydrodissection. So I have this cannula which is pushing saline in high pressure, and you can see the placental tissues, the villi, the fronds are coming out here first, and then I'm still using this hydrodissection, and you can see now, yes, this is the part of the gestation sac. There is some bleeding in it already because of whatever procedures we are doing. So this gestation sac and the villi fronds will come out, and once they pop out, can you see the edges are not bleeding at all? Because before I do this, I would have done cautery of the sides. So linear salpingostomy, I made an incision and took out the products. I did not do a suturing. That is called salpingotomy, and nobody is asking you salpingotomy anymore. Linear salpingostomy is the word which I have taught you just now. Okay, so linear salpingostomy, make an incision and do a hydrodissection, take out the products, and that is the conservative surgery for a unruptured ectopic pregnancy. So now, what is the management of a unruptured ectopic pregnancy? You can do a medical management of unruptured ectopic pregnancy. That is, you can use methotrexate, that is the most common drug used, and then the potassium chloride injection, or you can use mifepristone. Many other drugs have been tried. Mostly we are asking about methotrexate. Another question coming up in the same lecture about this. Okay, and then we can do surgical management of an unruptured ectopic pregnancy, which is linear salpingostomy, which you just now read, and there's another one which is the resection and anastomosis, rather difficult method to do the management, and there's still another one known as the milking of the tube. Now, what is the milking of the tube? The ectopic, which is like this, you squeeze the tube like this and you milk out the products, and you enforce a tubal abortion while doing the surgery, milking of the tube. And this is a surgery which is not done anymore. Please, it is there in the books, I don't know why. Please, we do not do milking of the tube. If you're trying to save the tube and you save it by milking the tube, you're actually destroying the tubal architecture altogether. So please don't do any milking of the tube. That's not done anymore. I've seen people trying to explain the juniors ki milking kaise ki jati hai. Please guys, if anybody, all you PGs, if some seniors teach you about milking of the tube, please tell them that this is not done. This actually spoils the tube. So we do only linear salpingostomy or resection and anastomosis, and out of that also linear salpingostomy. So the criteria, yes, all of you know, the size should be 4 centimeters, and if it is more than 4 centimeters, we do surgical management. HC should be 5,000 international units, and if it is 50,000 okay, okay, take it out, 5,000 guys. So HCG is 5,000. If it is more than that, linear salpingostomy. Cardiac activity, if it is present, then this surgical management. So all this surgical management, if the size is more than 4, HC is more than 5,000, and cardiac activity is present. Now, we can do medical management if the size is smaller than 4 centimeters, HCG is lesser, and cardiac activity is absent. Cardiac activity is absent, I'm sorry. Cardiac activity is absent. So now try and understand that even if one value is on the right side, then we will go ahead and do a surgical management. Right. So yes, once again, cardiac activity absent and cardiac activity present. So keep that in mind. So that is the management of an unruptured ectopic pregnancy. Just a quick revision. Now, the surgery shown here on the fallopian tube is a common procedure in emergency obstetrics. The tube is seen here in the background of significant hemoperitoneum. What is the most likely site of the lesion which required this surgery? So, another video guys. The surgery shown here is a common practice in emergency obstetrics. The tube seen here is in a background of significant hemoperitoneum. Can you see there is blood all over the place? And what we are doing with this tube, can you see that? Yes, what has been done with this tube? See, the ovary has been left behind and the tube has been snipped, totally snipped. Once again, Yes, here, can you see we have cauterized the base of the tube and then we have done a total salpingectomy. So, when we do a total salpingectomy, that is the management of a ruptured ectopic pregnancy, you can make out there is so much of blood in the abdomen. This patient had almost 3.5 liters and she was in shock. Now, you tell me when you're doing, of course, this is a laparoscopic procedure. In shock, laparoscopic procedure, please only senior doctors should be doing. Anyway, so when we're doing this, what is the most likely site of the lesion which required this surgery? Now, that's the question. You know the surgery. You've been told just before in this session itself that linear salpingostomy for unruptured ectopic and total salpingectomy for a ruptured ectopic. Now, you're seeing a total total salpingectomy of a ruptured ectopic pregnancy. What is the most common site of rupture of this ectopic pregnancy? Yes. How many of you are saying A and how many are saying B? Okay. Yes, Jayalakshmi has got it correct. Most common site of lesion, meaning most common site of ectopic. Yes, obviously correct. That's the right way to look at it. So, most common site of an ectopic pregnancy is obviously the ampulla. Okay. Do not get into any confusion. Ampulla is 70% of the ectopic pregnancy. Okay. So, if you written ampulla, then I'm happy all of you are correct. Yes, most of you are writing ampulla, and isthmus is the earliest to rupture, not the most common ectopic. Okay. So, yes, just for a quick revision. So, isthmic ectopic is 11% of the ectopic pregnancies, ampullary is 70%, and interstitial cornual is a very rare ectopic pregnancy. Now, when does the isthmic ectopic rupture? It is the earliest to rupture, and the ampullary ectopic is the commonest rupture. This is the commonest rupture. So, earliest to rupture, if at all they ask you, you can say isthmic, but the commonest ectopic, 70% ectopic will be the commonest to rupture. If ectopic happens in the ampulla most, then it will rupture in the ampulla most. And then the rare ectopic is the interstitial cornual. I'm not saying rarest. Rarest, yes, rarest ectopic. Anybody? I'm keeping it open. Please, I'm waiting for your answer, guys. I want some answers there. Rarest ectopic kaun sa hota hai? There are many other sites. Abdominal, ovarian. I'm not mentioning the other sites. Soch ke batao. So, interstitial cornual, this is the last. Why interstitial or the cornual ectopic will rupture at the last? Because you see, the tube traverses through the uterine body, and this part where it traverses, if the ectopic is here in this part, so the uterine muscle will grow along the growing ectopic. So, this grows for a long time before it ruptures. So, this will rupture at 12 to 6 weeks. Although the narrowest part of the fallopian tube is the interstitial part, this intramuscular part. This is indeed the narrowest part of the fallopian tube. Isthmus is narrow, but the narrowest is the interstitial part. And this time, remember that if the ectopic is here, it will grow for a long time before it ruptures. Okay. Now, what is the rarest? Uska answer though. Ovarian is not the rarest, guys. Ovarian is not the rarest. That's a tough question now. So, we have ovarian ectopic, we have abdominal ectopic, and then we have a cesarean scar ectopic. Which cesarean scar? The uterine scar, not the abdominal scar. The uterus के ऊपर जो हम लोग incision करते हैं, lower segment or upper segment, whatever you call it. So, the uterine scar is also there, and then there is cervical ectopic. So, yes, there was always a talk between, sir, whether the scar ectopic is the rarest or whether the cervical ectopic is the rarest. Let's see. So, you got the choices. Surgical site, abdominal ectopic is not the rarest, no. Choice is between the uterine scar and the cervical. So, I remember when I was doing my MD in JIPMER, my boss used to tell me that he had seen one case of a uterine scar ectopic, because we used to do so much of normal deliveries then. Now, the cesarean sections are increasing so much. I have seen 11 cases of cesarean scar ectopics. That's a lot. But because so many cesareans are happening, so that's why we have a lot of cesarean scar ectopics. Now, still rarer is the cervical ectopic. Okay. So, yes, most of you got it correct now after the a little bit of hint. So, I can now see 𝐒𝐿𝐿, all right, you got it correct. Smooth specialist, and Ravi and smooth specialist. That's a wonderful name you have. That's your handle, all right, great. So, these are the management options, and the rarest ectopic is the cervical ectopic. Caesarean scar is still rare, but not the rarest. All right, chali, let us see what is depicted by the marker in this early pregnancy scan. Marker means something will come on the screen and show you. So this is a transvaginal. Can you see this is the transvaginal ultrasound probe, and we are doing an ultrasonography in early pregnancy, and a marker is going to just come on that. Can you see now? Can you see? Yes, can you see this plus sign? This marker is trying to show you something here. Okay, I'll show you with my pen. What is this here? This is the head of the baby. This is the body of the baby, and there was a heartbeat here somewhere. Again, I'll show you. See, this is the heartbeat here. Yes, it's an intrauterine pregnancy. Yeah, there's no problem. It's an intrauterine pregnancy, and this marker is trying to show you something here. It's a very nice depiction of something which we ask in your VBQ exams. All you MBBS students are watching this. VBQ में पूछेंगे आपसे, picture देख देंगे, बताएंगे what is this? Just to trouble you sometimes. Tough है थोड़ा सा. Okay, tell me. Is the yolk sac, is the gestation sac, is the developing placenta, or is it a smaller twin, dichromatic diamnotic twin? Yes? Yolk sac, gestation sac. So guys, this is the gestational sac and this is the yolk sac. And you can see the yolk sac is getting pinched out. It is getting pinched out from the sac. What happens? I'll show you this in a picture here. Can you see this G sac here? And can you see this yolk sac? Around 7 weeks. See, the yolk sac is the primitive hematopoietic system. You must understand that in an early pregnancy, you see a gestational sac first. Gestation sac comes first. Then you see a yolk sac next. And this yolk sac will have the fetus growing next to it. So this is what is called the fetal node. Fetal node. And then after some time, this fetus becomes big enough like this. Next is this stage, fetus becomes big enough. And this yolk sac here, this yolk sac, it gets pinched out. It gets pinched out. Around 7 weeks, it gets pinched out. It is just like that. Once the yolk sac's requirement is gone, then it gets pinched out. So it is here like this. You can see this is a gestation sac. This is the yolk sac. So yolk sac gets pinched out of the amniotic sac. It just gets pinched out. Once it gets pinched out, then the uterus obviously has the placenta which is formed, and that placenta will be the source of the the nutrition to the baby. Earlier it was the yolk sac, right? So those who got yolk sac as the answer, you've answered it correct. Chalo, let's see something else. Ugrasen, since 12th standard, right? That's a heavy compliment, but thank you so much. Accepted. Okay, Chali, let's move on and see something else. So a procedure is being done for the management of this ectopic. Sorry, I'm a little heavy on ectopic pregnancy today. I just realized while taking the session because I had a lot of videos on that. So never mind, at least one topic will be very sure in addition to cesareans. Okay, a procedure is being done for the management of this ectopic pregnancy. What is the most common drug used in this procedure? Guys, be very careful. Don't please, this is only a session before the exams. Don't rush to the answer, don't jump to the answer. Please see the procedure which I am doing here, and this is done in one of my ectopic pregnancy patients. This was in fact a scar ectopic, but we are just asking what is the most common drug. Can you see this? I've given you a lot of hints. See, this is the transvaginal scan, this is the uterine wall here. You can't make out, it's a little zoomed in, but this is the ectopic pregnancy here, and a needle just came in. Come, I'll show this again to you. See this. This is the ectopic pregnancy. See, there's a heartbeat here. This is a pregnancy. It's a little zoomed in. There's a pregnancy here. Now the needle is coming inside. One needle is coming inside. See, one needle came. And now I'm going to, yes, I've reached the heart. Can you see? I've reached the heart. And now, just now you'll see. Yes, some drug has been, so it moved a little in the end. Some drug has been injected. Can you see? Some fluid came inside. So, we have injected a drug into the heart of the baby in an ectopic pregnancy. What is the drug? Be careful. I have already warned you. I said I warned you. You guys, you're answering methotrexate. Yes, Jayalakshmi, wonderful. Jayalakshmi, you got it correct. We are injecting KCl to stop the heart. Yes, remember one thing. Always, I told you earlier in the discussion already that when we are doing management of unruptured ectopic pregnancy by medical management, the most common drug used is methotrexate. Correct answer. You can give it intravenous to the mother, intramuscular to the mother. You can give the injection directly into the sac also to degenerate the products, degenerate the pregnancy. But to stop the heart, we give the KCl. Yes, so many times in this patient, in fact, what did I do? First, I use KCl to stop the heart, and next I give methotrexate so that the other products, they do not keep persisting. We don't want a persistence of persistence of trophoblastic tissues. I don't want any persistence of trophoblastic tissues here. They will keep having some blood supply at the edges and they'll keep growing. The baby has died, but the trophoblastic tissues will keep growing for a long time, and the HCG will stay high and she'll keep having intermittent bleeding. So I want to stop the heart of the baby and then I want to degenerate. So I give KCl first. So what is the question? What is the most common drug in this procedure? So you have to understand. I'm showing you it's an ectopic pregnancy. I've told you it's an ectopic pregnancy. There's no doubt about that. And I've shown you needle is going inside. So if the ectopic pregnancy is shown a needle going inside and we're stopping the heart, it is the cardioplegic drug. We are inducing cardioplegia. So that drug is KCl. So the answer is D. KCl is the answer, potassium chloride. Okay. So yes, again, the warning which I gave you, most common drug for the medical management ectopic pregnancy, yes, you are correct, it is methotrexate. But for the cardioplegia, it is potassium chloride. Yes. So if you see some of my videos on the YouTube, you will see you can put scar ectopic pregnancy and Prasan Veg, and you can see something about the uterine scar revision, and you can read about the scar ectopic pregnancies. And then you, of course, scar ectopic is unlikely to come as a NEET PG question in more detail, but yes, scar ectopic pregnancy is seen, and how can it be managed? Mostly we do medical management, although surgical is also done. May come as a question. Yes, NEET PG, they will ask you somewhat difficult questions, so that can come. Okay, go ahead and see that video, and let's see something else now. So in the procedure shown here, what is the most common uterine incision? Procedure shown here, what is the most common uterine incision? Okay, fine. We are seeing the head of the baby here. Okay, fine. The whole baby has come out. Looks like a cesarean section. That's the umbilical cord. And my resident, okay, in a little bit of hurry, has not done the delayed cord clamping because this is a 4-year-old video. Fine. That's yours truly in the video. So we have done an incision to take the baby out. All right. So that's that. Now, please tell me, when we're doing this cesarean section, what is the most common uterine incision? See, you know it's a cesarean section, but in the exam, don't get scared, okay? When we're taking out a baby, it has to be cesarean section, okay? So don't get, nervous when you see videos like that. So it's a cesarean section. So what is the most common uterine incision? Is it an upper segment vertical? Is it an upper segment transverse? Or is it a lower segment transverse or a lower segment vertical? Yeah, take your time. Take your time. I'm waiting for your answers. So, upper segment vertical, or is it a lower segment vertical, lower segment transverse? Okay, a lot of you saying C, lower segment transverse incision. Okay, fine. Now, most of you are answering this, so I'm not going to take much time and tell you what I want to tell you about the cesarean incisions. Remember, cesarean incisions can be abdominal incisions. So, abdominal incisions can be vertical incisions here, and they can be transverse. So that is the abdominal incision on the mother's abdomen to enter the abdomen. So this transverse is also known as the Pfannenstiel. This is also known as Pfannenstiel, also known as the bikini incision. Yes, it is the incision which is cosmetically much better, because if the lady after cesarean, later on in life, she goes to a beach, then the lower part of the bikini is going to cover this incision very easily. But if it's a vertical incision, then it is cosmetically, not very pleasing for the person. So it's actually called the bikini incision. Yes, so bikini incision or the Pfannenstiel incision or transverse incision in the lower abdomen. So these are the incisions on the abdomen. Now, once you open the abdomen, you enter inside and you have to do a uterine incision. Uterine can be a classical incision or a lower segment. Classical means the cesarean section, the first cesarean section. You know, there are a lot of stories. Some of them are, you know, now they are, they are refuted now, that Julius Caesar's mother, when she had a, delivery, that time the attending physician had to cut the abdomen and take the baby out. That was the first cesarean section. That's why this name is like the cesarean incision. All right. So that first was a vertical incision. Yes. As the cesarean section evolved, now we know that we can give a lower segment uterine incision, so that next time we can do a normal delivery, because upper segment contracts and lower segment relaxes. You know, that's how the contraction of the uterus is. Upper segment contracts, lower segment relaxes. That's why lower segment incisions are given. Now, when you give a lower segment incision, it can be low transverse. Yes, all of you said C are correct. Low transverse incision. So, lower segment transverse incision, this is known as the Kerr's incision. Kerr's incision. The lower segment transverse incision. But we can do a lower segment vertical incision also. So that is known as the 𝐒𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿𝐿 German those who are German enthusiasts, they will know this is known as the umlaut here. And this pronunciation is, I'm not the best person here, but yes, 𝐒𝐿𝐿 incision. Otherwise, a lot of people call it the Deeley's incision also. Deeley's incision, the lower segment vertical incision. All right, so you must know these incisions. And this, the scar on the uterus, these are the ones which can cause ectopic pregnancy. The uterine scars are the ones which will have the ectopic. Don't say the abdominal scar has ectopic. Uterine scars have the ectopic. Now, when I ask you scar endometriosis, that is the abdominal scar. So, scar endometriosis, yes, that will come in this abdominal scar. Okay, vertical or transverse, scar endometriosis. And scar ectopic, which I already showed you, scar ectopic is this one, right?
So first I'm going to show you the question. उसके बाद मैं आपको endoscopic finding दूंगा, and let us see how much we can correlate. So this is about a 38-year-old female who's a school teacher. So this is the first thing that I'm giving you as a clue. एक school teacher है who presents with progressive hoarseness of voice since the past 8 months. Hoarseness का क्या मतलब होता है? Hoarseness means when the vocal cords have got a lesion in between, they are not closing properly. So the voice is leaking out. Now she reports that her voice worsens by the end of the working day. That means by the end of the day, her voice is getting fatigued, which is called as vocal asthenia. Now, it improves after weekends or vacations because she's not using her voice, because she's a teacher. Now, she denies smoking, dysphagia, weight loss, or hemoptysis, which is extremely important history for cancers, because the smoker will have carcinoma, but she is a school teacher without any kind of history. Now, what exactly do we decipher out from this history? The following video of video laryngoscopy will be shown to you. Okay, so don't come to a conclusion. Abhi bilkul conclusion pe mat jao ki ye vocal nodule hai. I have asked you, what is the following appropriate management? Very nice if you guys have seen and if you guys have understood. But what I want to show you is, I want to show you the exact image of what is exactly happening to this patient. So now I'm going to start the endoscopy of this patient. और जब हम endoscopy करते हैं, so we use an endoscope and we go into and peep into the larynx. Now when I peep into the larynx of this particular lady, see, I'm putting the endoscope. Now this is the tongue of the lady. I'm going behind the tongue of the lady to enter inside into the laryngeal inlet. You would see this is the uvula which is hanging down. Beyond the uvula, you see this leaf-shaped cartilage which is coming up, which is the epiglottis. And finally, I enter into my laryngeal inlet just after that. Now, the moment I enter, you can see these two vocal cords which are coming together. Vocal cords always move together. So now you see one important finding. If you see, you can see these two bilateral symmetrical swellings on bilateral cords. You must have also noticed that these two cords are coming together and they are not completely closing. There is a kind of a gap that you can see in that. So what is exactly this is my question. So what I'm going to do is, I'm going to draw what I'm seeing over here so that it can help you out understand. What exactly I've shown you here is that let's say this is the circle. I have crossed my endoscope beyond the base of the tongue of the patient and I see a leaf-shaped structure which is called as your epiglottis. right? Now, behind the epiglottis, when I go into my laryngeal inlet, which you are seeing over here, let me just put it up for you, over here. So whenever you are seeing this kind of an image, you are seeing two vocal cords, and at the junction of the anterior 1/3 and mid 1/3 of the cord, I am having this kind of bilaterally symmetrical sessile swellings, which are less than 5 millimeters in size. And when these swellings are coming in between, and when my vocal cords are closing, now carefully see, can you see this? These are bilateral, they are whitish, they are symmetrical, and they are not allowing a proper closure of the cord. Now, if there is a vocal nodule, when your cords will close, they will close like an hourglass. And we call this as hourglass phonatory gap. We call this as hourglass shaped phonatory gap because there is a gap. Now, because there is a gap where the voice is leaking out, this particular thing will produce hoarseness. So maybe the lady is fine and now she says, my voice is not that good. And why is that? That is because she's becoming into a hoarse patient. This is called hoarseness of voice. Now, classical inka kya hoga? She's a school teacher. She uses her voice a lot. So by the end of the day, she will put a lot of force in order to make her voice good. मेरे अगर वोकल नॉड्यूल है मैं आपको क्या करूंगा मैं कोशिश करूंगा so that I can project out the best part of my voice. Now what will happen by the end of the day my voice will fatigue out. So they will worsen by the end of the day and they will have a lot of neck muscles which will pain because they are using their voices a lot. So whenever you see bilateral symmetrical swellings less than 5 ml, whitish, sessile. What do you mean by sessile? Sessile means that they have got a flat base. Flat base. And this is what is called as a vocal nodule. Now, it happens in teachers most commonly. That's why I gave you this particular question also, that this particular person has got, it's a teacher who's having this. So what exactly will be the most appropriate initial management of this patient? That is what I have asked you by showing that particular endoscopy. Now, what will you do in a vocal nodule is my question. Will you go for straight away excision of both the lesions by absolute voice rest for 2 weeks? Or you will go for voice therapy with vocal hygiene and measures of phonation or phonotraumatic behavior, or you will go for an endoscopic laser excision of bilateral lesions because it has a high risk of malignant transformation, या फिर आप oral corticosteroid therapy देंगे for 6 weeks and you repeat the video laryngoscopy afterwards. The rule of the book. Whenever you have got vocal nodule, the first and foremost thing is voice rest. क्योंकि the whole vocal cord is joining again and again. तो हो क्या रहा है? It is undergoing fibroblastic deposition. And because these fibroblastic depositions are not letting my vocal cords close, I need to stop speaking. So the first and foremost thing that you will tell this particular lady to do is nothing, but it is complete voice rest. After the complete voice rest, we will tell the person to maintain vocal hygiene. And what is vocal hygiene? Do not use your voice in smoky environments. Do not go out and speak in those surroundings जहाँ पे बहुत सारी automobile smoke होती है. At the same time, if you're a smoker, do not smoke strictly, right? At the same time, we'll tell the patient to have adequate hydration because your voice shouldn't go cracking or it shouldn't go bad. So you should have an adequate hydration also. You do not require surgery for vocal nodules. एक बात याद रखना, if I put a blade will lead to more fibroblastic proliferation and more scar tissue. More scarring worsens voice. That is why never ever use a surgery as a first time. 99% of the cases are treated by nothing, but they are treated by voice therapy with vocal hygiene measures and correction of phonotraumatic behavior. So obviously this is a singer's nodule, screamer's nodule, और मैंने आपको वीडियो दिखाया that how does that particular view look like. ठीक है, चलिए आगे बढ़ते हैं. Now let me go into my second case of the day. And now this case, once we have done the first case, now the second case of the day is about of a 45-year-old male who presents with progressive hoarseness since 4 months. 4 महीने से इस इंसान को progressive hoarseness है. Now he is a chronic smoker and he works as a salesman requiring prolonged voice use. That means he has a history of phonotrauma. Voice abuser है because he is a salesman. Now he recalls developing sudden hoarseness, one of the classical feature. वहां मैंने क्या बताया था? Hoarseness was gradual. 8 महीने की हिस्ट्री थी. यहां sudden hoarseness हुई after shouting loudly during a political rally, following which there is voice which never completely recovered. Now what is the video laryngoscopy finding? पहले हम लोग वीडियो देख लेते हैं so that we can understand what exactly has happened to this gentleman. So this gentleman has come to you and he has got a shouting history. And this particular gentleman, after you do an endoscopy, you see this kind of a following picture. So see again, what I'm doing, I'm passing my endoscope beyond the tongue. What you see this is a leaf-like structure. But see the difference what I told you from the previous one. Now you see the vocal cords coming up. You see both your vocal cords are white in color. You see both your vocal cords are white in color. The arytenoids are behind. And do you see something globular coming up? If you carefully see over here, if you carefully see, you can see a pedunculated mass which is moving in and out when the patient is breathing. This pedunculated mass is moving in, and see, it has got a stalk. If you see here, classically, this thing has a stalk over here. So let me just put it up again. So that particular thing, when it is looking like a stalk, that is nothing, but that is what exactly your vocal polyp looks like. See this, it looks like a stalk. And that stalk will move because you are inspiring and expiring and that stalk is moving. So what is the difference between a vocal polyp and a vocal nodule? Vocal nodules are sessile, they are bilateral, they are symmetrical, less than 5 mm. This is more than 5 mm, definitely unilateral. And it is having a stalk and it is pedunculated. Okay, fine. So this is something what exactly this vocal polyp is all about. The difference between a vocal polyp and a vocal nodule. अब इसको समझने के लिए आपको क्या करना है? I'll draw a vocal polyp over here for you. How do you differentiate a vocal polyp from a vocal nodule? Again, how to draw a picture? ये हो गया circle. This is your base of tongue. Then comes the leaf-shaped structure, which is nothing but your epiglottis. Now, you see the arytenoids behind. ये जो हमारी globular है, these are our arytenoid cartilages. And over the arytenoids are our vocal cords, which are attached. Now, the difference between a nodule and a polyp is, in a polyp, you will have a pedunculated unilateral growth like this. And that's what you are seeing. And where is it happening? It is happening at the junction of anterior 1/3 and mid 1/3. दोनों nodule and your polyp occur at a junction of anterior and mid 1/3. How? अगर आप अपने हाथों को बंद करते हैं, so that's how you phonate. When you breathe, you abduct your cords. When you phonate, the anterior 1/3 and mid 1/3 junction has got maximum friction. Now, because it has got maximum friction, it has got maximum phonotrauma. Now, if there is more phonotrauma, all your vocal cord pathologies maximum, which are related to voice abuse, happen at the junction of anterior 1/3 and mid 1/3 of the cord. So, iska classical point kya hua? What is a vocal polyp all about? So, if you see this video again, let me show you. This is the same kind of a thing which you will see protruding out. And you need to remember this. Again, see base of tongue, going behind, this is the epiglottis, which is a leaf-shaped cartilage. Behind, when I go to the epiglottis, I see my vocal cords. These are my arytenoids which you are seeing behind, which are closing. See, my arytenoids are closing, they are globular. And you see these both vocal cords, and on one of the vocal cord, you see that there is a pedunculated stalk containing a lesion, which is moving during inspiration and expiration. That is more than 5 mm and it is unilateral. अब हमेशा याद रखना, let's say I am an RCB supporter. I went to see a match. कोहली खेल रहा है. मैंने suddenly voice raise करी, कोहली, and I come with hoarseness of voice. Sudden hoarseness अगर हुई, they are usually pointing towards polyp because they are hemorrhagic. ये hemorrhage हो जाता है vocal cord में and they hang down like a lesion. So sudden hoarseness जहां मैंने बोला, it is likely to be this pedunculated lesion is a polyp. But जहां मैंने constant एक history दी 8 months, 9 months, bilateral, symmetrical, that is vocal nodule. Now, if I say vocal nodule की medical line of therapy होती है, my second question that will come to you automatically will be that what will you do in this case? इस केस में आप क्या करेंगे? What is the most appropriate management what you will do in a vocal polyp case? So the answer remains simple. If you take a vocal polyp, आप vocal polyp को कभी भी छोड़ नहीं सकते. It's a hemorrhagic polyp. It is moving during inspiration and expiration and it has a stalk. तो क्या हम इसे voice therapy या voice rest से ठीक कर पाएंगे? Answer है नहीं. We cannot. So what is the first line of management of a vocal polyp? It is different from vocal nodule. And here you need to go for a microlaryngoscopy excision of the lesion followed by post-operative voice therapy and vocal hygiene. तो हमें इसको निकालना जरूरी है. The reason being, I'll tell you a story about one of my patients. उसका क्या था? That patient came to me and he told me that sir मेरे ना hoarseness of voice है. मैं बहुत टाइम से मुझे समझ में नहीं आ रहा, मेरे आवाज नहीं सही हो रही, मेरी साफ नहीं हो रही. So you know, he came to me, I diagnosed him with vocal polyp. I told him कि you require a surgery. Now he said I don't have money. अब वो वापस चला गया. Now he said I don't have money. मैं क्या कर सकता हूँ? So he went. After some time, that guy coughed and coughed and coughed, and he came out and उसे एक अपना hanky खोला and there was a polyp. So he said, साहब ये तो अपने आप ही निकल आया, आप फालतू में मुझसे सर्जरी करवाना चाहते थे. So what is that called as? That's called as auto amputation. तो पॉलिप्स में बड़ा डेंजरस होता है that if you don't take them out microlaryngoscopy excision से, so they will keep rotating like this, they will keep moving, and because they have a stalk, that stalk might break. Luckily that patient got that polyp out of the mouth, but अगर वो नहीं हुआ, it will straight away go into the lung and the patient might aspirate. He will require a bigger surgery, that is bronchoscopy and removal. So don't ever leave it behind. Do a microlaryngoscopy excision, stalk को काटो and maintain the vocal cord mobility. दोनों vocal cords को बराबर से we maintain the edges so that the approximation remains better. ठीक है, fine. So this is about the difference between what is vocal nodule versus what is vocal polyp and how do they actually look like. चलिए, now let me move on to something more fun. Okay, तो एक एक करके we are going to see a lot of cases. This is how we read, right? Now this is something which was seen recently for FMG exam also, and that's why I took out one of my patients. So this is a 52-year-old female who underwent total thyroidectomy, and she underwent for papillary carcinoma thyroid, because obviously this is a very, very common thing that we do. Now on the second post-operative day, she complains of hoarseness of voice and occasional choking while drinking water. Flexible fiber optic laryngoscopy reveals the following findings that you see. So usually क्या होता है, thyroidectomy के बाद one of the common problems that usually happens to people is nerve injury. Now what happened here is that this lady came up with one of the findings where she has hoarseness immediately after surgery, and she came with occasional choking and aspiration of water. Now what exactly we saw in this case, so let me show you the laryngoscopy picture of this particular person. So let's say this lady came, and what I'm seeing over here, I want to see that how many of you can actually identify this particular thing. So this is the this is the laryngoscopy of that lady. Again, this is the base of tongue, right? Now, what you see here, this coming up is your epiglottis. You have crossed into the laryngeal inlet, right? Now, once that epiglottis comes, you go behind more. And now you see, I'll zoom up because this was a thyroidectomy which was done outside and the patient got referred to me. So what did I see now? Now see, one of the arytenoid has got a, it's kind of tilted. That means this vocal cord is not moving at all. And what I can see is only the opposite side cord is moving. एक cord नहीं चल रहा है, only the opposite side cord is moving. I'll zoom up more. See, this cord is absolutely straight. You can't see the cord functional. But see, the opposite side cord is trying to close as much possible. जितना कोशिश करके बंद हो सकता है, it is trying to close. I think this was one of the same questions they had asked in the FMG exam this time also. So देखो, this is trying to compensate to the glottic closure. What is this? Very nicely said. I think Parth has already said this is a recurrent laryngeal nerve paralysis. So this is very common post thyroidectomy. Or in cases में one of the cord will attain a position called as paramedian position. अब इसको पहले हम ना थोड़ा सा समझते हैं. What exactly is this all about? So let's read up about something about what is this chapter and how do you deal with these questions. तो मैंने आपको क्या बताया कि there is an important nerve which is called vagus nerve, right? Vagus nerve की दो important branches होती हैं that go into your larynx, right? One is called as superior laryngeal nerve, one is called as recurrent laryngeal nerve, okay? Superior laryngeal nerve की दो branches होती हैं, internal branch and external branch, okay? Now, one of the very important thing is that this internal branch of superior laryngeal nerve is the one which supplies sensations above a level of vocal cord. यानी जितना भी हमारा vocal cord के ऊपर के sensation है, that is supplied by the superior laryngeal nerve, internal branch. And the external branch is a motor branch which is supplying our cricothyroid muscle. And cricothyroid is an adductor and tensor of our vocal cord. Tensor and adductor of vocal cord कौन होती है? Cricothyroid muscle होती है. So let's suppose I'm talking to you like this. Suppose I'm talking to you like this. So what is my raise of voice? My vocal cords are getting stretched like a rubber band. Who's making me do that? That's my cricothyroid muscle. Because my cricothyroid muscle is here. तो यहाँ पे ये जब ये होगी, so I will go up in voice, right? That's why it's also called as singer's muscle. Because हम falsetto जो लेते हैं, that's because of the cricothyroid. Now, recurrent laryngeal nerve has got again two branches. Sensory branch and motor branch. Sensory branch and motor branch. Motor branch is the one which supplies all the intrinsic muscles of larynx. So all intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve except cricothyroid. क्यों? क्योंकि cricothyroid is supplied by the external branch of superior laryngeal nerve. Simple, right? And the sensory branch is going to supply below the level of the vocal cord. So this sensory branch is exactly ulta to the internal branch की supply of superior laryngeal nerve. Superior laryngeal nerve provides sensations above the level of the vocal cord, and this sensory branch provides below the level of the vocal cord. Maybe that is the reason the patient was choking, क्योंकि उसकी recurrent laryngeal nerve injure हो चुकी है, तो उसकी this motor supply and the sensory supply are all gone. That's why the patient is also choking, right? Okay, very nice. All of you are asking, very very बहुत बढ़िया. अब मैं यहां पे ना थोड़ा सा आपके लिए थोड़ी सी चीजें अबाउट कॉन्सेप्ट्स अबाउट दिस क्वेश्चन आई ड्रॉ आउट टू यू कि कैसे ये पर्टिकुलर क्वेश्चंस को आपको आंसर करना है. सो व्हाट आई एम टॉकिंग अबाउट इज दिस लेडी, राइट? तो दो टाइप की आपकी नर्व है, वन इज सुपीरियर लैरेंजियल, वन इज रिकरेंट लैरेंजियल. नाउ इफ योर रिकरेंट लैरेंजियल गेट्स इंजर्ड, still your superior laryngeal is working. If your superior laryngeal is working, the only muscle which is working in this patient is cricothyroid muscle. And cricothyroid is a tensor plus adductor of vocal cord. तो अगर कभी भी किसी भी इंसान के unilateral recurrent laryngeal nerve paralysis होती है, all the muscles are gone except cricothyroid. अब recurrent laryngeal एक ही abductor को सप्लाई करती है. The only abductor of the vocal cord is posterior cricoarytenoid muscle. And posterior cricoarytenoid, because it is the only abductor, it is also called as the safety muscle of the larynx, because if this gets paralyzed, things are gone. So now what will happen? There is a theory to this, and that theory is called as Wegener-Grossman hypothesis. And what is that Wegener-Grossman hypothesis all about? Wegener-Grossman hypothesis ये कहता है that if there is recurrent laryngeal nerve palsy, the cord will attain a paramedian position because of the unopposed action of cricothyroid muscle on the cord. यानी अगर एक तरफ की recurrent laryngeal nerve injure हो जाती है, till उस cord की superior laryngeal is working. And if superior laryngeal is working, one cord will attain a tensed and adducted position which is called as paramedian position. Paramedian मतलब the cord will be just like this, 1.5 mm away from the midline. और जो opposite cord है ना वो चलता रहेगा. The paralyzed cord will stay adducted and tensed. That's what I showed you there. That's exactly what Wegener-Grossman hypothesis states. अब देखो, फिर से देखो इसको. This is the same thing what you will see over here again. Now if you see this video, again I'm going behind the base of tongue, right? And if you see carefully over in this video, I'm going to show you something over here. What exactly you are seeing. This is again your epiglottis, right? The only muscle that is working is cricothyroid, क्योंकि उस तरफ की RLN injure हो गई है. Now, if you see carefully, this is your arytenoid and it is a little tilted because this cord is not working. And the opposite cord is trying to compensate to the glottic closure. It is trying to come as close as possible. That's what you are seeing here, right? Again, I'll go in. So let me go a little more in. Now I zoom up in. And now you see both the cords properly. Now what you are seeing, this is my paralyzed cord. See, it is in the paramedian position. And see the opposite cord, ये बाहर जा रहा है, and then it's coming inwards. So it is maintaining as much glottic closure it can. ये कोशिश कर रहा है. So now my question to you will be what? In particular cases को आप manage कैसे करोगे? How are you going to figure out what exactly is the management of these cases? So let me now go back to the question. So now you have seen the video laryngoscopy of this patient, and now what is the appropriate initial management I have asked you. आपको ये पता है एक cord paramedian है, but ये याद रखना है that it is just my second post-operative day. अभी 2 ही दिन हुए and the patient has been referred to you. Now, are you going to do an immediate injection laryngoplasty after 24 hours of all the patients with unilateral vocal cord paralysis? क्या आप तुरंत इंजेक्शन लैरिंगोप्लास्टी करेंगे? इसका क्या मतलब होता है? That you will inject something on the paralyzed cord so that it gets more medialized और opposite cord उसको ज्यादा अच्छे से क्लोज कर सके. That's called as injection laryngoplasty. इसे हम लोग medialization thyroplasty भी बोलते हैं. Medialization thyroplasty का क्या मतलब है? ये देखो, ये मेरा vocal cord है, ये दूसरा है, ये इसके पास आ रहा है. Now in order to aid a good closure, I am going to push this cord a little more in the center so that the closure is getting better. That's called as medialization of cord या फिर medialization thyroplasty. That's called as thyroplasty type 1 या medialization thyroplasty भी कहते हैं. What are you going to do? Are you going to immediately do that by using an injection? Injection में हम कुछ materials use करते हैं जैसे कि fat, hyaluronic acid, Teflon paste. Or you will observe with voice therapy for at least 6 to 12 months for spontaneous recovery. या फिर आप permanent medialization thyroplasty plan करेंगे 2 weeks after the surgery that you are going to go for an external approach and you are going to push it out. Or you are going to do a tracheostomy because of a unilateral recurrent laryngeal nerve injury commonly causes airway problems. what are you going to do? So my question to you is, have you seen the video properly? अगर आप ध्यान से देखो उस वीडियो को, तो ध्यान से उस वीडियो में आप क्या देख रहे हो? That the opposite chord अपनी पूरी जान लगा रहा है. Opposite chord is actually working everything out in order to compensate to the function of this chord. ये देखो, ये opposite chord almost आपका glottic inlet बंद कर दे रहा है. Almost. So there is a near normal glottic closure. Why will you want to do a thyroplasty? So the answer to this question will be that I will wait and watch and do a voice therapy. I will train my opposite chord to become a little more better in closure of. अगर मुझे ऐसा लगता that this chord is a little more away, improper glottic closure है, the chords are not approximating well, and कुछ 5-6 महीने हो चुके हैं of voice therapy, failed voice therapy, I would have still tried on doing a thyroplasty. But on the second post-operative day, I have no emergency in doing a thyroplasty. कि मुझे medialization नहीं करना है, I've got a fairly good compensation, why should I even do it? Or why should I even try? That's where you need to decide. तो इसीलिए इसका आंसर क्या होगा? The answer to this question will be that this particular patient should be dealt only by observation and voice therapy. और आपको कुछ नहीं करना है. You just have to do an observation with voice therapy. Now, only thing is, if it would have been more than 6 months, or there would have been an improper glottic closure कि उसे नहीं हो रहा है, और या फिर the patient is found to be aspirating a lot. Aspiration positive है patient में. So in cases में I would have done medialization thyroplasty, and that is called as type 1 thyroplasty. Medialization is type 1. सेंटर में ले आते हैं. ठीक है? हेल्दी कॉर्ड को कोई इंजरी नहीं होगी ओवर कॉम्पनसेशन से. ओवर कॉम्पनसेशन डज नॉट कॉज एनी, इट्स अ फिजियोलॉजिकल प्रोसेस. वो आपका खुद ही वो ट्रेन हो रहा है. यू आर नॉट हैविंग एनी काइंड ऑफ ट्रॉमा ओवर द कॉर्ड. ठीक है, दे आर वाइब्रेटिंग, दे आर कमिंग टुगेदर, देयर इज नो प्रॉब्लम एट ऑल टिल योर बॉडी कैन मैनेज इट. ठीक है, सो आंसर वुड बी डी ओवर हियर. बट अगर ये 6 महीने से ज्यादा होता, आई वुड हैव रिटन हियर 6 महीने से ज्यादा होता, इट वुड हैव कॉज प्रॉब्लम्स, देन आई वुड हैव गॉन. सेकंड पोस्ट ऑपरेटिव डे, नो नीड. चलिए, तो ये खत्म हुआ अबाउट द डिस्कशन ऑन रिकरेंट लैरिंजियल नर्व एंड इट्स एसोसिएटेड प्रॉब्लम्स. अब आ जाओ into the next question. So you have got a 58-year-old man presents with progressive hoarseness of voice for 6 weeks. He's a known case of bronchial asthma on long-term inhaled corticosteroids. Again, classical key pointer. Long-term asthma है, इसकी वजह से patient has been taken corticosteroids. Poorly controlled diabetes mellitus. That is my second clue. Now, he denies any smoking, dysphagia, neck swelling or weight loss. No other history which could suggest that it is going into malignancy. क्योंकि weight loss, neck swelling, खाना difficulty होना, that is all smoker, that is all something, right? That is all something that you see over in malignancy. But यहाँ पे देखो keyword, buzzword क्या है? Corticosteroids, diabetes mellitus. तो मेरी कुछ कहीं ना कहीं कुछ hint जा रही है, right? Now, he denies smoking, dysphagia, neck swelling. The following video laryngoscopy is shown to you. So let me show you कि इस particular patient की video laryngoscopy क्या है. So now this is a picture of the video laryngoscopy of this patient, and let me play it for you. So this is one of my recent cases who has just come, and what you see over here. So what you see over here is something that is extremely critical. Now, see, we are going into the glottic inlet. I have crossed my epiglottis. And once I cross my epiglottis, I see my laryngeal inlet. क्या दिख रहा है आपको laryngeal inlet में? Inside your laryngeal inlet, you see these kind of whitish plaque. देखो white plaque type के दिख रहे हैं, whitish अजीब type के गंदे गंदे plaques दिख रहे हैं. What is this irregular plaque-like thing? What is white inside a larynx? White inside a larynx can be a lot of things. So see this again. Again, I will tell you. See this again. You cross over through the larynx, and inside the larynx, what you are seeing. Let me draw it for you. Inside the larynx, what you are seeing is some kind of a picture like this. So this is your base of tongue, leaf-shaped epiglottis. And यहाँ पे देखो गौर से, what you are seeing here, let me draw the arytenoids, and these are your vocal cords. And here, you are seeing something which is kind of whitish plaque-like. Whitish plaque-like things you are seeing over the vocal cords, and they are almost on both the vocal cords, right? Okay. So now, what exactly is this? Very nicely said. Keratosis is one of the differential diagnosis. Curdy-white, probably candidiasis. Beautiful, very nice answers. I'm very happy. So, अगर मैंने आपको ये बोला कि what you are seeing inside there are many differential diagnosis to white patch. बहुत सारी चीजें हो सकती हैं. Now white patch, I'll tell you first the differentials की क्या क्या हो सकता है. Two of the answers are already right. That one could be candidiasis, क्योंकि it is curdy white. Why I will go with candidiasis more? Because I gave you a history of immunosuppression. दो चीजें मैंने बताई. क्या बताया मैंने? मैंने ये बताया that patient has long term usage of steroids. Inhaled corticosteroid में सबसे कॉमन क्या होता है? Fungus. So your answer towards this lesion will become fungus. Second thing I told you, diabetic. Diabetic also, fungus loves to breed on diabetes. So this also favors my question. That is point number one. Now second could be keratosis. Keratosis is a pre-malignant condition of the larynx. इसमें भी keratotic plaque बन जाते हैं. Third differential diagnosis हो सकता है ये pre-malignant condition हो like leukoplakia. Even oral cavity के अलावा it could be leukoplakia of the vocal cords. Right? और क्या हो सकता है? Sometimes even in cases of laryngopharyngeal reflux disease, बहुत ज्यादा reflux अगर हो रहा है, GERD अगर ऊपर larynx तक आता है, it could create such kind of whitish lesions which is called as LPRD, laryngopharyngeal reflux disease. That also could be one of the possibilities. Even this could be early carcinoma. I can call it carcinoma in situ. It could be an early carcinoma which is there. So these are the main ones. बहुत सारे होते हैं but ये main है. आपको क्या ध्यान रखना है? अगर मैं बोलता smoker or this patient has got voice change, not improving with medical line of therapy, I would have gone towards the pre-malignancy side. But now what I am telling you is this is a curdy white thing. Now watch this again, because I want you all to get accustomed to these kind of videos. Now see, again, base of tongue, epiglottis, jumping inside. Now once I take my endoscope inside, you see these globular arytenoid cartilages. See, ये पीछे वाली दो arytenoid. And now you can see these white vocal cords. Now what are you seeing over here? This is something a curdy white and it is diffuse and curdy. So again, very nice, already told, candidiasis, corticosteroids, DM, poor immunity, curdy white. So this is something which gives me, and you see, both my vocal cords are still moving. अगर ये कैंसर होता तो vocal cord mobility impair हो गई होती, अगर इतना बड़ा कैंसर अगर हो गया होता तो vocal cords are not having any impaired mobility. I'll show you cancer का video, then you understand उसमें कुछ दिखता ही नहीं है. So this is candidiasis, this is fungal. So what exactly my question to you here is that when you see this question, what are you going to decipher out? What exactly is this question? Which of the following is the most likely diagnosis of this patient they have asked? So आपको क्या लगता है? What is the diagnosis? So I've already told you. The most common thing, if you have a steroid and if you have DM, then it purely goes towards the diagnosis of, again, laryngeal candidiasis more. ठीक है? तो यह आंसर हो जाएगा इसका laryngeal candidiasis का. And now we are moving on to the fifth important laryngoscopy and fifth important question as to what exactly do you see over in this patient. Question number 5. 42-year-old woman आई आपके पास, presents with persistent hoarseness again, because larynx में सबसे common यही होता है. Throat discomfort, frequent throat clearing. Throat clearing का मतलब क्या हुआ? ये करना बार बार, repeated throat clearing. And a sensation of a foreign body in the throat for 8 weeks. So 8 weeks is not very long, but yes, roughly around 2 months. She underwent prolonged, one history I gave you, underwent prolonged endotracheal intubation for 12 days following polytrauma 3 months ago. So she has an endotracheal tube insertion history for her polytrauma 3 महीने पहले. Now, there is no history of smoking or alcohol use. तो अगर मैंने smoking alcohol नहीं दिया है, I take myself away from malignancy. But अगर मैंने ये endotracheal intubation की history दी है, there has to be something in my mind about it. That is catch point. Now, the following video laryngoscopy is shown to you. So let me first show you the video laryngoscopy. Now, this was again one of the interesting cases that I got some time back. And what does it show? So ये वही endotracheal intubation करने के बाद patient had this hoarseness of voice. And now when this patient came, see again base of tongue पीछे जाके. Now this is your epiglottis. I've gone inside into the laryngeal inlet. Now what you're seeing inside, right? Quite red. That means this is a congested larynx. Congestion काफी है. But यहाँ पे देखो vocal cords are coming together. But can you see this small kind of a hump in the posterior 1/3 of the cord? Can you see this? Posterior 1/3 of this cord has got some kind of a hump over it. So let me just take directly over here. Now see carefully. Can you see this? Can you see this kind of a growth at the posterior 1/3 of the cord? Now what is that 1/3 of the cord? Posterior 1/3 of the cord पे ये क्या दिख रहा है? ये cord ठीक है, पर ये cord देखो. You can see this kind of a growth at the posterior 1/3 of the cord. What is this posterior 1/3 of the cord? And I have given you an endotracheal intubation history. तो ये क्या है? What is this? So this is something, let me tell you now. So now let me go into and explaining this case to you. So this was very, very interesting. And let me now draw the picture for you. Again, if I draw this laryngoscopy picture, this is your base of tongue, right? And this is your epiglottis. And behind the epiglottis, you are seeing your arytenoid cartilage, right? And these are your vocal cords. But what I have told you that on the right side, you are seeing something more. And on the right side, you are seeing a kind of a tissue over on the posterior 1/3 of the cord. Now, posterior 1/3 of the cord, if I say anything, now see again, if I show you again, do you see anything on the anterior 1/3 of the cord over here? Do you see anything over on the anterior 1/3 of the cord over here? See this. Cords are closing, cords are opening, cords are closing, cords are opening. But what do you see on the posterior 1/3? The only lesion which can occur on the posterior 1/3 of the cord is what? Not laryngeal edema, not laryngeal ulcer. This is called as an intubation granuloma. This is called as intubation granuloma. So जब मैंने आपको intubation की history दी, whenever the person is getting intubated ना, so endotracheal tube हमेशा जब भी जाता है, so the endotracheal tube is always inserted from the posterior 1/3 of the cord. Endotracheal tube touches the posterior 1/3 of the cord and it goes inside into the trachea. Rinkies edema भी नहीं, मैं दिखाऊंगा सारे. So when you are touching your posterior 1/3 of the cord and going in, तो क्या होगा? There will be heaps of granulation tissue. And that granulation tissue which will form over on the posterior 1/3, उसे हम क्या बोलेंगे? उसे हम बोलेंगे intubation granuloma. This is the most important fact. तो अगर मैंने आपको कभी भी ये हिस्ट्री दी, whenever I give you the history, so this is what, this is your intubation granuloma. This is your intubation granuloma. Let me just mark this up. This is intubation granuloma. And always remember one thing, that it will always occur on the posterior 1/3 of the cord. ये हमेशा posterior 1/3 पे ही होगा. Anterior 1/3 और 2/3 पे सिर्फ vocal nodule, polyp और ये सब होते हैं. But this is हमेशा posterior 1/3. Why? Because when you intubate the patient, it rubs off the posterior part of the vocal cord. And when it is rubbing the posterior part of the vocal cord, अगर prolonged intubation है, repeated intubation history है, then it is classically going to cause granulation tissue, because granulation tissue healing tissue होता है, and that heaps out over on the posterior 1/3. That gives an intubation granuloma. So if this is present, your cords will not close properly. If they won't close properly, there will be leakage of air that will cause hoarseness of voice. Okay, that's how the linkage is. Now coming to what exactly they have asked you on this question is that हम इसमें करेंगे क्या? You have seen which of the following. So I gave you prolonged endotracheal intubation for 12 days intubation था, right? Now what will be the following most appropriate initial management of the patient? Should I take up the patient for the first line microlaryngoscopy excision? या मैं इसे पहली सर्जरी के लिए ले लूं? Proton pump inhibitor पे start करूं, voice therapy दूं, and I give a short term steroids? Should I go for external beam radiotherapy because it is highly likely to be a malignant? Or we should do a type 1 thyroplasty to improve glottic closure? तो क्या करेंगे हम? What should we do? Okay? What should we do? क्या करें? ठीक है, I am very happy that you guys are enjoying. Very nice. चलो, तो देखो, सोचो, क्या करोगे? This is how your patients are. ये ऐसे ही आएंगे आपके लाइफ में patients. तो इसमें always remember, never ever jump into excision. हमेशा जितना एक्सरसाइज करोगे उतना स्कार बनेगा. जितना स्कार बनेगा उतना ज्यादा vocal tissue will cause fibrosis and that will lead to a worsened voice. So in this case, what we will do? We will first wait. Now there is a reason why we are giving all these drugs. Granulation tissue, healing tissue होता है, वो subside कर जाता है. If we stop the trauma, then definitely that tissue will heal away on its own. So what we are going to do? We are going to start proton pump inhibitor. क्यों देंगे proton pump inhibitor? क्योंकि the reason being, ट्रेकिया के पीछे esophagus है. If the patient is going to have repeated GERD, that acid is going to bathe the posterior part of my vocal cords, and microaspiration की वजह से वो part में granulation बनता रहेगा. That is the reason I'll give the patient short-term proton pump inhibitors to control acidic reflux. I don't want that क्योंकि granulation ज़्यादा बनेगा अगर acidity है. Second, voice therapy दूंगा. I don't want the patient to undergo unnecessary excision. So I'll try कि उसके vocal cords दोनों better हो जाएं, close better करें, and I'll give voice therapy. Very good. And the third is short-term steroids. अब ये जो short-term steroids है, ये granulations को कम करता है. So we can even give inhalational steroids or we can give oral steroids. They usually get down the granulation tissue formation क्योंकि steroids हमेशा fibroblastic proliferation को कम करते हैं. So again, fibroblastic proliferation decreased, this lesion will also decrease in size. And that's how we treat this particular condition. So the answer would become, you start on a more conservative approach. अगर मैं ये बोलता that this is something which is continuing even after medical therapy, then what we would have done, we would have straight away gone for an excision. Medical therapy fails अगर मैं बोलता, we would have straight gone for an excision. ठीक है, fine. चलिए आगे बढ़ते हैं. Now we come to the next question. Now this is another interesting case. Question number 6. 54-year-old man presents with progressive hoarseness of 3 months associated with odynophagia, chronic cough, evening rise of temperature and a 7 kg weight loss. Now see, this is classical. 7 kg weight loss हुआ है, evening rise या night rise of temperature है, chronic cough है and 3 month associated difficulty swallowing है, painful swallowing, odynophagia है, right? Now, he has been treated twice with antibiotics without improvement. That means this person is not improving with your antibiotic therapy. So for obvious reasons, that is something not associated with bacterial infection. He has no history of smoking or alcohol abuse. That means that rules out malignancy also. Somehow. हो सकती है, but somehow. Right? Now, the following video laryngoscopy is shown to you. ठीक है? Usually the treatment that we give is around about for 2 weeks. Short term 2 weeks. ठीक है? तो ये video laryngoscopy है of the patient. And what do you see over on this particular person? Now, this is very, very interesting that I got some time back. And I'll show you. What is this? See, epiglottis has become extremely bada. Edematous हो गया. This doesn't look like a leaf. And can you see this larynx is completely dirty? Dirty in the sense छोटे-छोटे nodules बने हुए हैं. ऐसे लग रहा है ना somebody has bitten the larynx and gone away. You can't even see the vocal cords properly. Now see again. See, everything is so, you know, everything is distorted. Vocal cords move कर रहे हैं because you can see inside the movement is happening, but everything seems to be dirty. I always call this as a dirty larynx. Now what exactly does this mean? इस हुआ क्या इस इंसान को? So I told you, अगर आप इसको retrospect में सोचें, chronic cough, maybe hemoptysis, weight loss almost of 7 kgs, which is quite significant, and this patient has odynophagia. तो ये एक classical laryngeal tuberculosis का केस है. Very nice. Mouse nibbled appearances. This is actually a mouse nibbled appearance. ठीक है? So what exactly do you understand by this? This is called laryngeal tuberculosis. Beautiful answers you guys are giving. So now, see, this is your picture जो मैं बना रहा हूँ. This is your again base of tongue, okay? And this laryngeal tuberculosis में the whole epiglottis becomes edematous. Now this is the first sign of laryngeal tuberculosis, and this is called as what? ये edema of epiglottis is called turban epiglottis. Turban की तरह. This is called turban epiglottis. Trust me, this is very, very rare to see. Okay? This is turban epiglottis. Now what else do you see? You see arytenoids, and arytenoids के ऊपर you'll see small nodules. तो ये arytenoids के दोनों के बीच में ये छोटे-छोटे nodules होंगे. We call them as interarytenoid mammillations. Mammillation का मतलब क्या होता है? Mammillations means nodules. So between those arytenoids, you will see raised nodules called as interarytenoid mammillations. And over your inside part of the larynx, you will see dirty ulcers. And these ulcers look like कि कोई rat आया या mouse आया and it nibbled the larynx and went away. So they are called as mouse nibbled appearance of vocal cords. Mouse nibbled appearance of the larynx. Now, with the same finding, I want you guys to again see this video. Again, watch. See, can you see an abnormally big edematous epiglottis? इसे मैंने बोला turban epiglottis. Now see, these arytenoids are bulky and देखो इसके ऊपर ये red, white ये. These are your raised nodules called as interarytenoid mammillations, and inside it looks like somebody has bitten your vocal cords and gone away. So this is classical dirty larynx picture, and this is always towards TB laryngitis, yeah, tubercular laryngitis. Okay, and these are the signs of tubercular laryngitis. Always remember, extremely rare to find, but common in India who have untreated pulmonary tuberculosis. क्योंकि जो tubercle bacilli होते हैं, they keep coming up in cough, and when the patient will keep coughing, those tubercle bacilli will start invading these tissues. क्योंकि ये पीछे से आती है cough, and when they invade these tissues, you will classically see these kind of pictures, which is a classical case of tubercular laryngitis. चलिए, now let me show you the same question now, and I have asked you what? That you have seen the video laryngoscopy now. Yes, 7 kg weight loss, odynophagia, chronic cough, evening rise of temperature. ये TB की तरफ ही ले जाता है. Never ever in tuberculosis, the patient will become better with your antibiotics. They will never ever treat the patient. Right? Okay? So that is the reason now your antibiotic therapy has failed. So what will you give? What will you do the next management by? So obviously, we never ever touch and excise out TB lesions. The only thing we need to do is what? We need to obtain a histopathological testing for mycobacterium and we need to start our anti-tubercular therapy. But before starting ATT, the protocol says that we need to take a small biopsy, prove that it is TB laryngitis because it is a diagnosis of exclusion. Exclude karna hai diagnosis ko. So we need to take a diagnosis of exclusion and we need to rule out any other thing. So we send the sputum for culture, we send CBNAT testing, and we take a biopsy of the tissue for mycobacterial testing, and then we start the patient on anti-tubercular treatment. So this is very, very common. One of the studies I'm working on currently is this over on laryngeal tuberculosis, and luckily I've found some cases who have got extremely, book findings. This is how the dirty larynx looks like. So this is how exactly a TB laryngitis. हमेशा याद रखना, this is the whole idea. ये बहुत close होता है to malignancy, but malignancy में smoking alcohol दिया जाएगा. That's what is the whole idea. Okay? चलिए, मैं दिखाता हूँ आपको कैसा दिखेगा वो. Now let me come to this question number 7. Okay, now question number 7 says a 46-year-old man has presented to you with progressive hoarseness for 8 months. यानी 8 months लंबा time होता है. It's a long time for 8 months. He denies dysphagia or weight loss but reports recurrent episodes of voice deterioration despite undergoing 2 previous endoscopic surgeries elsewhere. That means this man has got a history of excision of some lesion inside the larynx. कुछ ना कुछ larynx से excise पहले किया है. That's what exactly that's what exactly this is, right? Now, he is a non-smoker. That means I have got ruled out malignancy. He does not have a history of prolonged intubation, जिससे intubation granuloma भी rule out होता है. तो मेरे पास एक इंसान है 8 months की history के साथ with hoarseness of voice with no other complaint but 2 previous surgeries done. That's what is the only thing. The following video laryngoscopy is shown to you. So now I am going to show you a video laryngoscopy of this particular gentleman. This is some time back. This is a case which I operated on some time back, and I'll show you. This was the classical history of this particular patient. Now see, I went inside, crossed the epiglottis, right? Can you see this vocal cord looks fine? Can you see a kind of a papillomatous growth over this cord? ये जो एक दिख रही है ना, ये पॉलीपॉइडल टाइप की ग्रोथ दिख रही है. ये बिल्कुल अजीब सी पॉलीपॉइडल है. मतलब इट इज नॉट एज बैड एज अ कैंसर. कैंसर में वोकल कॉर्ड चलना बंद कर देते हैं. But this looks like a little more polypoidal type of a lesion to me. So this is a confusing lesion definitely. So I see over one of the vocal cords there is a kind of a polypoidal type growth. But both the vocal cords are almost closing. What comes in my mind? Beautiful answer. Recurrent मतलब papillomatosis. Recurrent का मतलब ही है, इसका नाम ही है recurrent papillomatosis. So when this guy came to me to show, that was the particular point of time, he gave me a history. So I had somewhere in mind maybe, उसके पास कोई document नहीं था. Problem was that he got operated from some other people. So now he didn't have any page. And half of the people in India don't have any documentation. तो हुआ क्या? I have to figure out by seeing the polypoidal lesion, recurrent history goes towards recurrent papillomatosis because they are recurrent lesions. तो होता क्या है? Let me just show you over the diagram also ताकि आप लोगों को याद रहे ये मैंने क्या बनाया था. So again, this is your circle, this is your base of tongue, this is your epiglottis, right? And you have got your arytenoids. इनका कोई problem नहीं है. Over the vocal cord on one side, you see a kind of a reddish papillomatous lesion. This is an adult papilloma. This is an adult papilloma. So see the whole soul criteria I'm giving you. If I say whenever they are recurrent lesions, gone under endoscopic surgeries again and again, now they are papillomatous growths which are present over the vocal cords. Patient comes only with hoarseness of voice, non-smoker, non-alcoholic. Your answer shouldn't go towards malignancy क्योंकि alcohol smoking की history देंगे malignancy में. So this is something where it is more commonly associated with HPV, right? So अब मेरा question आता है ये क्या होता है? So papillomas are of 2 types. बच्चों में होता है juvenile onset recurrent respiratory papillomatosis जिसे कहते हैं JORP, और adults में होता है adult papilloma. Now if अगर बच्चा आता आपके पास, unfortunately I don't have the video to show you right now, अगर बच्चा आता आपके पास तो बच्चे में you would have seen multiple papillomas all about. जैसे आपको ये vocal cord पे दिख रहा है ना, you would have seen this kind of a polypoidal lesion all throughout the larynx. So that is why इसे juvenile onset recurrent respiratory papillomatosis कहते हैं, क्योंकि ये बच्चों में होता है, ये recurrent होता है और ये multiple होते हैं. They are multiple of them. And adult are usually solitary lesions. They happen over one of the vocal cords. तो क्योंकि ये सॉलिटरी है, सो दैट इज व्हाई दिस रेंजेस आउट टू बी एन अडल्ट पैपिलोमा, राइट? नाउ अनदर इंपॉर्टेंट क्लू, हु कॉजेज दिस पैपिलोमा? तो पैपिलोमा मींस ह्यूमन पैपिलोमा वायरस. तो ह्यूमन पैपिलोमा वायरस इज समथिंग जो बहुत ही एपिथेलियोट्रोपिक वायरस है. एचपीवी एक ऐसा वायरस है विच लव्स एपिथेलियम एंड इट इज एन एपिथेलियोट्रोपिक वायरस. मतलब ये एपिथेलियम प्यार करता है. वोकल कॉर्ड्स का अपना एपिथेलियम है. इट गोज इनसाइड द सेल्स एंड इट एंटर्स इनसाइड द सेल एंड स्टार्ट्स मल्टीप्लाइंग. तो ये क्या करेगा, लेट्स से ये मेरा वोकल कॉर्ड है, तो यहां से अगर मैंने निकाला, इसकी ये लाइनिंग है, तो ये क्या करेगा, इट विल एंटर इनसाइड द सेल एंड इट विल स्टार्ट मल्टीप्लाइंग विद इन दीज सेल्स. एंड आफ्टर सम पॉइंट ऑफ टाइम व्हेन इट स्टॉप्स मल्टीप्लाई, मतलब व्हेन इट कीप्स मल्टीप्लाइंग, ये ग्रोथ की तरह प्रोड्यूस करेगा एक लीजन एंड दैट लीजन विल बी कॉल्ड एज अ पैपिलोमा. नाउ देयर आर टू सेट्स ऑफ वेरिएंट्स ऑफ एचपीवी. एक होते हैं हाई रिस्क वेरिएंट्स, एक होते हैं लो रिस्क वेरिएंट्स. High risk variants of HPV are 16 and 18 and low risk variants are 6 and 11. 6 and 11 are usually the cause for papillomas and warts. So genital warts, papilloma, ये सारे 6 and 11 cause करते हैं. They are usually non-carcinogenic. But अगर 16, 18 HPV आया है, it has got the maximum predilection to form cancers. 16, 18, 31, 33, 41, 45, ये सारे strains जो हैं, they cause more malignancy. पर 6 and 11 are only for papillomas and genital warts. Now, if you get a child who has multiple papillomas, and I ask you iska reason kya hai, then usually the reason is always vertical transmission through the mother. The mother has got genital warts and the baby is coming out through normal delivery. Genital warts mein the baby is coming out through vaginal canal, so obviously the HPV enters into the larynx and that HPV sits in the baby and grows with time. So vertical transmission from the mother to the child during delivery, normal delivery, is basically the measure of how this juvenile papillomas happen. But when I say what is exactly the adult papilloma cause, it is basically orogenital sexual contact. So this is why this has become one of the leading papillomas, is one of the leading things which we are seeing in the United States these days. Tonsillar malignancies and papillomas, these are the most common which happen because of this. And that is why, because HPV can be taken up by these epithelial cells and it grows. Remember always, आपकी जो immunity होती है, it is good enough to erase out HPV. Almost every person in this earth has got some or the other chance of HPV infection because it's very, very common virus. But आपकी immunity उसे clear कर देती है. But in some cases where the immunity is not good, immunosuppressed state, rural population, poor hygiene, lack of good nutrition, what will happen? They will activate and they will cause these kind of lesions. Okay, fine. So this is something that you guys should remember about what exactly is HPV all about. That is why HPV is one of the leading causes of head and neck cancers nowadays. Smoking se zyada we see head and neck cancers because of HPV in young adults. That's what is the rising incidence now. So what I've asked you, which of the following is the most likely etiological condition for this patient? अब बताओ, मैंने क्या बताया था कि 6 and 11 are the most common causes of forming this papilloma and 16 and 18 are the ones which are causing more malignancy. So the answer here will become most common is 6 and 11. अगर मैं बोलता which of the following strains is most likely to become malignant into, तो आपका आंसर होता 16 and 18. Now my question is, how will you treat this guy? Because he has got recurrent lesion, तो अकेले सर्जरी से काम नहीं होगा. So what we will do now in this case is something that is called as ABC approach. ये बड़ा simple सा mnemonic है, I'll tell you. Now what is this ABC approach? So A stands for alpha interferon therapy, which boosts up the immune system and also it is good for counteracting HPV virus. Second is a newer drug, एक monoclonal antibody launch हुई है, which is again favoring against HPV and that's called as bevacizumab. So bevacizumab एक monoclonal antibody है which we inject directly inside these lesions. And the third is cidofovir. Cidofovir is an antiviral agent. ये question पूछा भी गया है. Now this can be given either by oral route or we can even give it by intralesional injections. So we can inject over wherever we are sending it, right? Now, after definitely with this, we have the answer of laser excision. तो इसके साथ we do laser microlaryngeal excision. Now, very, very important. लेजर करते समय HPV comes in fumes. एक बात याद रखना, लेजर जब भी हम लोग लगाते हैं, तो लेजर से फ्यूम निकलते हैं. लेजर के जो फ्यूम निकलते हैं, that's called as plume, PLUMES. तो लेजर के फ्यूम्स आर कॉल्ड एज प्लूम्स, और अगर सर्जन ने प्लूम इनहेल कर दिए, दे कैन गेट दैट वायरस डायरेक्टली इनटू देयर रेस्पिरेटरी ट्रैक. सो वी नीड टू बी वेरी केयरफुल. दैट्स व्हाई इन दीस केसेस हमें गॉगल्स, आई गेयर, पूरे मास्क, double clothing, we all have a full packed thing so that we don't get accidental inhalation of HPV when we are operating, because a lot of fumes are created during plumes are created during the surgery. याद रखना, this is something where we do a laser excision. Okay, that's it. तो इतना बात आपको याद रखनी है about what exactly is this HPV all about. चलिए, now we move on to the next patient. Now we have finished about question number 7. Okay. Now we move on to the 8th clinical scenario, okay, and this is about a 58-year-old woman who presents with gradually progressive hoarseness for 2 years. 2 years, देखो 2 साल की hoarseness है, and she has 40 pack year smoking history, long smoking history, woman smoker, think, woman smoker. Complains of her voice has become unusually deep and husky. Now always remember, woman talking like a man. So we have got our vocal cords, right? Vocal cord जो होते हैं, women have got more lengthier vocal cords, उनके थोड़े tightly stretched होते हैं. Males have got shorter vocal cords. Testosterone is important in males to bulk the cords. अगर male में testosterone ज्यादा है तो obviously cords will become bulky during puberty. आपने suddenly देखा होगा आपकी voice change होती है, right, during puberty. So male की voice certainly baritone हो जाती है, change हो जाती है. Why? Because testosterone की वजह से the cords become bulky. Females on the other hand have got more thinner cords. That is why females have got higher pitch. Males have got deeper pitch. What exactly has happened to this lady? This lady has a man-like voice. Deep, husky voice. And she denies any kind of dysphagia, odynophagia, hemoptysis, weight loss. Now my primary thing is, never ever go by आंख बंद करके 40 पैक ईयर है तो malignancy पूछेंगे. क्या malignancy 2 साल की हिस्ट्री लेकर आएगा? नहीं. Malignancy will be 3 month history, 2 month history. इतना दिन 2 साल कोई malignancy wait नहीं करेगी. It will spread into 10,000 places. So now I'm going to show you what this lady has got, right? Let us go now into this lady's video laryngoscopy. और देखो, now when I see the video laryngoscopy, this is classical. Vocal cords देख रहे हैं कितने बड़े-बड़े, they have become heavy. They are closing well, but can you see these vocal cords have actually become very, very bulky and heavy. Normal से double हो चुके हैं vocal cords. Now when I say when these vocal cords have become double and heavy, what does that mean? This is a classical case of Rinke's edema. Rinke's edema. See, there is no lesion over the vocal cords, just the vocal cords appear to be enlarged and bulky. Enlarged and bulky, and they are all throughout the length बड़े हो गए. And this is how Rinke's edema looks like. We also call this as smoker's larynx. Right? That's how Rinke's edema looks like. Now, what is this Rinke's edema? पहले तो इसका नाम देख लेते हैं कि इसका मतलब क्या है. तो पहले मैं इसमें आपके लिए एक डायग्राम बना देता हूं, तो how to draw or how to understand Rinke's edema. So let's say this is your larynx, और larynx में अंदर हम लोग गए. This is again your epiglottis. अब आप लोग आइडेंटिफाई करना जान चुके हैं कौन से स्ट्रक्चर्स क्या हैं. And this is your arytenoids. And you see these are your vocal cords. But here the vocal cords have got something strange. They look like kind of बड़े-बड़े bag of water. This is called as bag of water appearance of vocal cords. And this is a classical case which is seen in cases of Rinke's edema. Rinke's edema. So let me show you that bag of water again so that you can classically remember it. See this. दिख रहा है ये edema पूरे cords में like a bag of water. ऐसे लग रहा है पॉलिथीन बैग में किसी ने पानी भर के ऐसे अंदर लगा दिया है. So this is a classical bag of water appearance which you are seeing, and this is classical for Rinke's. All throughout the length they are enlarged, right? अब ये all throughout the length enlarged क्यों है, and why this bag of water appearance happens? This is important. Now, vocal cord की 5 लेयर होती हैं that you should remember. If I take a piece of this vocal cord out, let me just say कि मैंने इस particular vocal cord का एक piece बाहर कर दिया. Okay? So I've just taken out one piece of the vocal cord and I'm going to zoom up on that. Now, if I take a piece of this vocal cord out, vocal cord की innermost layer is called as a muscle called as vocalus muscle. Vocalus muscle के ऊपर there is a layer of vocal cord, and this layer of vocal cord is called as deep lamina propria. Above the deep lamina propria is another layer of vocal cord called as intermediate lamina propria. Above intermediate lamina propria there is another layer called as superficial lamina propria, and above superficial lamina propria there is our vocal cord का epithelium. ये होती है, these are the 5 step layers, और इसे हम cover and body theory भी कहते हैं, right? इसे हम cover and body theory भी कहते हैं. कवर एंड बॉडी थ्योरी का मतलब वोकल कॉर्ड की एक बॉडी होती है जो वाइब्रेट करती है और उसके ऊपर एक कवर होता है। तो बॉडी जो वोकल कॉर्ड की होती है दैट इज बिकॉज ऑफ वोकैलिस, डीप लमाइना प्रोप्रिया एंड इंटरमीडिएट लमाइना प्रोप्रिया, यानी ये मेरे वोकल कॉर्ड की बॉडी है। नाउ दिस इज गिविंग द मैकेनिकल सपोर्ट टू द वोकल कॉर्ड टू वाइब्रेट। और मेरा जो कवर है दैट कवर इज द वन विच इज वाइब्रेटिंग ओवर द स्टेशनरी बॉडी। मेरी वोकल कॉर्ड की जो कवर है दैट इज द वन विच इज क्रिएटिंग अ म्यूकोजल वेव एंड दैट इज वाइब्रेटिंग, एंड द कवर इज सुपरफिशियल लमाइना प्रोप्रिया एंड एपिथेलियम। The other name for this superficial lamina propria is also called as Rinke's space. इसे हम Rinke's space भी कहते हैं. So it was a scientist. His name was Frederick Berthold Rinke, and he was the first one who actually saw this, and that is why it is called Rinke's edema. अब होता क्या है? In this superficial lamina propria, there are a lot of small blood vessels. अगर कोई भी लेडी बार बार स्मोक करेंगे तो स्मोकिंग कॉजेज फ्रेजिलिटी ऑफ वेसल्स। हमारी वेसल्स बहुत छोटी छोटी फ्रेजाइल हो जाती हैं, एंड ये जो वेसल्स हैं दे स्टार्ट ब्रेकिंग। ये फ्रेजाइल हो गई एंड ये ब्रेक करने लगी। नाउ व्हेन दे ब्रेक व्हाट विल हैपन, देयर विल बी कलेक्शन ऑफ फ्लूइड जो कैपिलरी लीक करेंगी बिकॉज ऑफ फ्रेजिलिटी। देयर विल बी कलेक्शन ऑफ फ्लूइड बिटवीन द एपिथेलियम एंड द सुपरफिशियल लमाइना प्रोप्रिया। और ऑब्वियस ही बात है अगर यहां पे फ्लूइड इकट्ठा होने लगा सो ऑल माय वोकल कॉर्ड विल बिकम वेरी वेरी बल्की, एंड जैसे ही वोकल कॉर्ड बल्की हो जाता है द वॉइस डीपेंस। तो फीमेल वोकल कॉर्ड में अगर इस टाइप की पिक्चर आ गई that you are seeing that this vocal cord has become so heavy that now both of them have got uniformly enlarged and now they look like a bag of water appearance. So obviously बात है बहुत मोटे vocal cords are heavy vocal cords and that will create a male like voice. Classical picture, female when they go over the phone so they will sound like a man and you will get confused, and that's how Rinke's edema comes. तभी इसे edema बोलते हैं of the Rinke's space. That's why it's called Rinke's edema. अब मेरा क्वेश्चन है इसमें आप क्या करोगे? What will you do in this case? Let us figure out that. So what you are going to do in this case? What is the most appropriate definitive management for this patient? Either give oral corticosteroids with strict voice rest for 4 weeks. क्या ये काम करेगा? Smoking cessation alone as the lesion completely involves in both of the patients. So basically, smoking cessation अकेले काम कर जाएगा in this patient. Reduction glottoplasty with voice therapy. And radiotherapy because the lesion represents a pre-malignant disease. What you guys are going to do? What you guys are thinking about कि हम क्या कर सकते हैं? So the only way in which I can do this particular surgery is number 1 to relieve the edema. और edema हटाने के लिए मुझे इस vocal cord पे incise करके सारा का सारा edema हटाना पड़ेगा. And I have to tell the patient to completely stop smoking with voice therapy. So this is called as reduction glottoplasty. Reduction means reduce करना, glotto मतलब vocal cords, and plasty matlab repair. So what I'm going to do, I'm going to take an incision over the most dependent area of the vocal cords. मैं इनको open करूंगा. Once I open the vocal cords, I will straight away enter inside my superficial lamina propria. Inside the superficial lamina propria, I'll suction out all the secretions, and when I suction out all the secretions, this vocal cord will become again regular. और जब ये regular हो जाएंगे बस मैं patient को कहूंगा कि अब smoke नहीं करना है and maintain voice therapy. So you will do this surgery जिसमें आप reduce कर रहे हैं vocal cord का volume, and this is called as reduction glottoplasty with voice therapy. Now this is very very important. ठीक है, ये याद रखना. This is something how we do this particular cases. Okay? अच्छा, एक और चीज है जो एक बार आपके एग्जाम में पूछा भी गया था, ये INI का क्वेश्चन है कि what is your last layer of dissection? जब आप vocal cord की कोई भी सर्जरी करते हैं, what is the last layer? आप किस लेयर में नहीं जा सकते? तो मैंने आपको बताया एक है कवर, एक है बॉडी. बॉडी कौन बनाता है? वोकल कॉर्ड की जो मैकेनिकल स्ट्रेंथ दे रहा है. इट इज आवर वोकैलिस मसल, इट इज आवर डीप लमाइना प्रोप्रिया एंड इंटरमीडिएट लमाइना प्रोप्रिया. ये लमाइना का मतलब शीट, प्रोप्रिया मतलब लेयर. तो दीज टू इंटरमीडिएट एंड डीप लमाइना प्रोप्रिया टुगेदर आर कॉल्ड एज वोकल लिगामेंट. ये और वोकैलिस मसल, वोकल लिगामेंट एंड मसल, ये दोनों मेरी मैकेनिकल स्ट्रेंथ दे रहे हैं. In case if I am doing a vocal cord surgery in benign vocal cord disorders, I should never ever cross beyond vocal ligament. अगर मैंने vocal ligament इंजर कर दिया, patient will lose the voice horribly, क्योंकि the mechanical strength of the cord is lost. तो क्वेश्चन ये आया था, what is your last step of dissection? You identify the vocal ligament, क्योंकि superficial lamina propria इसके just ऊपर है. यहीं पे हमें रुक जाना है. We should never go and touch the vocal ligament, क्योंकि जहां if I cross over, it will lose the mechanical strength whatsoever. ठीक है, फाइन. पैपिलरी स्वेलिंग और एडिमा को कैसे? पैपिलरी स्वेलिंग का मतलब पैपिलोमा. एडिमा नहीं देंगे. लैरेंजियल एडिमा बहुत कॉमन चीज होती है, वो नहीं देंगे. रिंकीज एडिमा. पैपिलोमा में एक सॉलिटरी लीजन है ना, सॉलिटरी लीजन ओवर वन कॉर्ड, वो पैपिलोमा है। दोनों में देखो, इसमें दोनों कॉर्ड्स में बराबर से स्वेलिंग है, दैट्स रिंकीज एडिमा। ओके, चलिए अब आ जाते हैं आपके फेवरेट क्वेश्चन पे। तो इसमें हमारा बस आंसर क्या है, सो आई विल जस्ट राइट डाउन द आंसर ओवर हियर। So the answer here becomes that you will do reduction glottoplasty with voice therapy and better even smoking sedation. Smoking sedation which is strict. Okay, so we have done 8. Now we move on to the second last question for today and the second last VBQ for today for larynx. And this is about a 63-year-old man who presents with progressive hoarseness for 8 months. 8 months progressive hoarseness. Okay. Now, odynophagia, dysphagia and significant weight loss. सब कुछ है. 8 months की hoarseness, odynophagia, dysphagia, weight loss and 63-year-old man. Red alert. 45 pack year of smoking. Alcohol consumption. Examination reveals a fullness over the right side of the thyroid cartilage. मतलब मेरी जो इसकी जो thyroid cartilage है, आपने यहाँ पे छुआ तो it is very very tender and it is full. ये पूरा ये बाहर आ गई है. Okay. वीडियो लैरिंगोस्कोपी में आपको दिखा देता हूं दैट सेम पर्सन अंडरवेंट अ वीडियो लैरिंगोस्कोपी एंड व्हेन यू सी द वीडियो लैरिंगोस्कोपी ऑफ दिस पेशेंट somewhat has this kind of a picture. Epiglottis eye. Now behind the epiglottis, can you see anything? Can you see anything moving? You're seeing partial mobility of the left cord, but यहां पे देखो there is a visible ulceroproliferative lesion. ये देखो ये epiglottis eye. Now, if you see opposite cord is somehow कुछ करके ये move कर रहा है, but this area somehow has got this kind of huge growth. What is this? This is fixating my vocal cord mobility. Smoker, fixity of vocal cords, what does it lead you into? Obviously, that will lead you into a carcinoma. So this is how a glottic carcinoma looks like. पर मैं इतना आसान आपके लिए बनाऊंगा नहीं. Let me show you again. So this is how exactly you are seeing opposite cord is mobile, somehow working. But you see on this particular side, you are seeing that there is a huge growth, ulceroproliferative growth, which is not letting, or the patient doesn't even have space to breathe inside, right? Again, go back to the question that I told you. Now, what did I tell you? This guy has got a lot of history of smoking, significant weight loss, odynophagia, dysphagia, 8 months से hoarseness है, 45 pack year smoking के हैं, and he has fullness on the thyroid cartilage on the right side. Why fullness? Now let me further go on. Now I give you a contrast enhanced CT scan that reveals the following findings. So now the CT is an ionized CT question. तो अब मैं आपको CT भी दिखा देता हूं. This is the same guy and this is the CT scan of this patient. अब इस CT scan को पहले पढ़ने की कोशिश करते हैं कि what are we seeing over on the CT scan, and then we will see over on कि किस तरीके से वो वाली हमारी findings भी, they are matching over. Now when I see this CT scan, so whatever white on CT you see is cartilage या bone, whatever gray is soft tissue या tumor, whatever black is air. That's the rule of CT, right? So what do we do over here? See, this is your thyroid cartilage. Thyroid cartilage हमेशा V की तरह होती है, V की तरह, because this is an axial section. Axial मतलब ऐसे काटा, ऊपर से देखा. When you cut it like this, obviously your thyroid cartilage is like this, like a V. So you are going to see from the top. Now when you are going to see from the top, this is your V. On the center point of your thyroid cartilage are attachment of your vocal cords. ऐसे हमारे vocal cord center point of thyroid cartilage पे, they get it. अब what exactly are you seeing over here? You are seeing that this thyroid cartilage जो white है, this V is broken. And this gray thing is coming out. You see this V is broken and this gray thing is coming out and you don't see anything. You see a very shifted, very narrowed lumen, यहाँ पे कुछ दिख रहा है, but you don't see this kind of a picture. ऐसे V की तरह बीच में आपको कुछ नहीं दिख रहा है, एयर जैसा. You don't see any vocal cords over here. You just see this kind of a growth which is coming out of the thyroid cartilage. Makes sense? Because in what I gave you in the question, that was saying कि thyroid cartilage had pain, fullness. तो जब आपने examine किया तो ये full लग रहा था ये area. क्यों? क्योंकि the tumor has come out of the thyroid cartilage and it has invaded it. So that means if you see anywhere there is a breach of your thyroid cartilage, मतलब अब ये tumor thyroid cartilage के बाहर आ गया है. And you can't even see any place where you can have this particular breathing. Breathing के लिए कोई space ही नहीं रह गई है. This is the only space left for breathing. क्योंकि this is air. ठीक है? Whenever you have got gross cartilage invasion, जब cartilage के बाहर कोई भी carcinoma आ जाता है, what does it become? It becomes stage 4 carcinoma. So now let me revise out laryngeal carcinoma management and staging with you guys. तो सबसे पहले अगर मैंने आपसे बोला व्हाट इज T1A, T1B, T1A, A means ek. Ek means that there is tumor, but that tumor is only over one vocal cord, and both vocal cords that you are visualizing are mobile. यानी जो भी आपने ट्यूमर देखा एक कॉर्ड पे था, there was some ulcerative lesion over one cord, but both the vocal cords were mobile. You will call it T1A. T1B, T1B, B for both. So if there is tumor which is involving both vocal cords, but both vocal cords are mobile, तो आप कहेंगे T1B. यानी दोनों पे है ट्यूमर, but again both are mobile. अगर मोबाइल है तो it is T1. Whatsoever, A का मतलब एक है और B का मतलब both है. Tumor on both the cords, but in both cases, your vocal cords are mobile. Now let me come to the another one. What is T2? T2 you can remember now. Two subsites are involved in larynx. Two subsites का मतलब vocal cord पे already there was a cancer. Now it has spread to more than one subsite. And that more than one subsite could be either supraglottis or subglottis. या तो vocal cord के ऊपर कैंसर चला गया है, ऊपर चला गया है, या फिर नीचे चला गया है. More than one subsite of vocal cord means two subsites. Two subsites, either supraglottis or subglottis, and that is 2, T2. Now, whenever the cord becomes T2, any lesion is T2, if cord की impaired mobility आ जाएगी. If in case they say कि cord has impaired mobility, impaired मतलब कि चल रहा है but it is sluggish, then you call it T2. Now let me go to T3 because this is a question that comes. T3 means involvement of 4P. तो 4P मैंने अगर आपको बता दिया, it is automatically T3. What are the 4Ps? Mnemonic. If the vocal cord tumor is involving paraglottic space, which is a space around the vocal cord, तो ये vocal cord के side में जो space होती है, इसे हम paraglottic space कहते हैं. Pre-epiglottic space, the space present in front of the epiglottis, that is pre-epiglottic space. Post-cricoid area. पोस्ट-क्रिकॉइड एरिया कौन सा एरिया होता है? एरिटेनॉइड के पीछे के एरिया को पोस्ट-क्रिकॉइड कहते हैं. द एरिया बिहाइंड द एरिटेनॉइड, दिस एरिया, दिस इज माय पोस्ट-क्रिकॉइड एरिया. बिलो माय अगर मैं पोस्ट-क्रिकॉइड के अंदर चला जाऊंगा, आई विल एंटर इनसाइड माय ईसोफेगस. पोस्ट-क्रिकॉइड एरिया इज बिहाइंड द एरिटेनॉइड्स. एंड फाइनली कम्स द इनर पेरिकॉन्ड्रियम ऑफ थायराइड कार्टिलेज. इनर पेरिकॉन्ड्रियम ऑफ थायराइड कार्टिलेज, बट नॉट ग्रॉस इन्वेजन. यानी कि ये जितने भी यहां पे जो ये अटैच हो रहा है, दिस इज द इनर पेरिकॉन्ड्रियम ऑफ थायराइड कार्टिलेज. But I have not invaded the cortex. अगर मैंने invade कर दिया cortex, it becomes T4A. If I say inner perichondrium of the thyroid cartilage is involved, no gross invasion of cartilage, then it becomes T3. Whenever I say T3, vocal cord becomes fixed. मतलब अगर T2 था, there was impaired mobility, but when it becomes T3, it becomes fixed. यानी कि one cord is not moving because of the carcinoma. That is an important point. What is T4A? T4A का मतलब है ग्रॉस एक्स्ट्रा लैरिंजियल एक्सटेंशन. ग्रॉस एक्स्ट्रा लैरिंजियल एक्सटेंशन का क्या मतलब है? एवरीथिंग अराउंड द लैरिंक्स इज इन्वॉल्व्ड. सी, दिस इज कमिंग आउट ऑफ द लैरिंक्स. दैट मींस कार्टिलेज टूट गई. कार्टिलेज अगर ब्रेक हो गई, दैट इज T4A. व्हाट इज अराउंड द लैरिंक्स? लैरिंक्स से बाहर आ गया, देयर इज स्ट्रैप मसल इन द सेंटर, देयर इज स्किन इन द सेंटर, सो देयर इज इन्वॉल्वमेंट ऑफ स्ट्रैप मसल्स, देयर इज इन्वॉल्वमेंट ऑफ स्किन. ग्रॉस कार्टिलेज इन्वेजन, ट्रेकियल इन्वॉल्वमेंट, इसोफेजियल इन्वॉल्वमेंट, थायराइड ग्लैंड इन्वॉल्वमेंट, ऑल ऑफ दीज आर अराउंड हियर. So that is all T4A. And last is T4B. T4B हम तब बोलते हैं जब इन्वॉल्व होता है PCM, not physics, chemistry, maths. This is prevertebral space, carotid sheath, and mediastinum. So if anywhere they say कि ये तीन PCM इन्वॉल्व हो गए, then obviously it becomes T4B, यानी last stage. We can't do much about it. Question अब देखो क्या है. You can see gross cartilage invasion over here. Fullness of thyroid cartilage है. And if I go back to show you what I showed you over in the laryngoscopy also, तो यहां पे भी ध्यान से देखो. If you see this laryngoscopy, see, your vocal cord is completely fixed. कुछ नहीं चल रहा, बस opposite side का कुछ दिख रहा है. There is hardly any space for the person to breathe. तो fixity है, so मुझे इतना तो समझ में आ गया, ये T3 पे पहुंच चुका है. How will I come to know this has involved the thyroid cartilage? I have given you a clue that there was fullness over the thyroid. I have given you another clue that this particular patient had a contrast enhanced CT scan which showed gross extralaryngeal extension. So what is your answer? This becomes a carcinoma which is T4A. Khatam. Now for any particular carcinoma, हमारा एक treatment protocol होता है. There's a way we treat carcinomas. If your carcinoma question comes एंड दे टेल यू कि T1 और T2 कैसे ठीक करते हैं. तो T1 and T2 are early stage carcinomas. And in early stage carcinomas, you require only a single modality treatment. Single modality मतलब सिर्फ एक चीज करनी है. तो single modality मतलब if I say that you get a T1 या T2 carcinoma, then the whole soul either I send the patient for radiotherapy, सिर्फ radiotherapy, or I will do a transoral laser microsurgical excision. मतलब I'll put laryngoscope, I'll take out with the help of a laser, and I just require either of the two. That is upon my patient preference. अगर मुझे लगता है यंग पेशेंट है, I will still go for surgery. क्योंकि अगर पेशेंट का कार्सिनोमा वापस आ गया, I can do a radiotherapy. That's my second option. Usually older patients में I choose radiotherapy more over surgery. ठीक है, because उनकी obviously इतनी ज्यादा surgically they are not fit for undergoing a surgery. That is something which I'll do for T1 and T2. But now, when I go for T3, T3 is in between. ना तो ये ट्यूमर बाहर आया है, ना ये ट्यूमर अंदर है to be qualified. So now here, in T3, there was a huge fight between head and neck surgeons and radiation oncologist. उन head and neck surgeons said कि भाई कार्सिनोमा है, T3 हो गया है, total laryngectomy करके निकाल दो. But what did radiation oncologists say? Radiation oncologists came up with an idea. They said, no, this is an organ which is doing important work. Why should you unnecessarily take it out? It is not a T4 tumor, it is T3 still. तो ये borderline stage है. तो borderline stage में क्या करते हैं? We do something called as organ preservation protocol. ये हमारे ऊपर होता है. So this is where the head and neck surgeons sit with the radiation oncologist. So many of the times when I was very enthusiastic to do a laryngectomy, the radiation oncologist stopped me. क्यों? क्योंकि उन्होंने कहा because as a surgeon I'm enthusiastic कि भाई ऑपरेट करते हैं. But here I need to figure out an organ preservation हो रहा है कि नहीं. अब organ preservation protocol ये कहती है कि तीन चीजें आपको देखनी है larynx में. Larynx has got three functions, S, A और R. Speech, aspiration, respiration. Assess करो कितनी अच्छी स्पीच है. एस्पिरेट तो पेशेंट नहीं कर रहा, और रेस्पिरेशन में पेशेंट कैसा रिस्पायर कर रहा है. अगर पेशेंट स्ट्राइडर में आता है, एस्पिरेट कर रहा है, पेशेंट की स्पीच हार्डली है, तो दैट मीन्स दैट पेशेंट इज डेफिनेटली गुड फॉर अ laryngectomy. But if that patient is coming up with no aspiration, respiration इतने ज्यादा स्ट्राइडर के इश्यूज नहीं है, and we can still treat the carcinoma, so then I will choose concurrent chemoradiation. But ये देखो, ये दो modalities हैं. That is why in T3 and T4 we do multi-modality treatment. In T1 and T2 we do only single modality treatment because this is early stage. Either radiotherapy or transoral laser excision. But here I need an answer. Either concurrent chemo-RT और या फिर we will do something called as partial laryngectomy. अब प्रॉब्लम क्या है? पार्शियल laryngectomy का मतलब है कि एक पार्ट ऑफ वोकल कॉर्ड टुगेदर विद द ट्यूमर निकाल दो. इसमें प्रॉब्लम्स क्या देखी गई हैं? पार्शियल laryngectomy पेशेंट्स हैव मोर चांसेस ऑफ एस्पिरेशन. दे आर नॉट वेरी गुड कैंडिडेट्स. So that is the reason partial laryngectomy nowadays is not very popularized. अब हम लोग लेजर सर्जरीज करते हैं, but definitely if I have a chance in selecting and the patient is good, I will definitely go for a concurrent chemo-RT for if the patient has got a minimally functional larynx, या फिर हम कर सकते हैं उसमें, we can take him out. But if definitely अगर नहीं है patient, so we'll go for a laryngectomy. We'll remove the part of the cord together with the tumor and send it off. ठीक है? What is gross extralaryngeal? Nothing is left out. Cartilage is also invaded, so I can't wait and watch over here. I need to completely take out the larynx. So in T4A, जब भी आएगा, your answer should be total laryngectomy and neck dissection and post-operative radiotherapy. Because ये भी multimodality है. पहले surgery करेंगे, total laryngectomy, total removal of larynx. Neck dissection करेंगे bilateral because any cancer of head and neck goes into neck nodes as lymphatics. So we will take out the neck nodes. And finally, what we'll do after the surgery is finished, now we'll send the patient to radiotherapy so that it doesn't come back. So ये होता है for T4A. T4B, unfortunately, we don't have much of options. And this is something where we increase the life of the patient respectfully. And that is called as palliative treatment. Respectfully, give a good life to the patient to whatsoever time is remaining. Because यहाँ पे mediastinum, carotid, prevertebral space, we can't have a chance to save the patient. So here we'll just prolong the life of the patient for some months, make the patient pain-free, give nutrition to the patient, give as much care and emotional support to the patient. This is something which is T4B under palliation. अब मेरा क्वेश्चन देखो, आपने वो पूरी डायग्नोसिस देख ली है. You know that this laryngoscopy is showing what? So now, what will be the following appropriate definitive treatment for this patient? आपने contrast CT देख लिया, तो अब मुझे देखकर बताओ, what will you do? Will you do definitive radiotherapy alone for this patient? Will you do a concurrent chemoradiation with laryngeal preservation intent? Will you do a total laryngectomy with neck dissection followed by risk adapted adjuvant therapy like radiotherapy? Or will you go for an endoscopic laser cordectomy? अब इस पे सोच के बताओ जो मैंने आपको आंसर दिया है. Again, see the whole sequence. सारे के सारे क्वेश्चन, सारे के सारे ऑप्शंस आपके सारे स्टेजेस ऑफ कार्सिनोमा के हैं. If it would have been a T1, T2, I would have gone for radiation alone. If it would have been a T3 with a functional larynx, I would have gone for concurrent chemo-RT. Now this patient is of completely cartilage invasion, so what I will choose? I will do a total laryngectomy with bilateral neck dissection with no option left, and I will send the patient for post-operative radiotherapy. So the answer to this question will become, without a doubt, this. Just a second. So we will have no option left, and we will take this particular patient for surgery. Okay, we'll do a total laryngectomy. So this becomes your answer because it is a T4A disease. तो अब मुझे लगता है कि आप लोग एटलीस्ट मैनेजमेंट समझ गए. How to manage these kind of cases, now you guys have understood. ठीक है, चलो. तो this was my attempt कि ना ताकि आपको मैं थोड़ी से ओरिएंट करा दूं. This is how in regular life we see, because I still feel that see the more you see, the better you become, and the better you become, it's that how, you know, this is how a clinician works. So you need to see more. तो हमें एक तरीके से तभी हमारे हॉस्पिटल के राउंड्स की तरह कि हम ज्यादा देखेंगे तो हम ज्यादा समझेंगे. We'll retain more if you see more. That's how the attempt is towards this series also. Radical neck dissection, modified radical SOND. चलो इसके बाद में करता हूँ. ठीक है, after this question, then I will come back to this your question. But मैं पक्का करूँगा. 36-year-old man presents with progressive hoarseness for 1 year and has undergone multiple endoscopic procedures for recurrent laryngeal lesions. ये कुछ ऐसी हिस्ट्री है जो हमने पहले पढ़ी थी. Recurrent laryngeal lesions है, progressive hoarseness है, undergone multiple endoscopic procedures. Now the biopsy has confirmed कि ये patient के respiratory papillomatosis है. Following intraoperative video is shown to you, so I'll show you my video of operating on one of the cases which I did some time back on a recurrent laryngeal papilloma. और मैं आपसे ये पूछूंगा कि ये मैं कर क्या रहा हूँ? What is this procedure that I am doing? So what am I doing? So see, I'm sitting here, there's a microscope, the patient is in a position called Boyce position, and through this laryngoscope, I'm seeing both the vocal cords. I'm taking out some lesion from the vocal cord, and see this. Now see, this is kind of a suspension that I have attached. I'm watching everything inside this small hole so that I can fix something over on the vocal cord. My question is, इसे हम क्या कहते हैं? What is this surgery called as? Because I was again telling, and see, I've got these kind of instruments. So where I'm catching over some kind of a cotton, and I'm going in and I'm watching and I'm doing the stuff. So what is this called as? This is a procedure by which जो मैं अभी तक आपको microlaryngoscopy समझा रहा था. So this is how we do microlaryngoscopy. I've labeled the parts for you so that you can easily understand. So this procedure is called as suspension laryngoscopy. Suspension laryngoscopy. तो इसी तरीके से we take out maximum जितनी भी हमारी endoscopic microlaryngeal surgeries होती हैं for all the lesions जो अभी तक आपने देखे, वो हम ऐसे करते हैं. This is how we take out the lesion. This is how we reach. तो basically इसमें क्या होता है? We have got something called as a laryngoscope. देखो ये patient की जो position होती है, this patient position is called as Boyce position, जिसमें हम लोग patient में laryngoscopy करते हैं. Now important क्या होता है? That laryngoscopy करने के लिए you need a position called as Boyce position. Boyce position का क्या मतलब होता है? That this is flexion at cervicothoracic joint and this is extension at atlanto-occipital joint. इसका क्या मतलब होता है? इसका मतलब ये होता है कि जो patient है वो लेटा हुआ है. This patient is lying down like this. We raise the head end of the patient by 15 centimeters above the table. तो सिर्फ सर को 15 सेंटीमीटर ऊपर उठा देते हैं. So this is the kind of position that we achieve. इससे there is a cervicothoracic joint flexion and atlanto-occipital joint extension. What will I achieve with this position? सारी की सारी जितनी स्कोपी होती है ना, laryngoscopy, esophagoscopy, bronchoscopy, ये सारी इसी पोजीशन में होती है, which is called Boyce position. एक जॉइंट पे फ्लेक्शन, एक जॉइंट पे एक्सटेंशन. अगर मैं टॉन्सिलेक्टमी, एडनोइडेक्टमी करता तो दिस वुड हैव बीन रोज पोजीशन. रोज पोजीशन में आई कीप अ शोल्डर बैग अंडरनीथ द शोल्डर एंड आई एक्सटेंड बोथ माय जॉइंट्स, इवन द सर्वाइकोथोरैसिक एंड एटलांटो-ऑक्सिपिटल. तो अगर मैंने दोनों जॉइंट एक्सटेंड कर दिए तो उसे हम क्या बोलेंगे? रोज पोजीशन. इफ देयर इज फ्लेक्शन एट सर्वाइकोथोरैसिक एंड एक्सटेंशन एट एटलांटो-ऑक्सिपिटल, उसे क्या बोलेंगे? उसे कहेंगे बॉयस पोजीशन. ये फर्क है. सारी स्कोपी, ऑल ब्रोंकोस्कोपी, इसोफेगोस्कोपी, लैरिंगोस्कोपी, बॉयस पोजीशन. सारी एक्टमी, टॉन्सिलेक्टमी, एडेनोइडेक्टमी, इवन ट्रेकियोस्टमी, इन दोस केसेस रोज पोजीशन. ठीक है, तो ये रोज पोजीशन में है. नाउ व्हाट एग्जैक्टली आई हैव केप्ट इनसाइड? दिस इज अ लारिंगोस्कोप व्हिच आई हैव एंटर्ड इनसाइड. जिसके थ्रू आई एम विजुअलाइजिंग थ्रू अ माइक्रोस्कोप. माइक्रोस्कोप की लेंस कितनी होती है? अराउंड 400 नैनोमीटर लेंस वी यूटिलाइज फॉर लैरेंजियल सर्जरीज. This is obviously the surgeon's position. So this is a surgeon straight looking inside through the microscope into the laryngoscope and into the vocal cords. Now we attach an extra light. This is called as an optical cable, and we also keep a suction line. ये देखो ये suction tube है which I am holding, and there is a long suction which I am entering inside into the larynx ताकि मैं आराम से suction कर सकूं. This is a small space which we are working. Now ताकि मेरे दोनों हाथ free रहें. देखो मेरे दोनों हाथ free हैं. How is it free? I have attached this laryngoscope to a system. And this system is called as suspension laryngoscopy. Suspension laryngoscopy. So I attach this laryngoscope to a thing which is called as a chest piece. ये chest piece होता है जिसमें हम attach कर देते हैं पूरे laryngoscope को. अब laryngoscope कैसा दिखता है? This is how your laryngoscope looks like. If you see, this is how your laryngoscope looks like. This is what is called as a Klein-Sasser laryngoscope. This is a Klein-Sasser laryngoscope. Direct laryngoscope है. तो हम लोग क्या करते हैं? This is called as a handle. This is called as a shaft, and this is the eyepiece. यहां से आंखों से देखेंगे. This is the eyepiece. Now, after obtaining the voice position, we are going to hold this laryngoscope, and we're going to enter it through the mouth, and then through the mouth, I'm going to visualize the whole of larynx. ठीक है? That's how we are going to do. ठीक है? Even transoral laser microsurgery में भी यही यूज करते हैं. We're going to use the same instrument. एक में लेजर चला रहे हैं, एक में कोल्ड स्टील है. कुछ भी करेंगे इसी के थ्रू करेंगे. Okay? Fine. So now, what exactly this is going to be? So let me just show you. See, this is how we have done something called a suspension laryngoscopy. And अगर इसमें देखो, through that, I'll show you a video where you can see inside की क्या दिख रहा है through the laryngoscope. So I'll show you my view of how I visualize inside what I'm seeing inside of the same patient. So see, यहाँ पे मेरा ये है, and I've attached a monitor over here. और देखो इसके अंदर I can see both the vocal cords. See, this is where I'm working in. So this is my view of seeing. So this is how the surgeon visualizes, right? This is what exactly we see. So ये कौन सा सर्जरी चल रहा है? This is called as transoral microlaryngeal excision, right? Transoral microlaryngoscopy भी कह सकते हो with excision. So this is how the setup looks like. बस यही आपको पता करना है. This is what exactly you should know about this particular procedure. And the question was number 10 कि ये क्या है? So this is called as suspension microlaryngoscopy. क्योंकि suspension के through आपने attach कर रखा है through a chest piece. So what we call this particular thing as? We call this as suspension microlaryngoscopy and excision. This is about a 24-year-old female who has come for her routine checkup for medical fitness. Now this is a normal person who always goes and gets their ears checked, right? Okay, great. Residents have also joined. Very nice. So routine medical fitness के लिए there is a lady who has gone to your OPD. While examining the tympanic membrane, you noticed a shadow in the posterior superior quadrant of the pars tensa, as seen in the video clip. So I'm going to show you that video clip and I'm going to ask you, what do you see in that particular thing? Now already the answers have started to come, but let me just tell you how it looks like. What is the structure seen through during inspection? So first you see, then I'm going to ask you, what do you see actually? And this is about a normal tympanic membrane, because before we move on to diseases, I want you to show the important structures that we see in normal people first, correct? So this is the otoendoscopy. Otoendoscopy means I'm taking an endoscope inside the ear canal. And what do you see? I'm retracting the pinna backward, upward and laterally. Dekho, I've retracted the pinna backward, upward and lateral. This is one important sign. Why? Because I want to make my ear canal into a straight line. My ear canal is directed forward, downward and medially. I want to pull the pinna in a bull. Pull the pinna like a bull. Backward, upward and lateral, so that I can straight my ear canal. Now, once I go inside this ear canal, you can see this is the cartilaginous part containing hair. This is the bony part which does not have hair, and you see a semi-translucent tympanic membrane coming up. Now see what are the important things that you can see over here. Okay, I'm just going to pause this video for a while so that I want you to show what exactly things you can see over in this tympanic membrane. And let's first figure out that. Now, when I see this tympanic membrane, first of all, I need you all to understand which side is this. Is it the right side or is it the left side? That is my first important thing. That is for you to identify which side tympanic membrane a question can come. My first and foremost thumb rule is, if the tympanic membrane is tilted towards the right, it is right side. If they are showing you any tympanic membrane tilted towards the left, it is left side. Very simple and straight. So this looks tilted towards the right. So if I can say this tympanic membrane is somewhat tilted towards the right like this, So it is right, right? Now, whichever side the tympanic membrane is tilted, that side becomes anterior, ulta side becomes posterior. Yani, if this particular tympanic membrane is tilted towards the right, this side becomes anterior, this side becomes posterior. Simple. Okay? Now, what ossicle attaches to the tympanic membrane? One ossicle which attaches to the tympanic membrane is your malleus. So, in the center of the pars tensa, you will have your malleus. This is your handle of malleus, what you can see over here. The point of attachment of the handle of malleus, what you can see over here, is called as umbo. So this centermost point is called as what? This is called as umbo. So the point of attachment of the malleus to the pars tensa is called as umbo. Now if you see, pars tensa is seen to be gray and translucent, correct? Pars flaccida is up, you can see it is pinkish. So pars flaccida is pinkish, pars tensa is semi-translucent. And because it is semi-translucent, you will be able to see a lot of shadows of middle ear structures through the tympanic membrane. That's what the idea is, right? Okay. Now, simple rule of physics. Whenever you shine a light of an endoscope or an otoscope, the shine of the light will always get reflected to the most dependent quadrant. Again, when you shine the light of an otoscope or endoscope, the light will shine in the most dependent quadrant, correct? Now, how will you divide the quadrants of pars tensa? If you draw one imaginary line along the handle of malleus and another imaginary line perpendicular to it passing through the umbo, you can divide your pars tensa into 4 quadrants, correct? This is your antero-superior quadrant, this is antero-inferior quadrant, this is postero-inferior, this is postero-superior. Okay, fine, following? Now my question is, what shadows do you see of normal middle ear structures through in these quadrants? If you see, you can see something blackish behind the antero-superior, something black around here. This is the shadow of eustachian tube, because eustachian tube contains air and eustachian tube is right behind this antero-superior quadrant. So if I take this out, I'll see my anterior wall of middle ear and I'll see my eustachian tube opening. Okay, that's point number 1. Point number 2. I told you, when you're shining your light of the otoscope or endoscope, it will get reflected in the most dependent quadrant. What is your most dependent quadrant? सबसे dependent quadrant कौन सा है? It is your antero-inferior quadrant, क्योंकि this is the way in which it is tilted. So this is the point where it will get reflected, and this is called as a cone of light. Can you see? A cone-shaped light getting formed. So question 1 that comes in your paper is, which is the most important quadrant where you will find the cone of light? Answer is antero-inferior always, because it is the most dependent quadrant. Simple, right? Now, what else shadow can you see? Can you see this shadow over here? This whitish shadow over here. This is the shadow of 𝐒𝐿-stapedial joint. This is the shadow of 𝐒𝐿-stapedial joint, which you can see as a reflection out of your pars tensa. Now, because this is the shadow of 𝐒𝐿-stapedial joint, any disease which happens in the posterior-superior quadrant is always regarded as an unsafe disease. Why? Because you have got what? You have got an important ossicle over there, and that ossicle is what? That's called as 𝐒𝐿-stapedial joint shadow. And that's what is important for you to understand, that this is why this is the most unsafe quadrant of your pars tensa. Because if this chali gayi, there will be ossicular instability. That's why when we say cholesteatomas occur in posterior superior quadrant, they are the most unsafe there. Why? Because they will impede this ossicular function, and that will cause conductive hearing loss. Okay, fine. So I'm going to show you the video again. Now just follow the video, what we have done. Same way, antero-inferior cone of light. This is your handle of the malleus, umbo, eustachian tube shadow, postero-inferior quadrant, and over here you see your 𝐒𝐿-stapedial joint shadow. Upper part pars flaccida, lower part pars tensa. Correct? So this is what exactly your pars tensa looks like. Now, this is what the first question was that I asked you, which among the following is present over in the posterior-superior quadrant? Right? So this was about a lady who came for a normal examination. And what do you see in the posterior-superior quadrant in the video? So your answer should have been, it is always the 𝐒𝐿-stapedial joint, which we will see over in the posterior-superior quadrant. It is the most unsafe quadrant of the pars tensa. Why? Because it contains the IS joint. I hope you guys are following me. I hope you guys are understanding what I am telling you, right? And this follows our first important question, what exactly you understand from the normal tympanic membrane. Answer would be B. Okay? Chalo, very good. Now we move on to the further aspects, and to understand about the further questions, I move on to my next question, that is question number 2. Now in question number 2, I have a 65-year-old male who has presented to the emergency, and he has a history of polytrauma, multiple traumas over the body, after an alleged history of assault. So somebody had assaulted the 65-year-old gentleman and he ended up into your emergency. Now he told the injury happened 3 days back. So that means there is some time the injury had happened and he was admitted in some local hospital, but he didn't have any relief. So this gentleman was in a local hospital but had no relief. So now he was referred to our center and he now presented with severe pain, swelling and blackish discoloration over the pinna. Now I'm going to show you the video of this gentleman, how he came to our emergency. What did we see in this patient? My question will be, what is the most appropriate management for this patient? So you guys have to see the case, then diagnose the case, point number 1. After the diagnosis, you need to tell me what will you do in this case. So 2 things you need to do: identify and first diagnose and then treat. So what exactly is this video about? Is this 65-year-old gentleman who has come with this kind of a pinna in front of you after a history of polytrauma, and this is what we see. If you see, this is a pinna and this is what we are seeing over on the pinna. So again I'm playing, this is what you are seeing, something like a swollen pinna with some kind of a blackish discoloration. History of assault is there over on this gentleman. My question are 2. First of all, I need you guys to first tell me what is this diagnosis. What is the diagnosis of this patient? The second thing would be, how will you treat this patient and how will you go on treating this patient ahead? Kya karenge aap log next? What you are going to do next in this particular patient is my question. Okay, very nice. So Raj has told incision and drainage. Let's first figure out what exactly is this diagnosis. So if you carefully see, this pinna is quite swollen and boggy and tense, right? And he has got extensive, no, this is not perichondritis. So I am going to correct you here. This is called hematoma oris. See, whenever you get a history of assault, whenever you get any kind of a history of boxing, athletic, any person who has got a hit over here. So this was a road traffic accident, maybe an alleged history of assault. Somebody has assaulted, somebody has slapped over here. So this is called hematoma oris. Okay, ठीक है, तो इसे hematoma oris कहते हैं. Now understand what exactly this question is. Then I'll tell you why this particular thing happened. This is your pinna. This is your pinna. Pinna is made up of what? Pinna is made up of cartilage. Correct? I'm going to take a piece of this cartilage out. So pinna is made up of elastic cartilage. If I take a piece of this elastic cartilage out, you know cartilage किससे बनता है? Cartilage is made up of cells. और ये कौन से cells होते हैं? These cells which make up your cartilage are called chondrocytes. So cartilage is made up of chondrocytes. So these cells are called as chondrocytes. This is the same principle which we keep talking over in our theory lectures also. Now chondrocytes or cartilage, if you remember what I told you, over in cartilage क्या होता है? Cartilage is a connective tissue. Cartilage is a structure which does not have vascularity, no lymphatic drainage, no nervous supply. If cartilage does not have any supply, then how will a cartilage live? My question is that. Cartilage is a living structure. So cartilage survive कैसे करेगा अगर उसके ऊपर, it doesn't have any nerve, any vessel, any lymphatic drainage. So the whole life of your cartilage lies inside the covering of the cartilage, and the covering of the cartilage is called as perichondrium. Cartilage covering को क्या कहते हैं? Perichondrium. Correct? Now this perichondrium is the one जो contain करती है important blood vessels. यानी जितनी भी important blood vessels हैं, they are importantly present inside the perichondrium, right? And this perichondrium is sending their oxygen to these chondrocytes to live by the process of diffusion. So by the principle of diffusion, they are sending out all the oxygen to these chondrocytes and our cartilage is living. यानी अगर मैं आपसे पूछूं, the one thing that is making your cartilage live is what? That is your perichondrium. If I strip the cartilage of the perichondrium, your cartilage is dead. It is necrosed. ये important चीज है to understand why that black color is important there. I'll tell you now. तो हुआ क्या? What happened in this person? Somebody hit or slapped him from the right side. He got hit over the pinna. Obviously, perichondrium contains blood vessels. तो ये perichondrium के blood vessels got injured. Now, when they got injured, what is the next step that happened? This perichondrium underwent injury, and this particular cartilage started getting away from the overlying perichondrium. That means now when the person was slapped, the perichondrium blood vessels got injured, and now when the blood vessels got injured, there was collection of blood between the perichondrium and the cartilage. if there is collection of blood between the perichondrium and cartilage, in simple words, what exactly that will lead to? That will lead to कि ये perichondrium अब मेरी cartilage से दूर चला जाएगा. It will get lifted off. Now, if this perichondrium lifts away from the cartilage, will the cartilage derive nutrition? Answer is no, because the whole nutrition is coming from the perichondrium. अब ये दूर हो गया, so cartilage will not get nutrition. So what will happen in 72 hours? These chondrocytes will start undergoing necrosis. And that is why, because this man was late around 3 days, his necrosis has already started. His necrosis has already started because the cartilage has been stripped away from the perichondrium and he has already started to develop these kind of symptoms. Correct? Now, what exactly this particular person will need? क्या करना चाहिए इसमें? Right? So, you need to emergently drain this particular abscess, this particular drainage. Or this particular hematoma, you need to drain it out as soon as possible. Why? If you don't put an incision and drainage, this blood will keep continuing collecting between the perichondrium. It will keep getting lifted away. Cartilage will undergo complete necrosis और ये fall off कर जाएगी. It will completely become black. तो हमें करना क्या है? We need to just put an important incision over the pinna and we need to drain out the blood. ठीक है? 72 hours is the key. Right, very well said. So 72 hours is the key where you need to drain this out. तो जब भी hematoma होता है ना, चाहे septal hematoma, auricular hematoma, the answer is incision and drainage. Simple. Now we need to incise and drain it. So what I'm going to do is, I'm going to show you what exactly this particular person is. So what I'm going to do now is a very simple procedure where I'll just take a blade and I will just put an incision over the most dependent part of the pinna. So where it's maximum boggy, I'm just going to open it. When I open it, whatever blood clots I see, I'm going to remove that out. And then what I'm going to do, I'm going to take antibiotic ointment and I'm going to tightly pack the pinna. I'm going to tightly pack the pinna. In all quadrants, I'm going to tightly pack. Why tightly packing is important? So that it does not refill back. So can you see this necrosis has already started over the pinna. That's why this person is dangerous. Okay? So this is what exactly will be the answer. Now, I'm showing you another video of this man and I'm going to ask you another important signs what you see over here. So this man, because he had a history of alleged assault, he developed 2 more signs. Both signs are questions to you. So now I'm going to show you 2 more signs which are associated with this man and let's see whether you guys can figure it out or not. So see, this is the same man and this man also had this blackish discoloration behind over the mastoid. That is one sign. And when I saw his eyes, I saw these blackish discoloration around the eyes as well. I want the names of both the signs that you will see over in this particular case. This is another following of that question, that I want to know the signs where I am showing you there is blackish discoloration, or I can say ecchymosis over the mastoid. And then when I move in front, I see black eyes like a panda. So what are these 2 signs what I am showing to you, and what is that? Very nicely said. Both the answers have already come up. So what you see in the first, that's a very important PYQ. And that is when you see any kind of blood patch over the mastoid area, that's called as battle. Battle you can understand na, koi ladne gaya. That's called as battle sign. Battle sign. And what you see blackening around the eyes, they look like a raccoon. So this is called raccoon eyes. Both battle sign and raccoon sign, they are both classical features of what? They are both classical features of basilar skull fractures. So basilar skull fractures will lead to important battle sign. Battle sign means ecchymosis. Ecchymosis over mastoid. And the second important sign that you will notice in these patients will be raccoon eyes, and raccoon eyes will be seen also as blackening or circumferential orbital blackening. Circumferentially around the eyes. Circumferential blackening around eyes. Now both are seen in what? They are both seen in basilar skull fractures. Now both of them are important PYQs. Both of them are important questions. Okay, fine? Chalo. So this finishes about our important ways of understanding about what are the important signs that you will see. Now, let me go on to the third important case which we have over here. And this third important case is about a 54-year-old gentleman. So we have got a 54-year-old man, and this man presents with, see, the same kind of symptoms, but a little different. Pain, redness, swelling over the right pinna for 3 days. So one was pain and swelling over the right pinna for 3 days. You saw that he had a history of trauma. Now, he gave a history of recent ear piercing over the helix 5 days back. Ear piercing is an important indicator of history over here. He is febrile, he has fever, complains of pain as well as which has progressively worsened. A video clip demonstrates the following findings. What is the most appropriate initial treatment for this patient? ठीक है, तो हम लोग ने एक important चीज cover करी. Now we have got another important case. इसका क्या problem है? That he has got some ear piercing done over, let's say, गोवा गया और गोवा में इसने piercing करा ली. अब गोवा में piercing कराने के बाद ये आपके पास वापस आता है and ये कहता है कि there is severe swelling over the pinna, बहुत दर्द हो रहा है and he is not able to sleep. Now he comes up with important, very nice. People have already started answering, but see, now what I'm going to do. This is the same man. I have removed the piercing of this man. Piercing मैंने हटा दी है, right? And now this man is sitting in front of me, correct? Now when this man is sitting, I'm examining this man and what do you see over here? You see that there is redness and erythema over the cartilaginous part of pinna. See the lobule? I'm holding the lobule is paired. यहाँ पे कुछ भी नहीं है, why? Because cartilage नहीं है. Whenever I touch this particular person is having a squeeze, यानी इसके दर्द हो रहा है. He's having, it's extremely tender. Now, when I move the pinna, can you see that? This is called circumduction test. Means when I'm moving the pinna and the patient is having pain, this is called as circumduction test to be positive. The only thing where you cannot see this swelling is the lobule, क्योंकि lobule पे cartilage नहीं होती. So in simple words, what is this answer going to be? You see a red erythematous inflamed pinna, history of trauma or piercing. What will be your answer? Your answer will be perichondritis. तो ये perichondritis है. Not that severely boggy swelling which had a history of assault. ये है, देखो uniformly the whole perichondrium is inflamed and there is extreme tenderness जो दिख रही है यहाँ पे. इसे हम लोग क्या बोलेंगे? इसे हम लोग बोलेंगे perichondritis. ठीक है? अब सिंपल सी बात है कि अगर perichondritis से related questions आते हैं तो उसके बड़े specific questions हैं. Again I told you perichondritis means क्या? Perichondrium का inflammation. That means if this is your cartilage and the cartilage is having chondrocytes, इस कार्टिलेज की कवरिंग क्या है? इस कार्टिलेज की कवरिंग है पेरिकॉन्ड्रियम. आपको पता है that your perichondrium is the one which is containing important blood vessels. Correct? Now this person went to some unhygienic place. इसने क्या किया? इसने अपने हेलिक्स पे एक piercing करा ली. Now what happened was that piercing pierced these vessels. When this piercing of these vessels happened, क्या हुआ? This was an unhygienic piercing. So what happened was an organism came inside. And this organism most commonly is Pseudomonas. So important PYQ, most common question that comes in this particular case is that perichondritis happens because of which organism? And the answer becomes Pseudomonas. सबसे common, Pseudomonas loves your cartilage, loves your ear. So Pseudomonas will straight away come inside. It will start multiplying. अब अगर ये multiply करेगा, it will lead to an inflammation of your perichondrium. And that is called as perichondritis. ठीक है? अब सिंपल सी बात ये है कि if any patient comes with perichondritis, आप क्या करेंगे? What will you do first? You're going to remove this earring. That is the first important thing. Many of the girls come to our OPDs, they have got piercings, they do over the helix tragus. The first thing you need to do is remove that piercing out. तभी आप लोग हमेशा piercing कहाँ पे करते हैं normally? You do it over your lobule. क्योंकि यहाँ पे cartilage नहीं होती. Right? So the most safest way to pierce your ear is over the lobule क्योंकि वहाँ पे सिर्फ fat है. But here, just take out the piercing. That is point number one. Invading feature आपने हटा दिया. Now the second thing is you need to cover Pseudomonas. अब Pseudomonas को cover करने के लिए Pseudomonas hates which drug? Pseudomonas hates only one drug and that is ciprofloxacin. So Pseudomonas hates one drug and this drug is ciprofloxacin. Now my question is that ciprofloxacin तो बड़ा important drug है, right? Ciprofloxacin, you must have seen ENT and eye market. Ciprofloxacin has got such a big boon of market. Everywhere the ENT and ophthalmologists use the ciprofloxacin. My question is why? Why it is the most potent drug in the market as far as Pseudomonas is concerned? So this is the most potent anti-pseudomonal activity. So number one is ciprofloxacin is a fluoroquinolone, right? थोड़ी pharma पढ़ लेते हैं. This has got the most potent anti-pseudomonal activity. So this is point number one. Why we give that so much in our ENT practice, right? Second, this has cartilage penetration. That means it penetrates your cartilage and it goes inside and gives you protection. So it's a cartilage penetrating drug, very importantly used in our perichondritis क्योंकि उसमें cartilage को penetrate करके जाना जरूरी है. Third important reason is if I ask you how is it inhibiting why is ciprofloxacin utilized in Pseudomonas? क्या करेगा ये जाके अंदर? So it is going to inhibit DNA replication. And why it is going to inhibit DNA replication? This drug is a DNA gyrase inhibitor and a topoisomerase 4 inhibitor. It's a topoisomerase 4 and a DNA gyrase inhibitor. So what will happen if it inhibits both of these enzymes? This is going to cause less DNA replication. और अगर replication नहीं होगा, obviously the whole replication of the bacteria will be halted, और उसकी वजह से Pseudomonas will halt in its progression. That is why you have this drug given many of the times in ENT as well as far as our practice is concerned. Even eye में बहुत common होता है Pseudomonas, so we even give it there. ठीक है, तभी आप देखेंगे Ciplox ear drops और ciprofloxacin, oral antibiotics everywhere in the ENT market. This is the reason for that. ठीक है, तो सबसे important चीज क्या हुई? That will start oral ciprofloxacin and the patient will be fine in some days. Fine? चलिए, तो this is important about what you need to know as far as both the things are concerned. What is hematoma and what is your perichondritis. और दोनों के बीच में differentiating feature आपने देख लिया. चलिए, now I'm going to go into a little more inside and deep in your ear canal, and I'm going to show you something more. Okay, so now I have got another important case of a 35-year-old diabetic male. So this is my first important clue to you that this is a problem which is happening predominantly in diabetic people. Okay, and the patient has intense itching, feeling of ear block, mild ear pain and right ear for the past 2 weeks. So right ear hai, the patient has got the major problem is itching and the patient has got diabetes. That's the most important catch point. Diabetes, itching inside the ear. Patient also complains that he has got some kind of an earache, dull aching type, and his ear is full. Now, he gives a history of frequent self-cleaning of the ear with cotton buds. I always call cotton buds as a modern sin of the century. सबके घरों में cotton buds रहती हैं, but सबको पता भी रहता है we shouldn't use cotton buds. But still, this person has got a history of cotton buds, and he also has recent history of swimming. So all the things I have given you: cotton bud usage, swimmer, and diabetic. History of intense itching inside. Following video scopy shows the following. Okay, so this is an otoendoscopy of this particular patient, and I'm going to show you what exactly you see inside the ear. So see, I'm going inside the ear and you see something like this, right? You see something black, something white, you see something like a black and white, something like a newspaper, correct? So what exactly are these? Now see exactly how the particular thing looks like. See, can you see these dancing hyphae? Can you see that? A dancing hyphae. And this looks like a newspaper, right? Something white, something black. Correct? Right? Okay. So what is exactly this? This white and black and white and black. So I can call this is a wet newspaper-like appearance. ऐसे लग रहा है ना newspaper है, like a wet tissue, right? So now what I'm going to do, I'll take my suction inside and see what exactly these hyphae will start dancing. Can you see? They've started to dance all around. Now this is called as oral suctioning. Suctioning means what? I've utilized the suction and I'm just going inside and I'm taking out all these debris, all these whitish, blackish things what are present inside. Now keep looking as to what I am doing till the time I'm just going to jot down what exactly this is. So if you see something black and white, this is otomycosis. This is otomycosis. So what you see here, these are nothing, but these are aspergillus colonies. Can you see? These aspergillus colonies will be something like this. They'll be like a drumstick, right? So basically, they'll be having a black head and they'll be having these hyphae and a black head, right? So whenever you put your suction inside, they will start dancing as to whenever we are removing them, right? So this is called otomycosis. This is most common as aspergillus niger. Niger means black, so it produces black filamentous colonies, which I showed you. This is the same image which was given in the recent paper of FMG. Same image, यही आई थी FMG paper में, image आई थी, not the video. So black filamentous अगर colony दिखी, then it is aspergillus niger. Okay. Now, if you see any whitish, you can see even the white, right? So if you see any whitish colony, that whitish thing is basically what? That is Candida. This is Candida albicans. Alba का मतलब होता है white. This is Candida albicans, whitish. If there are blue colonies, that is Aspergillus fumigatus. तो अगर blue colony है, that is Aspergillus fumigatus. अगर white colony है, that is Candida albicans. If there are black filamentous colonies, that is Aspergillus niger. What is this appearance called as? This is called as wet newspaper appearance. This is called wet newspaper appearance. Now my question is, how will you treat this? So how am I treating? I'm suctioning this out. So this is called as oral toileting. Toileting का मतलब होता है that we clean the ear, right? With the help of a suction, with the help of a swab. So this is something called as cleaning of the ear. We call it oral toileting, right? And when we finish oral toileting, we have to give antifungal ear drops. And antifungal ear drops में सबसे commonly utilized are nystatin or clotrimazole. So nystatin and clotrimazole. Now they usually are in immunosuppressed states like diabetes. क्योंकि diabetes, you must have seen when you put that bread. आप अगर bread खाते हैं, so if you put bread over in the rainy season outside for 2 days, you will see fungus over it. Fungus loves to breed over these kind of, materials like bread, like something which is sugary. So fungus breeds on sugars, right? So free sugars जहां पे भी होंगे, fungus breed करेगा. So always remember that diabetics are a major thing that you will get one of this disease, and they will come with intense itching inside the ear. You see these black and white colonies. The second thing would be that this is very common in swimming. Okay, why swimmers have a very common otomycosis? क्योंकि जब आप swimming करने जाते हैं, or when you are living in a very hot tropical climate where you have got a lot of humidity, you'll see it over in the southern regions, coastal India, जितने भी coastal areas हैं, you'll get a lot of chances कि वहाँ पे हो otomycosis. Why? Because in all of these humid areas, or when you swim a lot, your pH of your canal becomes more alkaline. And when the pH changes from acidic, normally आपका acidic pH है, जब वो alkaline बन जाएगा, तो alkaline environment is the best for organisms to breed. And one thing which breeds on alkaline environment is fungus. So the pH changes from acidic to alkaline, in especially swimmers and those who usually live in this hot and tropical climates. That is the reason you get more of fungal growths over in the ear canal in that area. Okay? So I think all of you have understood about this. This is ideal, very, very important how you should see. Okay? So what exactly is this? What exactly is this? So this is video otoscopy. This is otoscopy. Now this will be what? Never ever give it oral से. Oral में कोई मतलब नहीं है देने का, right? The only thing that we need to do is we need to start on clotrimazole ear drops. But before that, the best treatment becomes clean the ear. You need to remove the fungus in order to let those drops function. तो सबसे पहली चीज हमेशा oral toileting होती है, and then there is topical clotrimazole followed by nystatin if required. अगर इससे ठीक नहीं होता है, then only in those cases we switch to oral antifungals. If you don't get it, then we switch to oral antifungals, which is usually fluconazole and itraconazole. Okay, fine. So this finishes about another important PYQ, that what you require for otomycosis. ठीक है? चलो, अब आगे बढ़ते हैं. Now we go on to the next question. So the answer here becomes this. Now what is your next question? Now I have gone inside into the middle ear more. Now when I go inside into the middle ear, what exactly do you see? 48. Remember this, I'm telling you about a 48-year-old man who has presented with progressive hearing loss and oral fullness. थोड़ा भरा भरा कान लगता है, right? Now, for the past 3 months, okay, 3 months he has got this progressive hearing loss and oral fullness. Now he denies any ear pain, discharge, vertigo, or recent upper respiratory tract infection, so he doesn't have any kind of a supportive history. Just 2 symptoms. 1, he can't hear properly. 2nd, he has got fullness inside the ear. Okay, fine. Video otoscopy demonstrates the following findings. Left ear is found to be normal. Right ear has some disease. Left ear is found to be normal. So that means I'm talking only of the right ear. So this is another important point, that this is a unilateral disease. Okay. Now, what is the most appropriate next step of management in this patient? So I am just showing you the options. Okay. See the options A, B, C, D. This is about a gentleman, 48-year-old adult male, जिसके एक side right ear में he is not able to hear well and he has got oral fullness. I'm going to show you the video otoscopy of that particular person, and now you guys have to tell me what exactly is wrong with this person and how will you manage this. अब आगे आके आप करेंगे क्या? So see, I'm taking my endoscope inside and see, this is a tympanic membrane tilted towards the right, so it is right. Can you see these kind of bubbles behind the pars tensa? I'll tell the patient to do Valsalva maneuver. मैं कहूँगा कि नाक बंद करके blow your ear out. See, he blows out. You can see these bubbles are kind of moving. Okay, multiple these kind of bubbles are seen behind. The tensa is normal, flaccida is normal, but you see these kind of bubbles which are present behind over in this tympanic membrane. So if you see again, these bubbles are kind of moving. What is exactly this? First of all, I need the diagnosis. When you see these kind of, we can see these kind of air fluid bubbles which are moving. What is this? Very nice. This is serous otitis media, also called as glue ear, also given the name as non-suppurative otitis media, also called as sterile otitis media, also called as otitis media with effusion. कुछ भी आप लोग बोलते हैं. This is something where you see classically what? you see that behind the pars tensa, you have got multiple air fluid bubbles. You can see, right? There are multiple air fluid bubbles. Air fluid bubbles are seen behind a normal pars tensa, and because there is so much of fluid inside the middle ear, that might be the reason that this patient is not able to hear properly or might be having some oral fullness. My question is what? My question is ki this gentleman has this finding. My question still remains, what will you do in further step of management in this patient? Are you going to start the patient on antibiotic, oral amoxiclav, 10 days, do a myringotomy with grommet insertion, do a flexible nasopharyngoscopy, or start on antihistamine together with nasal decongestants? क्या करेंगे हम लोग इसमें? What should we do in this particular case? Come on guys, I want your answers to come so that we can talk about this case. So then I'm going to tell you कि किस तरीके से I have taken this case out, and this was one of the case which was there, and I've shown you one of the rare cases today. Okay, so everybody is towards ki myringotomy and grommet insertion. Chalo. Now let me give you a clue. What is the most common? Okay, so let's see. Let's say this is your middle ear. This is your middle ear. Okay. This is the anterior wall of middle ear. Anterior wall of middle ear contains eustachian tube opening, and the eustachian tube opens on the other side in your nasopharynx. दो opening होती है. One is bony and one is cartilaginous. Correct? Bony opening is here. This is your cartilaginous opening, which is opening in your nasopharynx. Correct? That's my second point. Number one is, this is a unilateral disease. Okay? Half of ENT surgeons. I'm telling you what happened with this case. This case came to me after quite a long time. He came after, some 3-4 months of struggling with this, and this was his only symptom. Right? Now, what exactly you need to understand, number one point is that in order for this fluid to develop inside the middle ear, eustachian tube has to be blocked. How will eustachian tube get blocked? Eustachian tube can only get blocked if there is some mass present inside the nasopharynx. Following? If you block the eustachian tube, fluid will start collecting inside the middle ear. Correct? This fluid collection only can happen when your eustachian tube is blocked. Now, the most common reason for blockage of eustachian tube in children is which pathology in the nasopharynx? Adenoid. In child, you get a simple adenoid hypertrophy, and these adenoids are there in every child. So when they grow big, they cross over the eustachian tube orifice, they close the tube, and everything starts to fill up inside your middle ear. So in adenoid hypertrophy, usually you get otitis media with effusion. But in children, both the side adenoids will be involving. Matlab adenoid is a huge tissue. So both the eustachian tube will be involved. So in cases of children, there is bilateral serous otitis media. And the most common cause of eustachian tube obstruction becomes adenoid. What I have told you, this is a right ear disease. Left ear is absolutely normal. And this patient is a 48-year-old man. So can a 48-year-old man have potential adenoid? No, he cannot have. The only one thing he can have in the nasopharynx is nasopharyngeal carcinoma. Nasopharyngeal carcinoma is one of the most common causes of producing unilateral serous otitis media. So, अगर मैंने बोला 48, so your answer should be simple. I will want to check why this particular serous otitis media is happening first of all. And this is what happened in this case. When I did a nasopharyngoscopy, it was a stage 4 nasopharyngeal carcinoma. Nasopharyngeal carcinomas are very hidden tumors. उनके सिर्फ दो signs होते हैं. If you see any adult coming with unilateral OME, NPC, always remember that. And if you see anyone coming with painless cervical lymphadenopathy, NPC, 75% of the NPC cases don't end up with nasopharyngeal complaints. They come with only 2 complaints. Both are questions for you. One, painless cervical lymphadenopathy. अगर कोई भी आया, 75% of the times it is NPC associated. क्योंकि ये बहुत छोटा ट्यूमर होता है. It occurs in the fossa of Rosenmuller. Fossa of Rosenmuller is an important 3-dimensional space present behind your eustachian tube. So यहाँ से start होता है and it comes over in the nasopharynx. So it blocks. So remember, this is a unilateral OME case. And the answer would be NPC. So you need to nothing. Don't put any grommet or anything. And I'm telling you, he was counseled for grommet insertion. But the answer was what? The answer lied in where it is. You need to do a flexible nasopharyngoscopy. see the finding, and obviously when nasopharyngeal carcinoma confirm ho gaya, so what will be the management for this nasopharyngeal carcinoma? Now tell me the next important MCQ. What is the management strategy? The management strategy for nasopharyngeal carcinoma is concurrent chemoradiation. This is the management strategy. This is also another PYQ. कि क्या करेंगे? You will always send nasopharyngeal carcinoma cases for concurrent chemoradiation. Correct? Fine. So these are the important PYQs. Unilateral SOM, painless cervical lymphadenopathy, what will you send them for? CCRT, concurrent chemoradiation. Because that is one area which we cannot resect out properly and reconstruct. That's the reason we send it here.
So we'll start with the question number 1. I have a 46 years old male presented to us with the swelling in the inguinal region. Okay, the following test has been performed. Identify the test performed. So it's simple. I'm going to show you a test of the inguinal hernia and you have to tell me what test is this. As simple as that. Now the video is this. So it's a very short video and I want you to observe what is happening. This is the index finger I have put inside it in the inguinal region. Now you see here. I've put the finger and now you can see we are asking the patient to cough. Now as the patient coughs, right, you can see the impulse is positive and your finger is moving, right? So what do you think is the diagnosis? I have a 46 years old male presented with swelling in the inguinal region. The following test has been performed. What test is this? Is it a 3-finger test? The answer is no. It is not a 3-finger test. 3-finger test is what we call it as the Zeeman test. This is what we call it as the Zeeman test. And the Zeeman test, we use 3 fingers, right? What are 3 fingers? You will use the number 1 index finger, the middle finger, the ring finger, right? The index finger is going to be at the superficial inguinal ring. This middle finger is going to be at the deep inguinal ring and this is going to be at the femoral ring. This is not the Zeeman's test. Is it a finger invagination test? Absolutely correct. So the answer to this question is finger invagination. I'm going to take my index finger, insert in the superficial inguinal ring and reach to the deep inguinal ring. I'll ask the patient to cough. Now, when you see here, again a very specific thing. I've taken my index finger from the superficial inguinal ring to the deep inguinal ring. So here you have your superficial inguinal ring and here you have your deep inguinal ring. So this is the superficial inguinal ring, this is the deep inguinal ring and I'm asking the patient to cough. Now, when the patient coughs, you have to find where the impulse is felt. If the impulse is felt at the tip of the finger, because the tip is going, your finger which you are going to put, the tip of the finger. So this is how the finger is going to go. The tip of the finger will be at the deep inguinal ring. Now, if you feel the impulse at the tip of the finger, it is your indirect inguinal hernia because the entry point of indirect inguinal hernia is through the deep ring. But if you feel the impulse at the base or the pulp of your finger, it is your direct inguinal hernia. In this patient, when we asked the patient to cough, I felt the impulse at the pulp of the finger. This is a direct inguinal hernia. I want you to observe it again, right? See, superficial inguinal ring, deep inguinal ring, I'm asking the patient to cough. Now you see the finger is moving. If the impulse is felt at the tip, it is your indirect. If it is felt at the pulp, it is your direct inguinal hernia. So answer to this question is going to be your finger invagination test. For ring occlusion test, in the ring occlusion test, what are you going to do? I am going to use the thumb. We will use the thumb to occlude deep inguinal ring and ask the patient to cough. And ask the patient to cough. Ask the patient to cough. And if I find the impulse to be positive even after occluding the deep ring, then the answer is direct inguinal hernia. If the cough impulse becomes negative after occluding the deep ring, it is an indirect inguinal hernia. The exception is pantaloons hernia because it's a fallacy. In a pantaloons hernia, because you have direct and indirect, either you occlude or do not occlude, you're not able to differentiate. Another fallacy is if there's a lax deep inguinal ring, you try to compress it, your thumb will not be able to compress the entire deep ring, you'll still get it positive. Those are the fallacies of your ring occlusion test. None of the above cannot be the answer. So answer to this question is B for Bombay. That is your finger invagination test. Everybody clear with that? Okay, sorted hai? Okay. Chalo, great. Now, moving to the second question. So the question number 2 is this. I have a 30-year-old male presented to us with a discomfort in the periumbilical region. Great. The patient was examined. The examination video is attached to identify the sign demonstrated, right? And I'm going to show you a video. Now, this is a 30-year-old male with an incidentally found swelling in the periumbilical region. There is no other medical history. I'm going to show you the clinical sign and I want you to identify. What is happening, right? Now, this is the patient and this is the clinical video. Now, I'm seeing the swelling is present in this axis. That is what I'm trying to tell you. Now, if I press here, the swelling becomes more prominent on the other side, right? You can see here. You can see that's getting more prominent. And then when I press from this side, the swelling becomes more prominent on the opposite side. So if I'm pressing here, the swelling is becoming prominent. Now I press here, look at here. The swelling will become more prominent here. The swelling is becoming more prominent, right? Now, as I press, the swelling becomes more prominent on the other side. So the swelling is orientation in this manner and it is only mobile in this particular manner. And when I perform a percussion, see, I'll also do percussion on the swelling. Very good, Anuj, very good. So what is this sign? Kya hai ye sign? What is this sign? I'm also doing percussion. I'll find the dull node and there'll be band of resonance around it, right? So I have a patient, 30-year-old, periumbilical swelling is present. Now it is only mobile in this particular direction. It is not mobile along its direction and I'm also doing percussion. If you find a video like this, what is the possibility? What is the possibility? Last time also it happened this way only, no? Wait. One second, guys. Just hold on for a second. Fortunately, this time nothing happened. So we are good. Now, what is this sign? Now, what is this sign that you're seeing across here? Now, is it a Murphy sign? See, Murphy sign is... No, don't worry. We got this time back. Now, what is Murphy sign? Murphy sign you will find where? Where would you actually find the Murphy sign? Murphy sign would be found. Kahan milega Murphy sign? Where would you find Murphy sign? So Murphy sign positive basically indicates that there is whenever mid-inspiratory arrest or deep palpation in the right hypochondriac region. So presence of mid-inspiratory. There's a mid-inspiratory arrest on deep palpation. On the deep palpation in right hypochondriac region. Now this usually we see in cholecystitis, right? This is not it. McBurney sign is in the appendicitis. This is what we call it as the Tilloch sign. So what is Tilloch sign? The Tilloch sign is the swelling that you're going to palpate. The Tilloch sign, when you look at the Tilloch sign, so Tilloch sign you'll usually find it is in mesenteric cyst. The mesenteric cyst usually arises from the mesentery. So you have two types, chylolymphatic and enterogenous, which is more common. Obviously, the chylolymphatic is more common when compared to enterogenous cyst. Now, in the Tilloch sign, you will see that the swelling is mobile. It is mobile perpendicular to mesenteric attachment. Perpendicular to the mesenteric attachment and immobile, and it is immobile along the mesentery. And also there is a band of resonance. this band of resonance, this band of resonance around the swelling. There is band of resonance around the swelling. This is what we call it as styloxine positive, right? Cullen sign, as you see, it is, okay, somebody saying it is pancreatitis, but it is hemorrhagic pancreatitis. Cullen sign positive will be seen in retroperitoneal hemorrhage. It's a periumbilical ecchymosis. This is periumbilical. This is a periumbilical ecchymosis. And this periumbilical ecchymosis is seen in retroperitoneal hemorrhage. It is the retroperitoneal hemorrhage. It is seen in the retroperitoneal hemorrhage. What are the other signs? You can also see the Fox sign. You can also see the, you have the Cullen sign, Gray Turner sign, and the Fox sign. Okay? Fox is along the inguinal region. Cullen's is periumbilical, and Gray Turner is a flank ecchymosis. There are three signs that you're going to watch it. Okay? Great. So we have finished the two questions. Let's go to the question number 3. Something is happening. Okay. So going on to question number 3. Now, in the question number 3, what do you have? In the question number 3, now this is a very interesting question. Okay. Now, in question number 3, I have a 55-year-old female, short statured, presented to us with pain in the groin region. Okay. Which was intermittent in nature. Great. The patient is examined. There was no swelling identified in the groin region. The following clinical test was performed and the sign was found to be positive. Identify the test and the diagnosis. Right. Now, I'm going to show you the video. You have to find me what test it is done. Your 4 options: Hannington-Kiff sign, Hausche-Bromberg sign, Fox sign, Gray Turner sign. Right. Now, even before we start with the discussion, the basic consensus is clear already. Right? What is the basic consensus that we have? The basic consensus is that Hannington-Kiff sign and Hausche-Bromberg sign are the 2 signs that you see in obturator hernia. These are the 2 signs we see in obturator hernia. Fox sign and Gray Turner sign is seen in retroperitoneal hemorrhage. It is a retroperitoneal hemorrhage. This is your retroperitoneal hemorrhage, right? Now we have an absolute clarity of thought that if you have Fox sign, which is going to be ecchymosis around the inguinal region, Gray Turner is going to be ecchymosis in the flank region, I have to differentiate between Hannington-Kiff sign and the Hausche-Bromberg sign. As simple as that. ठीक है, चलो देख लेते हैं. Now this is the question, right? I'm going to show you a clinical video. You have to identify. But diagnosis is obturator hernia even before starting the video. But I want you to identify what clinical test is being performed here, right? Now, I have a hammer in my hand. Patient is sitting. This is the knee. This is the medial aspect, right? Now, watch it. I have palpated the medial epicondyle of the femur and I have tapped it, right? On tapping the medial epicondyle of the femur, there is sudden jerk at the hip. What is the sign called as? बेटा Hausche-Bromberg sign नहीं है, वही तो हम बता रहे हैं. क्या sign है ये? I'll play it again. I'm tapping on the medial epicondyle and you see there is jerk at the hip. क्या sign है ये? This is your Hannington-Kiff sign. This is your Hannington-Kiff sign. ठीक है? Hausche-Bromberg sign क्या था? Hausche-Bromberg sign, there'll be shooting pain along the obturator nerve on medial rotation of the semi-flexed thigh. वो आपका Hausche-Bromberg sign है. ये Hausche-Bromberg नहीं है. ये क्या sign है? This is your Hannington-Kiff sign. This is your Hannington-Kiff sign. When you tap on the medial epicondyle or the medial condyle of the tibia or the medial epicondyle of the femur, there will be abduction of the limb because of jerky movement at the level of hip. And this is what we call it as the Hannington-Kiff sign positive. ठीक है? चलो. Going on to the next question. Now this is also a very interesting question. I want you to pay a little bit of attention. देखो video based questions ना थोड़े tricky हो सकते हैं अगर आपका concept clear नहीं है. ठीक है? So my job is to make sure your concept is sound and good here. Now I have a 14-year-old boy presented to us with the swelling in the left side of the chest, started 5 days ago. Started 5 days ago, right? And present status of the swelling is given in the video. Okay, the patient is a known case of pulmonary tuberculosis. On chest X-ray, it was suggestive of left-sided empyema. Identify the diagnosis. I have 4 options that I have. What are the 4 options that I have? Option number 1, is it a cold abscess? Is it an empyema necessitans? Is it a chest wall abscess? Or all of the above? Clear? Okay, let's look at the video. Now, this is 2-part video that you have. I'll show you both the parts of the video and you have to identify the diagnosis. Now, let's look at the first part of the video. Look at the swelling. I hope you're able to see. The swelling is in the anterior chest wall that you can see here. I'm asking the patient to cough to see whether it expands or not. And it is basically a fluctuant swelling. You can see here, the swelling is quite evident, right? This is the first part of the video. Now, in the second part of the video, what we did, because on the chest X-ray, it was suggestive of empyema, I'm going to put this tube. What is this tube? It is an intercostal drain. Now, after putting an intercostal drain, the swelling disappeared. The swelling disappeared and the bag is now filled up with purulent material. The bag is now filled up with the purulent material. Now, my question to you is, what is the diagnosis? You had the swelling before putting the ICD and swelling disappeared after putting the ICD. Before there was a swelling, there was nice swelling, there's some sinuses also there, but after putting the ICD, the swelling disappeared. That means it is communicating with the thorax. Which swelling or which of the following options will have an intrathoracic communication? Quick feedback. ऐसा कौन सा swelling है जिसका intrathoracic communication होता है? Cold abscess, it is because of necrosis of the lymph nodes. So ये cold abscess तो नहीं है. Yes, the answer is correct. It is your empyema necessitans. The empyema necessitans communicate with the intrathoracic cavity. And that is why the minute I put the ICD, swelling also disappeared. That's a very, very important point. In fact, empyema necessitans mein IND nahi karna hai. You have to put an ICD and you should make sure the swelling regresses and disappears. Okay? It is not a chest wall abscess because chest wall abscess would not change in size even after putting the ICD. All of the above to वैसे ही नहीं है. The answer here is B for Bombay. Everybody is clear? ठीक है? It was a good case and a good video discussion. Sorted? Chalo. Moving on to the next question. Now, let's take the next question. Okay. The next question is, identify the test performed. I'm going to show you a video. You have to find. Now, if I say slip sign, now the slip sign is seen in lipoma. Fluctuation test will be positive with any fluid-filled cavity or a fluid-filled swelling. Trans illumination is going to be transparent, or you can say bright light, indicating of clear fluid. Pinch test. It is done whether the swelling is to identify the origin of the swelling. To identify the origin of the swelling. Is it originating from the skin or the underlying? If the skin is pinchable, that means it is originating from the underlying tissue or the underlying structure. If the skin is not pinchable, that means the swelling is arising from the skin itself. As simple as that. Alright? Okay. Now, I'm going to show you the video and I want you to identify what is the sign or the test that we have performed. But a fluctuation test can be positive in any fluid-filled swellings, right? And transformation is positive in the neck, it is in cystic hygroma. Hydrocele, they will have positive, right? So myelomeningeocele, they are positive, correct? Okay? So wherever you have dermoids, they don't have positive fluctuation, positive transformation. Dermoids can have positive fluctuation test. Okay? Now, I'm going to show you the video and you are going to tell me what is the test that you are going to perform. Now, there is swelling in the calf. I fixed it with 2 fingers and I'm now going to press at the summit of the swelling. Right, now you identify what is this. I have the swelling, right? I'm pressing at the summit and you see my fingers are moving apart, right? I'm pressing in the between, the swellings, the fingers are moving apart. What is this test called as? Is it a slip test? Slip test is what? You press, the swelling moves away. Are you doing that? No. Is it a fluctuation test? If you're pressing, fluctuation test is basically if you have a larger swelling, you put two fingers at the end of the swelling. You press one, the swelling goes, this finger goes up, and you press from here, this finger goes up. Because this swelling is fluctuant, the fingers will also move up and down. This should be done in two perpendicular direction. That is what we call as fluctuation test positive. But if the swelling is too small, you can't put two fingers, you can do this. So this is a fluctuation test. Absolutely spot on. Okay. Translumination, I did not put any light, so it is not a translumination test. It is not a pinch test because I'm not holding the skin and pinching it, right? So answer here is going to be your fluctuation test. So the test that we have performed, is B for Bombay. That is your fluctuation test. Clear? Okay. So this was your next question. Okay. Okay. Going on to the next question. Now, this is also a very anticipated exam question. I'm thinking this will come. Okay. Laparotomy 10 years ago. Okay. Now, I have a 45-year-old male patient presented to us with the following condition in the video. Okay. The patient underwent laparotomy 10 years ago. So, there's a previous history of surgery 10 years ago for a hollow viscous perforation. Okay. Could be because of peptic ulcer disease. According to EHS, that is European Hernia Society classification, what hernia is this? Is it an M1 hernia? Is it an L1 hernia? Is it an F hernia or an M5 hernia? Okay. So, what was the location of the swelling in the video? It was on the scalp, beta. It was on the scalp. Okay. Now, I have a 45-year-old male presented to you with the swelling in the, I'll show you the video. Okay, let's see the video and then we'll come back to this question. Okay. Now, this is the patient that we have. You can see a previous laparotomy scar is present. Now, this is the condition of the patient. This is the condition of the patient. Absolutely correct. Okay. So, it is not a rocket science to identify that it is an incisional hernia. But I've twisted the question by asking you, according to European Hernia Society classification, what category does it belong to? Now, for that, you should know the EHS classification. Now, according to EHS classification in the incisional hernia, if you take this as the representation of the abdomen and you take this as a representation of the umbilicus, right? So, the hernia that is going to be present within 3 centimeters of the xiphoid is called a subxiphoid. This is your M1 hernia. Now, within 3 centimeters of the umbilicus, it will be called as the umbilical hernia. So, this is your M2 hernia. This is your M3 hernia. This is your M4 hernia. And if you draw the line passing through the two anterior superior iliac spine, below this is suprapubic. This is a M5 hernia. Right. So, these are M1, M2, M3, M4, M5. Now, our patient is having the incision in the periumbilical region, which is here. So, it is involving M2, M3 and M4 region, right? So, because of the laparotomy that you have. So, incisional hernia is in this region, right? Now, you tell me, according to this, right? So, you have entire laparotomy scar. So, the laparotomy is going to be from the xiphoid to that of the suprapubic region because the complete laparotomy, right? Now, in the given options, the midline option is only one, that is M1. So, L1 is your lateral hernia, which is going to be subcostal, right? So, it is not L1, right? I can eliminate the L1. I can eliminate the L1. F stands for femoral hernia, that is for inguinal region. M5 is going to be suprapubic, it is pseudo, right? So, it is more likely to be in the upper part. So, it is your M1 hernia. It is your M1 hernia, right? So, see again, if you look at the video, you will have more clarity on the question. Okay? Again, look at this. So, if I just point it out, this is the xiphoid, this is the pubis. The swelling is more towards the upper side, right? I want you to identify as I play the video. See here. Look at this. Look at this, right? So, hence, it is more in favor of M1. That is why I want you to watch the video, no beta. So, it is very unlikely to go into suprapubic because usually incision does not cross the ASIS. The level of ASIS is the lower extent of your laparotomy incision. And that is again a very, very important clinical point. Okay? So, M5 is very unlikely. So, M1 is a better answer here. Okay? Clear? Clear? Chalo. Moving into the next question. So what do you have in the next question? Okay. The next question says that the following test was performed in the swelling found in the inguinal region. Based upon the video, identify the diagnosis. Right? Pretty straightforward question. I will show you a video. उसमें एक टेस्ट होगा, उस टेस्ट के बेसिस पे आपको मुझे बताना है कि कौन सा हर्निया है. Is it an indirect inguinal hernia? Is it a direct inguinal hernia? Is it a femoral hernia or is it an obturator hernia? As simple as that. ठीक है. ऑप्टेटर हर्निया नहीं हो सकता बिकॉज यूजुअली वी टॉक अबाउट हाउशेवर रॉम्बस साइन एंड हैनिंगटन-किफ साइन, वो हमने ऑलरेडी डिस्कस कर लिया. तो लेट्स गो विद द वीडियो एंड सी व्हाट. सो क्वेश्चन इज आई हैव डन अ टेस्ट. बेस्ड अपॉन द टेस्ट यू हैव टू टेल मी वेदर डायरेक्ट, इनडायरेक्ट और इट इज गोइंग टू बी एन femoral hernia or an obturator hernia. And this is the video that we are going to play. Now in this video you can see I've used three fingers that is there. The first finger is your index finger. Okay. So this is your index finger, this is your middle finger, this is your ring finger, and now I am asking the patient to cough. Now when the patient coughs, you can see the impulse is present on the lower finger, right? It is at the level of the lower finger. So what is the absolutely correct? This is a Siemens test. Okay. So where did you find the impulse? Where did you find the impulse? So three fingers are there. You have put the fingers like this. Okay. And you felt the finger impulse on your index. Yes, the answer is femoral hernia. This is your femoral hernia. This is a Siemens test. This is your Siemens test, or also called as the three-finger test. Also called as the three-finger test. Last time also we have discussed the same question. Okay? Chalo. Okay. Okay, moving on to the next question. Okay, so again, an interesting case. Let's see this also. Now, I have a 4-week-old male child presented to us with the repeated episodes of vomiting, and the clinical presentation of the baby is given in the video. Identify the diagnosis. Let's look at the clinical video. 4 weeks old male child, repeated episodes of vomiting. I know where it is going. You have options like CHPS, duodenal atresia, interception, and esophageal atresia. See, duodenal atresia will present to you on day 0 or day 1. So I already rule out this. Esophageal atresia will also present to me on day 0, day 1. So again, I can rule out this. So I'm left out with CHPS and interception because that can occur at any age group. But interception usually occurs between 6 to 10 months of babies. So by the virtue of the question, I already know the answer is CHPS. But I wanted to look at the clinical video and give me the objective. Now, this is the baby with repeated episodes of vomiting and something. This is what you're going to see. Tell me, what do you see in the video? That is more important. What do you see in the video? A very classical sign that you're going to see. I'm just going to move away from here. What do you see in the video? But it's not a rocket science. You can already know it's a CHPS. What do you see? There is some lump or a swelling, and that swelling is not at one place. It is moving. Where is it moving? It is moving from the left subcostal region towards the umbilicus. So there is a moving swelling from left to right. What is this? Yes, it is an olive lump, and that is moving from left to right. It is a visible gastric peristalsis. How am I able to tell you it's a gastric peristalsis? You see the peristalsis, you see the swelling moving from the left to right. If it is moving from right to left, it is colonic. If it is moving from left to right, it is gastric peristalsis. 4 weeks old baby, repeated episodes of vomiting, olive-shaped lump, and a visible peristalsis, and that to gastric peristalsis goes in favor of congenital hypertrophic pyloric stenosis. Yes, even before we started the video, you already knew the diagnosis. No rocket science in this. Clear? Okay? Right. Absolutely spot on. Chalo. Moving on to the next question. Now, this is also very, I would say, possible exam question because they have already asked you this question in a image-based format, right? So now we are asking you in a video-based format. So identify the method of the thyroid examination done in the video, right? Now, I've given you optional Lahey's, Kreil's, Pezzilo's and Rose method. Rose is not a position in which you examine the thyroid. It is the position for thyroid surgery. It is a position for thyroid surgery. So I can ready-made rule out the Rose position. Okay? It's an hyperextension of the neck, as simple as that. Now I have Lahey's method, Kreil's and Pezzilo's method. Okay? Acha. Now Pezzilo's method is done for short statured female, for short and obese neck. Now how do you identify Pezzilo's? The patient hand is behind the head. जो पेशेंट के जो हाथ होंगे ना, पिजिलोस मेथड में आपके पेशेंट के दोनों हाथ ऐसे क्लास्प होंगे और पीछे होंगे. अगर इस पोजीशन में आप पेशेंट का थायराइड एग्जामिन कर रहे हो, देन इट इज गोइंग टू बी योर पिजिलोस मेथड. क्राइल्स में आई विल बी यूजिंग थंब, एग्जामिनर का थंब होगा. सो एग्जामिनर is going to use the thumb and I'll ask the patient to swallow. I'll put the thumb, I'll ask the patient to swallow and the swelling is going to move against my thumb. That is your Kreil's method. Lahey's method jo hoga, examiner is going to stand behind the patient. Examiner stands behind the patient. Rest the thumb on occiput. Rest the thumb on occiput and use fingers to palpate the thyroid gland. To palpate the thyroid gland. This is what you call as Lahey's method. In the Lahey's method, the thumb is going to be on the occiput, the fingers will come forward. From one side, I will press the swelling, it will become more prominent. I'll feel from this side, and then I will press from this side, and then I'll feel from this side, right? So this method is what we call as Lahey's method. Now I have oriented you pretty well. I'm going to show you the clinical video. See, at the end of the clinical video, I just want you to tell me what is the diagnosis. ठीक है? अच्छा, देखो. Now this is the patient that you have, right? And this is the method by which you are examining. So I'm using my fingers to palpate and my thumb is resting on the occiput. Thumb occiput mein I'm using the fingers to palpate. What do you think the diagnosis is? The answer is pretty straightforward. This is your Lahey's method. Kreil's में तो thumb है, हमने thumb तो use किया नहीं, ठीक है. Pezzilo's में patient का हाथ पीछे होना चाहिए, patient का हाथ तो दोनों side में. तो answer here is going to be Lahey's method. Sorted? Clear है? ठीक है, चलो, great. Now, going on to another question. ये थोड़ा difficult हो सकता है, but then I hope because you all are very intelligent, so I'm assuming that even before I start the question, you'll know the answer. ठीक है, चलो. What is the question? I have a 62-year-old. I have a 62-year-old male presented to us with the features of dynamic bowel obstruction with the history of laparotomy. It is laparotomy. History of laparotomy 25 years ago. Now, I've given you the video provided to you. It is not interrogative image. It's a video provided to identify the cause. Identify the cause for obstruction. Identify the cause for the obstruction. Okay? So I have a 62-year-old male who has underwent laparotomy 25 years ago for some XYZ reason. Now the patient has now presented to you with dynamic bowel obstruction. I am going to show you the intraoperative video and you have to tell me what is the reason for obstruction. Is it because of bands, stricture, volvulus or internal hernia? Based upon the video, you have to identify what you see inside the video. Are you ready? Okay, chalo. So this is the laparoscopic video that we are going to play. It's a 13-second video. Identify what is going to happen. Reason for bowel obstruction, right? Now you go inside. As you're going inside, now you see something is there. I want you to identify what are these, right? Now the obstruction is because of these structures. So what are these? And these are the causes for obstruction. There are multiple of them, not one. There are 2, 3 of them. And because of that, the bowel can twist around that and cause obstruction. Cause for obstruction, beta. Cause for obstruction. Cause for obstruction. Yeah. Very good. This is your adhesions or bands. So this is your post-operative adhesions. This is your post-operative adhesions. This is your post-operative adhesions, which has caused the dynamic bowel obstruction. In fact, the most common cause for dynamic bowel obstruction is post-operative adhesions of bands. There are no strictures here. Volvulus, it should have rotated around its own axis, and it is usually in sigmoid colon. There's not there. For an internal hernia, the patient should either have a history of surgery where you have mobilized a bowel loop, example like Roux-en-Y surgery, very, very important. Or there should be a potential defect through which it is going to herniate. Either it has to be from the foramen of Winslow on top, or either side you have on the superior mesenteric artery and the inferior mesenteric artery, potential defects are there. Either has to herniate from there. In a Roux-en-Y limb, if it herniates through the transverse mesocolon, it is called as the Stammer's hernia. If it goes behind the Roux limb, it is called as Peterson's hernia. But those are not the case here. So answer here is going to be bands. Okay? बेटा स्ट्रक्चर में ना बावल लूप कंडेंस होता हुआ दिखेगा, यहां पे बैंड्स क्लियरली नजर आ रहे हैं ना, तो आंसर हियर इज गोइंग टू बी पोस्ट ऑपरेटिव बैंड्स.
Can you notice this infant? He's holding a furniture, right? So what is this milestone? This is stand with support, right? He's holding the furniture and standing. So this infant is observed holding onto a furniture. Which of the following milestones is likely to be present at this age? Mature pincer grasp, immature pincer grasp, walk with one hand held, speak 2 word sentences. Right? So firstly, when does this milestone appears? When does this milestone appears? This milestone, we all understand this is stand with support. And the stand with support comes at 9 months of age, right? 9 months of age. So they are asking at which age this will be there. So mature pincer grasp, you all know, 12 months. Immature comes at 9 months. Walks with one hand held, again at 12 months. Speak 2 word sentences at 24 months or 2 years of age. Right? So the stand with support comes at 9 months. So the milestone that collaborates with 9 months here is immature pincer grasp. So they're going to drop in such integrated questions, right? Giving you milestone, asking what other milestones would be seen at this particular age, or could ask which next milestone could be there, right? So observe the video carefully, which milestone is this. So moving to the next question. I've dropped this animation over my Instagram also. Can you notice this girl child? A very typical movement is happening over here. A stereotypical midline hand washing or hand wringing like movement. Right? So let's move to the clinical stem. We have an 18-month-old girl who was previously meeting all the developmental milestones, now presents with loss of purposeful hand movements and development of repetitive midline hand movements. Genetic analysis is likely to reveal a mutation in which of the following gene? Firstly, what is this? This girl child previously had normal milestones, but now there is loss of previously acquired milestones. Loss of previously acquired milestones. So what is this? When a child loses a previously acquired milestones, we label it as neuroregression. So along with the neuroregression, what is there? There is a stereotypical hand movement, right? A stereotypical hand movement, hand wringing movement. So whenever you see this neuroregression along with the stereotypical midline hand wringing or hand washing like movements, this is nothing but Rett syndrome, a cause of acquired microcephaly. Right? So look for these pointers. Firstly, neuroregression, stereotypies, and third, acquired microcephaly. Acquired microcephaly. Right? So a clinical stem will tell you these 3 things. Neuroregression, that the child has lost the previously acquired milestone. Second, stereotypical hand movement with as seen in the video. Right? As seen in this video, can you notice the stereotypical midline hand wringing movements? And acquired microcephaly, that means now the head size of the child will be into a halt, the head size will appear smaller, right? So this is nothing but Rett syndrome, and in Rett syndrome the most common mutation is in MECP2 gene, MECP2 gene, and predominantly female children are affected, right? Okay, so this is about Rett syndrome. We'll come back to this question and ask about other options also. But let's first just cover these 10 questions. We'll come back. Okay. So moving to the next video. Look at this child. What can you notice? A sudden flexion happening in the trunk, neck, right? So we have a 6-month-old infant who presents with these sudden, brief, symmetric contractions of the trunk and limbs, and they are occurring in clusters. The EEG shows a highly disorganized pattern with high voltage, slow waves, and spikes. What is the drug of choice for this condition? Ethosuximide, vigabatrin, sodium valproate, adrenocorticotropic hormone. What do you think is the correct answer over here? What is this? What is this condition? Firstly, tell me. An infant, 6-month-old infant, there are brief, sudden symmetric contractions of the neck, trunk, and limbs, as you can see. And these are happening in clusters. That means they're happening again and again in groups. The EEG also shows a very chaotic pattern, high voltage, slow waves, and spikes. What is the drug of choice of this condition? What is this? No, this is not absence seizure. This is a typical case scenario of West syndrome. West syndrome. Yes, exactly. This was infantile spasm. This, whatever this child is doing, the sudden flexion, this is infantile spasm. And whenever you see this infantile spasm in clusters, that means happening again and again in groups, in clusters. Along with that, if you notice on EEG, there is a chaotic pattern. That means hypsarrhythmia is there. Chaotic pattern is there. Along with that, there is again neuro developmental regression. That means the child will lose the previously acquired milestone. Whenever you see this triad, this is nothing but West syndrome. And in West syndrome, what is the drug of choice? If you look at the recent 𝐒𝐄, they say the drug of choice is steroids or ACTH or ACTH. Here in the option, you can see ACTH only, right? Exam tip from my side: if the question stem gives both steroid as well as ACTH, go for ACTH, because in AIIMS they prefer giving steroids, right? So prefer steroids. If the one of the options is steroids and other options is ACTH, do not get confused, because both are the drug of choice. But in a country like India, steroids are relatively cheaper, oral, and are non-inferior to ACTH, so we prefer steroids in most of the cases. And also in AIIMS they prefer giving steroids. So if one of the options is steroids and other option is ACTH, do not get confused, mark steroids. Otherwise, choose the best option over here, right? So this is ACTH, option D. Vigabatrin, remember, is the drug of choice for West syndrome in patients with tuberous sclerosis. Right? Let's understand this West syndrome. I told you there is a triad: seizures, infantile spasm happening in cluster, developmental regression, and EEG has hypsarrhythmia. That means a high voltage chaotic pattern, as if some child has scribbled over the EEG print. Right? Remember, this West syndrome can be either idiopathic or cryptogenic when the underlying brain abnormality is not there. But when the underlying brain abnormality is there, this is known as symptomatic West syndrome, as in tuberous sclerosis. Right? In tuberous sclerosis, you have subcortical tumors. And in tuberous sclerosis, the drug of choice, remember, is vigabatrin. Okay, so this was about West syndrome. Let's move to the next question. Observe this child now. Right, this child is sitting in the emergency department. Can you notice the drooling of saliva? How is his breathing very rapidly? Seems in distress, has a toxic look, right? This child looks absolutely sick to me. Look how the child is leaning forward with taking support of the forearms, right? What is this? What is this? Can you tell me this posture? This is a tripod posture with the toxic looking child presented with high grade fever. There's drooling of saliva. So what is this? This is a 4-year-old child that presented to your emergency department with high grade fever, sore throat, drooling. The child is leaning forward, as we just saw, with extended neck. What would be the most appropriate next step? We have option A as examine the throat with trunk depressor, option B administer nebulized epinephrine, option C prepare for urgent intubation, option D obtain a lateral neck x-ray. What do you think? A lot of you have given the diagnosis, yes, this is acute epiglottitis. What would be the next step? Next appropriate step in this case, whenever you see a child looking like this, what would be the next appropriate step according to you? What is the next step? What are you going to do? Are you going to examine the throat? Are you going to give epinephrine nebulization? Or are you going to prepare for urgent intubation, obtain a lateral neck x-ray? Okay, so Pradeep is saying D, get an x-ray done. Vishal is also saying get D, x-ray done. Jishan is saying that go for urgent intubation. So Jishan, you are right. We prepare for urgent intubation. It is a emergency scenario. Remember, acute epiglottitis emergency scenario. We have to first focus on A, B, C. So securing the airway is the first most thing. So prepare for urgent intubation. This is a very toxic looking child, right? So let's revise a few things about acute epiglottitis. The age group, 1 to 3 years of age. Most common causative agent is a bacteria, Haemophilus influenza type B. How will the child look come up to you? The child is going to have a high grade fever, will look very toxic, muffled voice, this tripod position, drooling of saliva, right? Severe respiratory distress. The x-ray, yes, shows thumb sign. If you look at the normal epiglottis, it looks like this, but swollen over here, right? You can notice the swollen epiglottis. This is known as the thumb sign, right? So this is about nothing about epiglottitis, right? Vitals are mentioned, Pradeep. They have given that the child has a high grade fever, sore throat. And can you look in the image how the child is sitting, have a typical toxic look? These are the enough clues. They don't need to give you the heart rate, the pulse rate. They have mentioned high grade fever, drooling, sitting like this, leaning like this. Can you notice how the child is breathing? Visibly, the child looks in discomfort, severe respiratory distress. They are focused on the chest also. So this is nothing but acute epiglottitis, and the next step is going to be ABC, airway, breathing, circulation. So urgent intubation, option C is the correct answer over here, right? Moving to the next video. Look at this. I asked this girl child to take out the tongue, protrude the tongue, and I can notice this. What is this? The tongue is coming in, going back, coming out, going back, coming out, going back. What is this? Can you tell me? What is this? What is this sign called as? What is this sign? This is darting tongue sign. And where do you see this darting tongue sign? Remember motor impersistence? This is a hallmark of chorea conditions, right? Motor impersistence. So what happens in motor impersistence? So you understand chorea is an involuntary movement. So whenever this violent involuntary movement happens, so they sometimes disrupt your normal movements, normal voluntary actions. So that's why you see this darting tongue, jack in box phenomena, and also the supinator sign you see, spooning you see. All of these things are associated with chorea. So coming to the question, during the physical examination, the child is asked to protrude their tongue, but it repeatedly retracts and darts in and out. This is darting sign. This is associated with which condition? You have tardive dyskinesia, Wilson's disease, syndendum chorea, Huntington's disease. So the correct answer here is syndendum chorea, right? Syndendum chorea. Though Huntington's disease is a confusion over here, but remember Huntington's disease in childhood does not typically present with the chorea-like movements. It initially has those bradykinesia. So the most appropriate answer here is going to be syndendum chorea. Okay, so moving to the next video. Look at this child. Child is looking into the mirror. playing with their own reflection, smiling at it, right? This is what is happening. Can you appreciate? Right? So the question here is, they're asking at which age the child enjoys looking at the mirror, smiles, and try to reach their own reflection without yet realizing that it is themselves. Essentially, the examiner is trying to test whether you know when does mirror play comes. Mirror play. So when does mirror play comes? Yes, Vishal, you are right. Mirror play comes at 6 months of age, option A. 6 months of age, right? So very typical milestones, a very frequently tested one. This is mirror play. Moving to the next question. Look at this scenario. What is happening over here? Look at this animation. What is happening? So mother denied the mobile phone. He turned blue, right? So this happened. So what is this? What is this? Child was asking for mobile phone. Mother denied giving iPhone. He cried, turned blue, then regained back his consciousness, right? So a 2-year-old boy becomes angry after his mother denies giving him mobile phone, cries vigorously, then suddenly stops breathing and turns blue before losing consciousness for a very brief duration. He turns back normal after a few seconds without any confusion, without any drowsiness, which is of the following is most likely to be associated with this condition: temporal lobe epilepsy, GERD, long QT syndrome, iron deficiency anemia. Yes. So what was this condition in the first place? Yes, this was a breath holding spell, a cyanotic breath holding spell, right? It is a reflex event. It is not a temper tantrum of some thought. This is a reflex event after frustration, anger, prolonged crying. The child immature reflex system. What it does, there will be apnea after a prolonged expiration. That's why the child turns blue, faints. There is an exaggerated vagal response. And as soon as the child loses the consciousness, the respiratory system takes over. He comes, breathing starts again. He turns back normal. There is no post-ictal phase over here. So this is nothing but cyanotic breath holding spell, and it is very closely associated with iron deficiency. So iron deficiency anemia is the correct answer over here. Hitesh is right. Jishan is again right. So let's look at the other options here also. So temporal lobe epilepsy. Temporal lobe epilepsy can present in this way, but in epilepsy, remember, whenever true seizures are happening, there is going to be a post-ictal phase. And often seizures do not have this emotional trigger, right? So no trigger in cases of epilepsy, and there is often a post-ictal phase, which we do not see in this question. Then comes GERD. In GERD, what do you see? In GERD, we see something known as Sandifer syndrome, where the child will be having this opisthotonous posturing, and again, there is a trigger, that is food intake, not mentioned in this question. Long QT syndrome sometimes presents with brief lapse of consciousness, right? More goes in the favor of absent seizure-like situation, and also sometimes in this situation, if you are worried about long QT syndrome, there is a family history, then we go for ECG, right? But that is reserved for some cases where there is some family history or you have a suspicion per se of this long QT syndrome. The most appropriate answer here is going to be iron deficiency anemia, right? So let's discuss something more about this breath holding spell. I told you it is a reflex event due to immature autonomic nervous system, exaggerated vagal responses there. The age group in which you see is 6 months to 5 years of age. Slowly the child, as the child grows, no longer these breath holding spells are going to happen. What happens over here? In cry, frustration, pain, the child will hold the breath in full expiration and either turn blue, that is a cyanotic breath holding spell, or pale, that is a pallid breath holding spell. Just reassure the parents about this condition, that this is a developmental condition, behavioral disorder, developmental behavior thing. It will sooner or later the child will outgrow this. Just at this point of time, you have to counsel the parents that whenever this such episode happens, make the child lie down on a flat surface where there is no harmful thing around, right, and a safe flat surface. Do not lift the child up or shake the baby during this episode, because lifting the child up can actually further decrease the blood flow to the brain. And also do not shake or start giving CPR to this child, right? Just turn the baby sideways, so as to not let the baby aspirate something if there is anything in the mouth. Differential diagnosis definitely are seizures, cardiac arrhythmias, long QT syndrome. Whenever you have a suspicion for that, you can go ahead with evaluation. With iron deficiency anemia, apart from breath holding spell, you have to remember 3 more conditions. First is pica. Second is restless leg syndrome. Third is temper tantrums, right? So these are the clinical associations with iron deficiency anemia. Whenever you encounter any of these conditions or the examiner tries to test you the associations with iron deficiency anemia, you should remember these 4 conditions: pica, restless leg syndrome, temper tantrums, and breath holding spells, right? So now let's see the next video. Can you notice how the nursing staff is feeding the baby right now? With a spoon, a steel spoon, a spouted steel spoon, the traditional pallidi, right? This is pallidi feeding. So let's see what the examiner is trying to ask from this video. So examiner has given you a clinical scenario that a preterm male infant who is born at 30 weeks of gestation is now on day 10 in life in NICU. He has been receiving gavage feeding, that means OG feeding or NG feeding, and is tolerated full volumes. His current weight is 1.35 kg. On examination today, he shows stable vitals, good spontaneous activity, has begun exhibiting coordinated rooting and sucking behaviors during care circles. The clinical team wants to transition him to oral feeds using a traditional pallidi as shown in the video. Now they are asking, what is the absolute minimum gestation age or post-menstrual age the infant should typically reach before safely initiating the pallidi feeding, and why? Right? So they are asking 2 things. When usually we start giving pallidi feeds, and second, why do we start at that particular point? So option A says that we give at 30 weeks because the pallidi bypasses the need for sucking reflex by then. Option B says 32 weeks because sucking and swallowing coordination mature at this time. 34 weeks because the protective cuff reflex is absent prior to this age. And lastly, 36 weeks because a pallidi requires active coordinated lip seals like breastfeeding. What do you think is the correct answer over here? What do you think is the correct answer over here? The pallidi feeding. When do you transition? What all maturation, neuromuscular maturation should be there to start this feeding? So Hitesh is saying A, that 30 weeks. Shweta is saying C, 34 weeks. Hitesh is again confused between A and B. Shubham is saying C. So let's revise the concepts, the modes of nutrition. So when the child is very small, less than 28 weeks, what happens? The gut is not mature. So gut motility is absent. So you cannot give anything into the gut. I cannot give enteral nutrition. I have to give parenteral nutrition through IV line, right? So we give total parenteral nutrition before that. In between 28 to 31 weeks, what happens? The gut motility now starts. Also, the reflexes that you need for proper feeding, rooting, sucking, swallowing, they are absent. But gut motility has been fine now. Gut motility, gut maturity is achieved. So what can I do? I can place either an NG tube or an OG tube and directly transfer the milk into my gut, right? At 32 to 34 weeks, now the reflexes, rooting reflex, swallowing reflex, sucking reflex, they all appear. So I can start giving katori spoon feeding. After 34 weeks, a proper coordination and maturation of this reflexes happen. So I can directly start breastfeeding. So the correct answer is nothing but option B, that 32 weeks, because the sucking, swallowing reflex are now there. So remember, Hitesh, you read it today only, but you forgot. It's very easy. Remember these blocks: less than 28, 28 to 31, 32 to 34, and after 34, right? These blocks you should remember. Initially, we give total parenteral, then you start to OGNG feeding, then you give Pathology, and lastly, you start with breastfeeding, right? So these are the approximate gestational age. According to the maturity of the baby, we can transition. Like in this scenario, they have given you a 30-week child. This child is not yet 32 weeks. He is day 10 of life, right? Not yet 32 weeks. He is somewhat around 31 weeks and 3 days. But because he is showing us good activity, spontaneous activity, rooting, sucking behavior, so in this case we can try giving Pathology feeds, right? So these are the minimum gestation age by which this maturity comes, but depending upon the child, in practical scenarios we transition early if the child is showing good activity, showing these coordinated rooting, sucking behaviors, right? So this is about your Pathology feeding. Let's move to this next situation. Can you notice how this mother is holding this baby? Right? Can you notice how the mother is holding this baby? What is this? How is the mother caring for this baby? Is there a specific name to this care? Anyone? So the mother has a baby over her chest, skin to skin contact, and she has wrapped her gown over the baby. This is nothing but kangaroo mother care. Kangaroo mother care. Right? Shubham is right. This is kangaroo mother care. So let's look at the question, what the examiner is trying to ask us. So we have a low birth weight infant who was born at 33 weeks of gestation, weighing 1.6 kgs. That means it was a low birth weight baby. This child is admitted to a level 2 special newborn care unit. The baby is stable on room air, no respiratory distress is there. The pediatric resident is counseling the mother regarding the initiation of KMC. Which of the following instructions provided by the resident is completely accurate according to standard WHO and national guidelines? Option A, KMC should only be provided by the biological mother to prevent cross-contamination. Is that true or false? This is false. Anyone can give this KMC, right? Father can also give, grandmother can also give. Just the mother is not the correct statement. Moving to the second option, to be effective, each session must last for a minimum interrupted duration of 1 hour. This is true. Minimum duration 1 hour, maximum can be any much, right? Throughout the day also mother can stay like that with the baby. So minimum uninterrupted 1 hour. Correct. Option C says KMC can be safely discontinued as the infant reaches a chronological age of 28 days, which is actually a false statement. KMC can be continued as long as the baby is comfortable in that position. Once the baby denies that position, then at that time it can be discontinued, right? So you allow KMC as long as the baby wants KMC. So this is again a false statement. Option D, during KMC, the baby should be kept fully clothed with front opening sweater to retain the body heat. This is again a wrong statement. Wrong statement. Baby should not be fully clothed. The baby's front zip should be open, front opening sweater. There should be skin to skin contact. You can keep a cap over the head. But fully clothed baby, not a correct guideline. So the correct answer here is option B. Hitesh is right, option B. Right? So let's move to the next question. What is happening over here? They're giving breaths through the ambu bag. Breaths through the ambu bag, right? So the examiner is giving you this scenario. A term male neonate is born via emergency lower LSCS, lower segment cesarean section for fetal distress. At birth, the baby is apneic and limp. Initial steps of resuscitation, that is drying, warming, positioning, suctioning, are performed. At 60 seconds of life, the heart rate is 78 beats per minute and the infant remains apneic. Which of the following represents the most immediate action, including the correct ventilation rate and pressure using an ambo bag? Right, so a lot of things the examiner has given you and the correct things the examiner has given us, right? So they told us that at birth the child was not breathing, the child was limp, so you started with initial steps of resuscitation, and now 1 minute has happened. We all know 1 minute is important. It is a golden 1 minute. Within this, if positive pressure ventilation should be started. So they have given us that the child after initial steps is still apneic, heart rate is less than 100 at 78 beats per minute. So we have to start positive pressure ventilation using this ambu bag. So let's see how we can give this ambu bag. Initially, we focus on just ventilation. For good whole 30 seconds of effective positive pressure ventilation, you have to give this, right? So let's start. The first option says start chest compressions immediately, which is a wrong statement, false statement. Firstly, you give effective positive pressure ventilation. If despite that the heart rate is less than 60, then we go for chest compressions. Second option says that initiate positive pressure ventilation at a rate of 40 to 60 breaths per minute, aiming for a peak initial positive inspiratory pressure 20 to 25 centimeters of water, which is a true statement. Third says initiate PPV at a rate of 80 to 100 breaths per minute, which is false. The target is 40 to 60 breaths. And the last option says administer free flow oxygen via face mask held closely to the baby's face for 30 seconds, which is not recommended. We start with positive pressure ventilation. So the correct answer here is option B. Everyone over here is right. The Pali is right. Jack Rose is right. This is option B. Initiate positive pressure ventilation 40 to 60 breaths per minute, aiming for PIP 20 to 25, right? So with that, we cover the 10 questions. Now I'm going to show you some of the videos from my end which are important for your exam, right? So firstly, look at this. In this video, I'm going to show you 3 kids. This is something that we have discussed earlier also. So look at this first child, baby A. Very happy looking at the father. He gets very excited and do something like this, as if a shivering movement, right? A shivering, a tightening movement, as if someone has dropped cold water on his back. What is this? Is this normal or abnormal? Do you find this a normal thing or abnormal thing? This was a normal thing. This was shuddering spells. This was a normal thing, right? So this is a normal thing. This is shuddering spells, right? So this is a developmental variation. You don't need to worry about this. This is shuddering spells. If the child's development seems normal and out of excitement, the child is doing like this, this is shuddering spell, which is normal. Now look at this child B. Child B. Observe this child closely. What was that? Infantile spasm. And look here, this is the child of West syndrome. Here, infantile spasm happen in clusters. Can you notice back to back this is happening? Back to back this is happening. This is a 2-minute long video, and this entire 2 minutes the child is doing this cluster infantile spasms only. So whenever infantile spasms are present in clusters, this is nothing but West syndrome. West syndrome. Right? West syndrome. Right? So with that, now the last video, that is movement disorders. So movement disorders, whenever we are talking about movement disorder, you should know how to precisely define the abnormal movements. And once you know how to define abnormal movement, you will easily pick up what this movement is, right? So let's start with the very first movement, that is ethetosis. What are ethetosis? Ethetosis is slow distal writhing movements. Look at this child doing like this, right? So usually if you see a distal movement and it is a very slow writhing movement, this is ethetosis. Right? This is ethetosis. So this child has ethetosis with us. Right? This is ethetosis. Then you have chorea. What is chorea? Chorea is an involuntary semi-purposeful movements. So these are dance-like movement, very unpredictable, large joint movement, proximal movement, right? Flowing as if it movement is transferring from one limb to the other, very unpredictable. right? And sometimes, because these are unpredictable movements, child try to make purpose of that movement. So for example, if there is a jerk like this, child will try to comb his hair like that, right, to make it into some purpose, semi-purposeful movement. So it can involve both upper limb and lower limb. Moving to tics. Tics are just sudden, abrupt, repetitive movements. They can be vocal tics or they can be motor tics. You can notice over here, these are motor tics. The child is going like that. And sometimes you have vocal tics also. In vocal tics, the child will produce some sounds or some slangs the child could come out of with. The important point in tics is there is a premonitory urge. That means the child will feel an urge to do that tick, right? And these are suppressible also. These movements are, these tics are suppressible also. These are repetitive pattern movements. Every time they will be happening with the same pattern. Then you have myoclonus. Whenever you hear the word myoclonus, remember shock-like contractions, as if the child has started shock-like contractions. It could be a positive myoclonus, negative myoclonus. Positive means you will actually appreciate a movement, abnormal movement. Negative means whatever the child is doing, that gets halted for some time. So this is myoclonus, right? So if it is elicited by sensory stimulus, it is known as reflex myoclonus. If by action, it is known as action myoclonus. Then you have stereotypies. We have discussed the stereotypies in Rett syndrome. Similar stereotypies is seen in children with autism spectrum disorder also. They do these ringing movements or something like that, right? Again, exacerbated with excitement, stress, or fatigue. This is nothing but stereotypies. Okay, so I know these you have thoroughly discussed in medicine, but from pediatrics point of view, what are the key pointers that you need to know? That I have discussed, right? So remember, stereotypies usually in autism and Rett syndrome you see. Now, what are dystonia? Dystonia are abnormal twisting movement. There is a sustained muscle contraction. The child will be like twisting the posture somewhat like that, right? It could be in the upper limb, in the lower limb, and here you see sensory tricks or vestiges. What happens in sensory tricks? If you stimulate some other portion of the body, this can be relieved. This dystonia can be relieved, right? So these are dystonia movement. There is simultaneous contraction of the antagonist and agonist muscles. A twisting movement, a random twisting movement are there, right? So this is dystonia. Then you have tremors. These are rhythmic oscillatory movement around a fixed point or plane. So these can be action tremors. While doing some action, there could be rest tremors, as you see in Parkinson's. There could be intention tremors, which is considered a part of your action tremor only. Once you reach the object, it starts tremor. Balismus are high voltitude large joint movements. They can be they usually occur proximally, so a shoulder movement like that, or a movement of the leg as happening in this video. So there are these large joint flinging movements. Balismus is very rare in pediatric population per se. More common movements are choreoorthotic movements. So this is all about the different movement disorders that we appreciate. So thank you everyone. I hope this video based session helped you to come up to have an idea as to how the examiner can present to you in the exam, right? So expect definitely a longer clinical stem, multiple videos like these. Some of the videos here were animation, some of there were real patient videos. I believe both can happen in the exam. Most likely they are going to throw in real patients, but if you have seen the animation, I know you can pick up that in the real life scenario too. So any doubt regarding any of the questions so far? If there are any, please drop that down in the comment section and I'll be more than happy to cover that.